Yes.
Hello. Please keep your mobile on silent mode. Good morning, everyone. It is said that be joyful and happy. That is the best way you can view for yourself and everybody around you. So, wishing you all a belated happy Diwali with full of joy, happiness and well-being. I, Dr Janvi Khavle, proud to be the Public Secretary for the second consecutive year of the biggest regional association of more than 1,500 medical professionals in Mumbai. I wholeheartedly welcome this great gathering of mini conference of Mdmpa, that is minicon 2023. I follow in the lines of the remarkable leaders of this association and I resolve to build up the legacy. The minicon 2023 of Mdmpa not only allows us to meet, greet and eat to stand for national anthem.
शुरू हो जाए
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 जय
बोलो भारत माता की
जय हिंद, भारत माता की जय।
जय महाराष्ट्र
Thank you.
जय महाराष्ट्र
As we have been continuously receiving response from our well-wishers, speakers and valuable MDMP members, we are again pleased to organize this knowledgeable activity, that is minicon 2023. This event will always be remembered as an achievement for us due to our dedicated teamwork of all our committee members. We have been successful in raising the benchmark, which has been elevating year on year. As you are aware, MDMP always exceeds expectation all the time. Friends, now I welcome you all for the inaugural function of today's event. As we begin with today's event, I request our President, Dr. Sandeep Singh, to escort our honorable guest, Dr. Nikesh Jain sir, on the dais. Now, I would request our immediate past President, Dr. Amit Patil, to escort our honorable guest, Dr. Lotika Purohit, Madam, on the dais. Friends, now I have pleasure calling our honorary treasurer forever, Dr. Praveen Gujarati sir, on the dais. Now, I would like to call upon the young dynamic Vice President Scientific, Dr. Vijay Jain. I would like to invite Vice President Cultural, Dr. Vijay Panikar. I would like to call upon a very quiet but quick and hard-working Vice President Camp, Dr. Naseem Khan. I would like to invite our energetic, enthusiastic editor, Dr. Kiran Awari. Now, I would like to call upon our strong pillar of Mdmpa, everyone's favorite scientific coordinator, Dr. Rajesh Kovil sir. Now, I would like to call upon our scientific coordinator, the most disciplined, well-known diabetologist who has received national and international award, our Dr. Kale sir. I would like to invite our one more scientific coordinator, always ready to help, Dr. Chandrasekhar Taure sir. Friends, it is said that if you light a lamp for someone else, it will brighten up your path also. Light is a symbol of knowledge, happiness and prosperity. Now, I would like to invite our most humble and admirable President, Dr. Sandeep Singh, and all the dignitaries on the dais and all the senior members of our committee to lit the lamp. Please.
मैं फोटो लेता हूँ, आप चलो। आप तो भी थोड़ी चलने वाला
Thank you, all the dignitaries. Please take your respective seats in the audience. Now, I would like to call our dynamic, hard-working Vice President Scientific for the 4th consecutive year, Dr. Vinod Jain sir, to have a word. Please.
Thank you, Secretary Ma'am, for your kind words. Yeah, good morning, one and all. So, respected speakers, managing committee members on the dais and off the dais, and dear friends. I welcome you all for minicon and glad to see you in such a large number, a huge number on Sunday morning. Friends, last time we have, this time we have all eminent speakers for you under the leadership of our President Dr. Sandeep Singh and our organizing chairperson Dr. Rajiv Kovil and team Mdmpa. Dr. Sunil sir has taken a great initiative to bring all dignitaries under one roof. जैसे मैडम ने बोला, he is very disciplined person. वो सच में disciplined है. लास्ट 1 महीने से उन्होंने जितने मुझे फोन किए होंगे उतने फोन मुझे मेरी बीवी ने नहीं किए होंगे. Regarding this conference, such a great personality, like he is like, you know, ये काम हुआ, ये सारा proper में चलना चाहिए और सारी चीजें टाइम पे होनी चाहिए, everything is like thank you sir. Let's I usually see on there.
नेटवर्क स्टेबल नहीं है, इंटरनेट बराबर नहीं है. ठीक है, चलेगा जो भी है.
भाई हमारा भाई है.
Today's heroes of the show, our Rishi Kapoor of Mdmpa, Vice President Cultural, Dr. Vijay Panikar, please come up. Our senior, most jovial personality, whose motto of life is only hungry for knowledge. Please welcome Dr. Milind Toroskar sir. Over to you.
Yes.
Namaste, good morning, adab, sat sri akal. Hello everyone. Thank you so much everyone
to be on time on this romantic Sunday morning to hear us.
But Vijay, are you sure they're all present here to hear us?
No sir, no, not at all. I am sure they are waiting for one of the best lecturers, not only in town, but also at the world-class level.
Then why you are waiting for? Let's start the show.
Yes sir. First of all, I request our chairpersons, handsome hunk of Mdmpa and our VP Scientific, Dr Vijay Jain sir, and emerging physiotherapist who is well known for her work, Dr Prarthana Pujari, to come on the stage and chair the session. Our speaker is a well-known cardiologist and he is one of the youngest cardiologists in Mumbai, Dr Nikesh Jain, and his topic is diagnostic modalities in cardiovascular disease. Sir, please come on the stage.
Also the youngest actor in the industry.
भाई मेरे मत देख तू सपने बिछड़ जाएंगे तेरे अपने.
अगर चाहता है लंबी जिंदगी और दिल में चैन, you have to consult Dr Nikesh Jain. Now I request our chairperson to introduce our respected speaker, Dr Nikesh Jain.
Good morning, everyone. So our first speaker for today is Dr. Nikesh Jain. Sir is a consultant cardiologist. He is DNB Medicine, DNB Cardiology, FESC, FSCAI Fellow. He has passed his MBBS from MUHS, completed his DNB Medicine and DNB Cardiology from Jaslok Hospital and Research Center, Mumbai. He is attached to Wockhardt Hospital, Mumbai Central, Jaslok Hospital and Research Center, Sethi Hospital, SL Hareja Hospital, Masina Hospital, KJ Somaya Super Speciality Hospital, Science, and Sudana Hospital. His publications include PJ Mehta's Practical Medicine for Students and Practitioners, 20th edition. Contributed to PJ Mehta's Emergencies in Medical Practice, 6th edition. Contributed to RSSDI textbook of diabetes mellitus, 3rd edition. He has also contributed for many medical textbooks, handbooks, and articles. So his special interests include complex coronary interventions, structural heart disease interventions, heart failure, and heart transplant workup. Over to you, sir.
So good morning everyone. This is my first association with Mdmpa and very glad to be associated with it, and very happy to see on a Sunday morning which is full house and starting right on time. So without wasting much time, I'll start with my topic, which is diagnostic modalities in cardiovascular disease. Since it's my first association, I know there are multiple talks on advances in cardiology, updates in cardiology, but people, we forget that the most important thing is the basics that we should not forget. So that is why this is just a gist of cardiology evaluation and some points regarding basics that should be useful for your practice as well. So basically, whenever a patient comes with any cardiac complaint, chest pain, breathlessness, we have all this gamut of investigation that we can run, right from routine blood test, lipid biomarkers and everything, to ECG, 2D echo, I5 test called as MPI scan, cardiac MRI, and to invasive tests as angiography and everything. But can anyone tell me what is missing in this? Drop please here, down. History. Okay. So most important thing is history. that we often forget to have in detailed evaluation with the patient. Some 8 to 10 pointers about the history, and you will come to a diagnosis, and you can come to a clinical diagnosis of just 2 or 3 differential diagnoses. Rather than running all the gamut of investigations and multiple referrals, the simple history will point you towards a diagnosis of the patient also, that your clinical knowledge is quite good. That has been taught to us in MBBS days, in our undergraduate days. So first step is recognize the cluster of signs and symptoms, place patients in diagnostic categories, which system does the category falls in, okay, and related to the system also, whether it's cardiovascular or respiratory, what 2 or 3 differences can you come across? Symptoms and signs that will give rise to pre-test probability. So what investigations that you have to dictate, it depends on the symptoms and signs that you get on clinical examination in the history. And then only you can advise some diagnostic cell to come to a diagnosis, just to support the diagnosis and more have a convincing impact on the patient also. So coming to the history, this is a simple example of one of my friends, typical young, currently what scenarios that we are looking at. 37 years old male, recently diagnosed diabetes, dyslipidemia, stressful lifestyle, intermittent smoking, working at late nights around 2 or 3 o'clock. He was having pain since afternoon, typical retrosternal heaviness, which he ignored, continued his work, and by till 2 o'clock at night also the pain was still intermittently increasing. He did his first ECG at 10 o'clock as advised by a doctor, which was normal. Tropi was normal, so he again went back to his work and started his accounts. He again called me at 3 o'clock at night and saying that that heaviness, the retrosternal heaviness is still persistent. Tropi, the first tropi was normal, the second tropi was also normal, this was the next day tropi morning. Okay, I still got him admitted at 3 o'clock because the symptoms are classical. I started him on antiplatelets, heparin, everything. Tropi next day was just high normal, but still it was on the increasing trend. ECG was still non-significant. Based just on history, I took him for angiography without wasting much time. So this is a typical substrate, what we call as you can see in the LED, there is a marker which comes. LED, there is a haziness. There you can see there is a dye staining. The dye is flowing very slowly to the bottom of the artery. Okay. So there is a typical substrate of a young MI who has just 30 to 40% block, but what happens is the plaque ruptures. Okay, and there is a thrombus formation. Okay, this is a typical substrate of a young MI which there is a plaque rupture, there is a thrombus formation, there is sudden MI with sudden cardiac death. Okay, if the patient would have been ignored without starting any antiplatelets or heparin, then he would have got a sudden MI and mostly a sudden cardiac arrest also. So history is most important. If you feel the history is convincing, then don't waste much time, get the patient admitted and don't waste time for stress test or repeat ECG or discharge the patient. This is very important. So basically what does a cardiac chest pain looks like? Okay, so basically the duration is just 2 to 5 minutes. Typical location is precordial, substernal and diffuse. Radiation to the left arm, right arm, ulnar respect, arm, forearm, neck, anything that can happen. Typical character is important, squeezing, choking, pressing or tightness. Typical exerting factors like exertion or emotion, and it will be typically related with sorbitrate, nitrates, and it may be associated with palpitation, shortness of breath. So that is why history is important. Non-cardiac chest pain, less than 20 seconds, lasting for minutes, hours or days. More peripheral, epigastric or lower limb pain, right shoulder pain, left shoulder pain. Sharp shooting pain, that is non-cardiac, not related to exertion or any exertional factors, that is also non-cardiac pain. Okay, so depending on this clinical history characteristics itself, you can classically describe whether it's an angina or a non-anginal pain. If it's an anginal pain, I don't waste time in stress test or any CT coronary angiography. I directly advise the patient of angiography as well. So typically what the textbook describes is, angina pain can happen anywhere from neck to the epigastric region. As you all know, some people have come with dyspeptic symptoms and they have landed up with MI. Jaw pain, choking sensation in the throat, that is also angina pain. So what we call as angina equivalence. So not all the patients will have classical heaviness or chest pain while exertion. Sometimes they will just describe shortness of breath on exertion, fatigue on exertion, okay, discomfort in the secondary radiation site like shoulders, ulnar aspect of the arm, forearm, lower jaw and the neck. Angina equivalence, as I showed in the diagram, it is uncommon above the mandible and below the epigastric region. Postprandial angina, patient typically have anginal symptoms after food. That is also a classical symptom. Nocturnal angina is angina at night, chest pain or heaviness at night. That is, both these symptoms are mostly a marker of triple vessel disease or left main or LED. Walk through angina. So this is an important symptom. What happens is the patient who starts walking, he feels some heaviness, he takes some rest, but after that when he walks, there is no angina. That is called as walk-through angina. It is washed out by the metabolites. That is a phenomenon which has been described. But that is also a classical angina. Don't ignore that the patient doesn't have any symptoms. Okay. Warm-up phenomenon is similar to that walk-through angina. Initial patient will have symptoms, but after that the patient can walk throughout. But don't ignore this symptom as well. Microvascular angina is an important syndrome nowadays because of unhealthy lifestyle, obesity, sedentary lifestyle, diabetics. It is more common in women also. Basically what happens is the microvasculature. What we see on angiography is only the 5% of the coronary circulation. But the microvasculature, which combines almost to 90 to 95%, we cannot assess on angiography. So this, what we call as endothelial dysfunction, what we call as obesity syndrome and all the syndrome which has happened, syndrome X. So the microvasculature is affected. There is impaired blood flow to the coronaries at the microvasculature level. Symptoms are classical of angina. When the patients do angiography, it will be completely normal or will show some slow flow. That is classical of microvascular angina. The problem with this is it is difficult to treat with nitrates and nicoran. Only way to prove is angiography. Sometimes test may or may not be positive, but patient will still have classical symptoms. Only way to happen is lifestyle changes and counseling. So this is a typical cardiac evaluation patient from a cardiac point of view. Whenever there is a patient with chest pain, evaluate whether the patient lands into emergency category or non-emergency category. BP, vitals, everything should be fine to warrant patient to subject to casualty or just to manage an OPD care. If the patient is hemodynamically stable, first step is to do an ECG, which can be done in your clinic. I think most of you are doing it in the clinic nowadays, but it's available in any nearby nursing home as well. ECG should be done within 5 to 10 minutes of the patient presentation. ECG is not showing any STEMI pattern. Yes, then the patient can be managed on OPD basis unless the patient's symptoms are classical of angina, recent onset or recent worsening of symptoms. So that should be taken care of. If the patient is showing ST elevation, then the patient should be subjected to emergency angioplasty, okay, or at least a thrombolysis if the angioplasty is not feasible. So coming to this drop I will just on each modality I'll just give you a gist of points that can help in your practice because detailed talk can happen for a couple of hours together. Role of recommended enzyme is drop I. Okay, not even CKMB, which has a lot of false positives and negatives. Drop I takes time to come positive, 6 hours to 12 hours. So if the patient is presenting within 6 hours, the first drop I will be normal. But if the history, come back to the history with my first slide. If the history is classical, don't discharge the patient, make the patient wait in casualty, repeat ECG after 6 to 12 hours and repeat drop I after 6 to 12 hours. Many of the times you will find that the drop I or ECG are showing changes. Okay, this is an important point about drop I. Right. Once the drop I is elevated, it will take time to come down. It takes at least 7 to 10 days. Okay, so definitely if the patient has some evolved MI and if you find that the drop I is positive, it means the event has happened in the last 1 to 2 weeks. So that is an important marker. And if the drop I is negative, it means the MI has happened beyond 2 weeks or 3 weeks period. So that is how you can clinically judge the time of the event also. Coming to the ECG, this is a normal pattern of ECG, P, QRST. You should be well versed with all the intervals, all the ST segment, what are the definitions and everything. I won't go give you into all the examples of ECG patterns, but with ECG, simple ECG, you can come to conclusion of lot of things regarding whether the patient has ischemia, LVH, stress-induced cardiomyopathy, drug or electrolyte disturbances. So all these changes can happen can contribute to ECG changes. So don't correlate ECG changes with only MI. Okay? Whenever a patient comes with some ECG changes, always compare with the last one. Okay? Sometimes what happens is patient is LVH. So he will have repolarization changes, STD changes from before. So no need to panic if the patient has atypical angina. Okay, many female patients, diabetic patients, they have non-specific T inversion. So if the T inversions are old, nothing to be panic about. So you can just compare with the old ECG. Many patients have RBBB and LBBB, previous one. Okay, so if the patient pattern is old, nothing to be worried about. But be worried about LBBB. New onset LBBB is also an acute MI. If the patient presents with classical angina, new onset LBBB, definitely it's an acute MI and warrants emergency angioplasty. Not even daycare admission or ICU admission, routine admission. So this is basically a pattern of what we call as early repolation pattern. In this, there is an ST elevation, okay, but it's ST going upwards, okay. It's called the concavity is upwards. If you see in leads 2-3 AVF, there is a typical patient presenting with young age, presenting with a typical angina. So you should not be worried about this ST elevation pattern as shown in this ECG. Whereas in this ECG, you can see there are different patterns which are shown. ST coving upwards, flattening upwards, or like a doming pattern. So this is a typical STEMI pattern. So if the ECG is showing concavity upward, that is that ECG is smiling at you, the ST segment, you should not be worried about it. It is just an early repolation pattern. This is the different characteristics of ST elevation pattern: convex upwards, upsloping, horizontal or downsloping. Concavity upwards is not an MI. There are many references for this concavity upwards, ST elevation pattern upwards, but these are a common pattern in young athletes and individuals or young patients. Reciprocal changes: if the patient has ST elevation in anterior leads, he will have reciprocal changes in inferior leads. So that is a common pattern. We should not be worried about that. It's an end STEMI. It will support the diagnosis of STEMI, but don't mistake it for an end STEMI patient and just manage on heparin. There is a typical patient of end STEMI. So in STEMI, patient has ST elevation, but in end STEMI, non-ST elevation myocardial infarction, patient has ST depression, T inversion. This requires ICU admission with management with emergent heparin and nitrates, because these patients can convert to STEMI with any span of time. So this also requires urgent admission. So there are all the T waves patterns. So not all T waves are ischemic. Okay, post ischemic T inversion are usually deep and symmetric. T wave inversion can be associated with any stroke also, cerebral bleed also, LVH also, and can be very non-specific also, just as a normal pattern of variant for that individual. Okay, so always correlate with symptoms and see the pattern of T inversion. Isolated T inversion here and there are absolutely non-significant. It has to be in contiguous leads. If it's inferior, so it should be in 2-3 AVF. If it's lateral, so 1 AVL, V5, V6. Then only it can account to ischemia. Isolated T inversion in lead 3, lead 1, V2 doesn't matter. So ECG can be normal at initial presentation, always correlate with history. As I told you, repeat ECG after 6 to 12 hours if the symptoms are classical or persistent. LCX lesions are notorious, they will have normal ECG in presentation. If you want, you can use leads V7 to V9. They may show changes for LCX pattern. These are just LVH and RVH patterns, I won't go into the details. X-ray is important from cardiological perspective from 2 or 3 findings. Valvular heart disease, pericardial effusion, cardiomegaly. Okay, so there are certain, we should remember these landmarks: main pulmonary artery, left atrial appendage, left ventricle, and we can correlate the borders of these findings. Okay, though it has limited value, but in some cases it can pick up very nice findings, like for mitral stenosis, there will be straightening of this left heart border. There are multiple findings which can happen. But if you remember the normal pattern, the normal boundaries, then you can pick up the abnormal findings. Coming to 2D echography, I know it is done most commonly now, every center, every diagnostic center has it, but the parameters that we look at from the cardiologist perspective is sometimes different when a normal sonographer or a normal diagnostic center does it. Most of the machines are not dedicated cardiac machines as well, so they miss some of the important parameters. Your software is not tuned to have details and to have detailed gradients across all this. We have many patients who have missed regional walls, who have missed severe aortic stenosis because the software was not tuned. Whenever we do a 2D echo, we should look at all these parameters: regional wall, EF, diastolic function, because heart failure with preserved ejection fraction they will have symptoms of heart failure, breathlessness, edema, feet. EF will be normal or near normal, okay? But we have looked all these parameters like PA pressure, EBA, EPAM values. So if these are also positive, then it fits into heart failure with preserved ejection fraction. So we have to look at all these parameters. Valvular anatomy, stenosis, regurgitation, PA pressure, RV function is often missed when we do it, when we find all the reports. Clots, vegetation, pericardial, it's all operator dependent. So always get an echo up at a good cardiologist. Okay, look at all these findings. Look for yourself. What are you looking for in all these reports? And then you can ask questions. What is missing in this report?
Sponsors का चाहिए क्या chairperson?
So this was the patient with acute MI, 2 weeks anterior wall MI. You can see the blood flow which is going from left heart to the right heart. So this patient was complicated by a ventricular subtle rupture. This patient though came walking, but it was a time bomb patient. He could have collapsed any time. Luckily he was survived for 2 weeks also. I immediately got him admitted and got a ventricular septal repair with CABG done. He had a primary angioplasty done, but he had the septal rupture because the walls become thin, and this is a dreaded complication of post-MI. Coming to stress test. This is the next basic evaluation. Whenever you feel that the patient is having non-typical angina, okay, angina is not classical, not so much risk factors, head in healthy, you can do what we call as different types of stress tests. Exercise treadmill stress test is the most common which is advised. Other types of stress tests are dobutamine, which is done by an echo-guided test, and a myocardial perfusion scan, which is a nuclear-based stress test. Exercise stress treadmill stress test is underrated, underutilized, and not adequately performed in many of the centers. There are specific criteria. We should compare with old ECG. There are few ECG patterns. If there are baseline ECGs like LBV, RBV, ideally we should not advise stress test. Monitoring is done of heart rate, blood pressure during the ECG with continuous ECG recording. Contraindications are if the patient has recent chest pain, don't advise a stress test. Wait for 48 to 72 hours. Okay. Even if the patient has classical angina, don't advise a stress test. Ideally, I avoid it. Aortic dissection, arrhythmias, if the patient has atrial fibrillation, avoid it. Severe valvular heart disease like aortic stenosis or recent myocarditis patient, we should not do it. So what does it do? It evaluates symptoms, it evaluates ST depression or ischemic changes, functional capacity, predicted meds, heart rate, BP product, and evaluation of treatment, whether the BP response is right to the changes that you have done. With exercise, there is an increase in BP, but there should be a limit to that. Okay, so we can respond all these parameters. What people do is just look for ECG changes in 3-4 minutes and they stop the test. I try to stretch the patient to their maximum heart rate of at least 90-95%. Look for the BP response. It helps in counseling the patient also, like how much exercises are you doing and how much is the capacity of yours, exercise capacity, your response to exercise capacity, your heart rate dropping after recovery period. So that is also important to counsel the patient. Dobutamine stress test, patients were not able to walk on treadmill. Dobutamine is a simple non-invasive test that can be performed. We do a TODI echo simultaneously. There is an infusion of dobutamine, okay, and we assess for regional wall as well, and we simultaneously monitor ECG as well. That has more sensitivity and specificity than that exercise stress test, but that is also operator dependent, done mostly in hospitals. Myocardial perfusion scan is a special type of stress test, more accurate than dobutamine. Okay, so stress test, dobutamine, next comes the myocardial perfusion scan. In this, we inject a nuclear dye. Heart is imaged like a CT scan twice, before and after the exercise, and it almost gives the blood supply of the heart, whether it is deficient in those specific areas or not. That is more sensitive and specific, but that has also few fallacies. In multi-vessel disease, sometimes it can be fallacious, it can give normal also. No test is accurate or 100% in excluding coronary artery disease, except for angiography. So always correlate with history. This is all ancillary tests to support your diagnosis or to have a convincing power in the patient to have an angiography done. Okay, but these are also very good tests to have a functional capacity of the patient, evaluate for fitness of the patient, okay, and to evaluate for the risk of the patient pre-operatively. So whenever there is a perfusion defect, first it will be picked up in this nuclear perfusion scan. So that is where the importance of this nuclear perfusion scan is. It evaluates at the molecular and the circulation level. This will be the earliest to show the change. Then comes metabolic changes, LV diastolic dysfunction, ECG changes, and then angina. So angina is usually the last symptom. So that is why we evaluate with stress test earlier to have an early detection of coronary artery disease. So this is usually a typical how a report comes. I don't want to go into the details of it. So the sensitivity and specificity, what we call, is almost equal to dobutamine, okay, but stress test is much less than that. Coming to CT coronary angiography. Ideally, in my practice, I usually avoid CT coronary angiography. I do it only in patients whom I know that the angiography will be normal, like young patients with atypical symptoms. Okay, if the patient has classical angina, don't do it, because even if it shows 50 or 60 or 70% blockage, I will have to repeat an angiography. Okay, if the patient is bound to have coronary artery disease, there is no point wasting time, dye and money in this, because anyways I have to do an angiography to prove the blockages. So this has a limited role for coronary artery disease. Only in patients who have normal coronaries, you do it, so that invasive procedure is avoided. Other uses are anatomy of the heart, cardiac masses, valvular pathologies and congenital heart disease. So as I told you, CT, people do it for CT calcium scoring and coronary evaluation. Do it more in younger patients. There are many false positives and false negatives which come and which creates anxiety in the patients. So avoid having a routine evaluation with CT coronary. Do a simple exercise stress test. That will give you enough information. Cardiac MRI, we do it for viability. Okay. Cardiomyopathies, patients who have dilated cardiomyopathies for sarcoidosis, for hemochromatosis causing myocardial issues, for COVID, for COVID involving the heart. So basically for all these myocardial issues, cardiac MRI is more useful than at very few places with very few good interpretation. I usually send patients to Dr. Jankari or in any of the corporate hospitals. But don't do it in a routine diagnostic center who are not tuned to evaluate those images and interpret those images. So basically this is an angiography for a patient who had a borderline lesion. Okay. Stress test was positive, symptoms sometimes having an exertional pain but not having a classical angina pain all the time. Stress test was positive, borderline lesion in LAD and critical lesion in RCA. So that was simple stress test which was positive that triggered me to do an angiography. I did not waste time in doing a CT coronary angiography. But what to do now? Whether to subject an LAD also or only RCA, which is the culprit artery. So what we do is we do an FFR. FFR and IFR is a special wire-based technology in which all these borderline lesions, 70 to 80% or 90% lesion, we do this FFR test, it gives us a value like a blood pressure value. If the value is normal, we don't do a stenting of this artery. So FFR of this LAD was normal. Of this LCX lesion was also normal. So I did only angioplasty of this RCA. My special forte, which is I did a fellowship also recently, is a TAVI. Okay, it's a transcatheter aortic replacement. As you are all aware, there will be multiple talks by all things in the past. But this is a special patient because we did it almost for free. This is a transgender patient. I know it's all ignored in our community. Hypertensive retrovirus disease on ART. So retrovirus disease with the main culprit because many surgeons refused because she had a severe aortic stenosis, symptomatic syncope episodes. So we counseled through social workers and everything. We involved many social workers. They all came in forward for a charity and they almost did it for TAVI for this free patient. We did angioplasty and TAVI both. It's almost 2 years now. Patient is heart and healthy. Except for the sugars, everything is going well fine with the patient. So if there are any questions, I'll be happy to take it.
So no question.
No question.
सुपर लेक्चर सर. मैं इतना ही कहूँगा कि पहले ही बॉल पर आपने मारा 6 सर. And I know you are waiting for the rest. And believe me,
Mdmpa is the best.
Now I request chairpersons to Dr. Vinod Jain and Dr. Pratana Pujari to thank and felicitate Dr. Nikesh Jain.
Now I request our youngest and our hard worker treasurer sir, Dr. Praveen Gujarati and Dr. Priya Singh Naburkar to come on the stage to felicitate the chairpersons.
टाइम वेस्ट मत करो ना
बेकार
प्रिया मैडम प्रिया मैडम को पकड़ना पड़ेगा.
Now I request our next chairpersons, our active and hard-working secretary, Dr. Janvi Khavle, and our lovely Vice President Camp, Dr. Nasim Khan, to come on the stage to chair the next session.
Our next speaker is one of the best diabetologists in the town, Dr. Lotika Purohit, and her topic is the duo with extra glycemic benefits. Ma'am, please come on the stage.
जाने दो, आप अपना काम करो. आप अपना कंटिन्यू करो, लेट इट बी कंटिन्यू करो.
मैं इतना ही मत खाओ इतनी चॉकलेट, लाइम जूस, आइसक्रीम और टॉफियाँ,
वरना शुगर तुम्हारी हो जाएगी हिट एंड यू हैव टू गेट एडमिट अंडर डॉक्टर लोतिका पुरोहित.
Thank you so much for the interesting introduction. And
Thank you, ma'am. Now I request our chairpersons to introduce our respected speaker, Dr. Lotika Purohit.
Thank you, sir. It's my privilege to invite our today's female speaker, Dr. Lotika Purohit, madam. She is the director of Diabetes Care Center in Kolaba, Mumbai. She is visiting diabetologist and diabetes and obesity clinic at JJ Hospital and Grand Government Medical College, Mumbai. She is a partner, Sugar Doctor, Medicare LLP. She is a chair-elect in RSSDI Maharashtra chapter. And I am glad to announce that she is going to be the president of RSSD Maharashtra chapter. Heartiest congratulations to you, madam, from our team Mdmpa.
thank you so much.
She is accredited diabetologist by RSSDI since 25 years. She is a fellowship research society for study of diabetology India, a diplomat of International Board of Lifestyle Medicine. She is the president of Rotary Club of Bombay Midtown, and moreover, she is the member of Women and Diabetes Interest Group Diabetes India. Welcome to you, ma'am.
Thank you so much. I'm really happy to see so many people on a Sunday morning, and this is really nice that you all are interested in hearing about various cardiovascular, diabetes and other problems. So let's start, because I saw the previous introduction was a very romantic, so good. So let's start with the duo which has extra glycemic benefits. We all know that diabetes is a huge burden in India. Particularly, most of you over the last 2 to 3 decades must have seen a huge escalation in the number of people with diabetes that you see. When we were all in medical colleges, diabetes was supposed to be a disease of the elderly people. So I think Satoskar mein there was like maybe half a page on diabetes or so. But in the last 25-30 years, the number of people with diabetes has also increased, and the number of medications for diabetes has also increased. We now have a full chapter in Harrison on diabetes and all the medications that are required, all the pharmacotherapy. So basically the prevalence is about 11.4%. The burden is about 101 million people having diabetes. Has diabetes. This is a serious problem. We also have a dual problem that we convert from IGT to type 2 diabetes very fast as compared to the other populations. The Finnish people, just about 6% conversion is there. In the Chinese, there is just 11.3%. But in Indians, we have 18% rate of conversion from IGT to type 2 diabetes. So this is a real public health problem also. Another thing is that our patients, in spite of all the medications that we have available, the level of control is not good. Only 1 out of 3 patients maintains an HbA1c of 7%. We all know that 7% is the HbA1c target that we need to meet to see to it that they stay away from complications. But 1 out of 3 is only the target that does achieve this. So that is also a concern. Also, we've had that there has been no significant improvement in this target in the last 10 years also, in spite of all the new medication. So what are the challenges that we have? We have early onset type 2 diabetes. Like now we see people in the age group of 20, 25, 15, 18, 30, all coming with elevated blood sugar levels. And these are usually type 2 diabetes, not type 1 diabetes. There is an early decline in the beta cell mass, insulin resistance because of the excess weight. There is higher insulin resistance. Our food is full of carbohydrates. It's much higher carbohydrates than anywhere else. Whether it's the chapatis, the rice, the idlis, dosas, all that is full of carbs. So that is something which is also part of our lives. Then the physical inactivity. In the last 30 years or so, we have seen the increased number of gadgets that have started coming. So there is no exercise which is there. Most people do not even walk maybe 100, 200 meters to probably catch a cab or something. They just take either a cab or two-wheeler. They get down from their houses, get into the two-wheeler and go, or whatever other mode of transport. So basically, the lack of walking is there. Children don't go out to play. There is no place for them to play, or even if there is place, they have gadgets, they have tuitions, they have all these things which are there, which restrict the physical activity. Now we, because of type 2 diabetes, there is so central obesity is there. There is the unique dyslipidemia pattern that we Indians have. Because of this, we have an increased cardiovascular risk. Like you saw the previous speaker who was speaking about cardiovascular risk, and in that case it was not the cardiovasculars. We actually did see what heart attacks are. And another association is NAFLD or MASLD as it's called. Now in diabetes, we know heart failure, CKD are very closely connected. About the most people with diabetes are at 5 times more higher risk than any normal person to have heart failure. 58% of type 2 diabetic people are likely to have CKD. And of course, both of them together is a vicious circle. They also cause and worsen each other. Now, what are the choices we have? We have either we take the staircase, use diet and exercise, give them people some time to follow the diet and exercise, the monotherapy, then gradually add a combination, probably add insulin subsequently, or we have the option of starting aggressively. So now we know that the pathophysiology of diabetes is multifold. We have many different defects which are there in the body. That is, one is the decrease in the insulin secretion by the pancreas, the increase in the glucagon secretion, increase in the hepatic glucose production, decrease in the incretin effect, increase in the lipolysis in the adipocytes, increased glucose resorption by the kidney, decreased glucose uptake by the muscles, and the neurotransmitter dysfunctions. So for all these problems, we have different solutions also. Today we have medications which act on each of these problems. So the combination that we talk about, DPP-4 and SGLT2, they counter about 7 out of 8 of these components, unlike any other therapy that is there. And what do the guidelines say? Our guidelines of ADA says that early combination therapy is something which we can start if the HbA1c is more than 1.5% to 2% above the target. We know that usually the target is about 7%. So if it's if the HbA1c is 8.5 or 9, again the AAC also says that if the HbA1c is above 9% is when you should consider dual therapy. In younger people, because as I said, we're seeing much younger people now, we should consider starting with a combination therapy early. Also, our RSSDI guidelines say that if the HbA1c is more than 1.5% above the target, then we should start with combination therapy. So the need of the hour is we need something to combine, to adopt, to treat all these multiple pathologies that we have. We also want not just the glycemic control, we want the non-glycemic benefits also. Because diabetes is not just the blood sugar level, it is the other comorbidities also which we see. Reducing occurrence of hypoglycemia, because I'm sure you all have seen people with hypoglycemia calling you in the middle of the night or day or anything saying, chakkar aa raha hai, kya karu? We don't know whether it's hypoglycemia, but when you are giving a medication which you know does not cause hypoglycemia, it is much safer. And of course, oral option, nobody wants an injectable preparation to start with. So how do we bridge the gap? Dapagliflozin is an SGLT2 we have been using now for over 10 years. It is quite potent and it lowers the blood sugar levels. This works without the insulin action. It also reduces the risk of CV death and hospitalization for heart failure. It also provides effective glycemic control and does not affect the major adverse cardiac effects, lower risk of hypoglycemia. Besides this, it also reduces the body weight, blood pressure, and progression of renal disease. FDA also has given approval for in patients with eGFR decline. It reduces the cardiovascular death. It has been tested to show that it reduces the hospitalization for heart failure. In an adjunct with diet and exercise, it can be utilized. The mechanism of action, I'm sure you've all seen this before, but a little bit different. There is reduction in the kidney resorption of glucose and sodium, and an increase in the glucose excretion. This causes the reduction in the plasma volume as well as the systolic blood pressure. As an outcome, the eGFR decline is reduced. To the heart, it acts by reducing the preload as well as the afterload that is there. To the neurohormonal level, it reduces downgrades the parasympathetic activity which is there. So the outcome is that it reduces the cardiovascular death in patients with heart failure, as well as hospitalization for heart failure is much less. Then on the other hand, we have linagliptin, which is also one of the gliptins which we have been using for several years. It has 10,000-fold selectivity for DPP-4. It is the only one that is secreted by the hepatobiliary route as compared to the other DPP-4 inhibitors. It does not require any dose adjustment once the eGFR starts going down. It can be used in all patients with CRF. Also, the complementary actions of DPP-4. One works with the insulin-dependent mechanism. The DPP-4 reduces the glucagon and the endogenous glucose preparation, whereas the SGLT2 works to increase the glucagon and endogenous preparation. DPP-4 is weight neutral. SGLT2 reduces the weight and the blood pressure. Together, both reduce the fasting, the postprandial, as well as in the long run, the HbA1c is reduced with minimum or no hypoglycemia. This is a pictorial representation of how they both work, the sites that they work at. The SGLT2 works on the kidney, on the pancreas indirectly, whereas the DPP4 works essentially on the pancreas as well as on the intestine. And together they all reduce the weight, reduce the blood pressure, as well as cause weight neutrality for the DPP4. Now, there have been several trials which have been done, systemic reviews. They all have shown that when an SGLT2 and DPP4 combination together is used as compared to just a DPP4, the results are much better, as well as the cardiovascular risk also improves. Similarly, when an SGLT2 and DPP4 is compared with just an SGLT2, also there is a greater reduction in the HbA1c. On the body weight, when they combine together, they're both efficacious and safe. It also, linagliptin also reduces the risk of genital urinary tract infection when it is given along with an SGLT2 as a fixed dose combination. The time in range. Time in range is what we usually measure when we do continuous glucose monitoring or ambulatory glucose monitoring, which is done. In this, what is measured is the glycemic variability. When it was evaluated, it was found that the glycemic variability has been much better as compared to the glycemic variability with either or of these medications. So now when do we use it? So ideally, of course, after medications, after metformin is where it should be used. But there are people who do not tolerate metformin. Metformin doesn't suit them because it does cause a lot of, feeling uncomfortable, anorexia, nausea, diarrhea. You will all find that in your practice there will be at least 1% of patients who do not tolerate metformin. And those are the people that you can start directly with a combination therapy. Of course, if the HbA1c also is high, in spite of the metformin, you can start this medication. Now, like I said, it can be in treatment-naive patients where metformin is not indicated or the HbA1c is above 8%, 8.5%. Also in patients who are uncontrolled with metformin monotherapy, patients who are treated, management of type 2 diabetes in where you have already given metformin and probably you have started a DPP4 or a SGLT2, you can add the other one, so you can give it as a combination therapy rather than just giving them two separate tablets. Also, we can use it in patients where we've added either a sulfonylurea or glitazone or something which has been added, and yet they are not meeting their targets. So that's where also it can be added. Insulin, of course, if a person who comes to you is on insulin but still in spite of insulin is not meeting their targets, type 2 diabetics, we can consider adding this. Patients with cardiovascular risk, of course, it would be the first opportunity to add because in cardiovascular risk, it is better to start with an SGLT2 or a DPP4. Sometimes if the HbA1c is more than 8.5, we can start together. If we have assessed their their CKD status, if they are already having an elevated creatinine level or the eGFR is starting to lower, we can start this levels. So, dapagliflozin in patients with chronic kidney disease, it is known to improve the primary composite by about 39%, the combination by 34% risk reduction, cardiovascular benefits by about 29%, and total reduction in mortality by about 31%. So this is something which, as compared to the other medication, is much better. The study, of course, was done in people with diabetes and without diabetes also. It was found that they were good to reduce the onset of cardiovascular risk. With linagliptin, we have seen the Carmelina trial. It has been extensively studied, and it has shown long-term CV safety profile. It has a long-term kidney safety profile also. And this is unique because we don't need to reduce the dosage if the eGFR is falling. Now coming to the weight, because most of our people with type 2 diabetes are overweight. We need to address that. Of course, diet, lifestyle, all these things can be done. But along with that, we need to see that we don't give them medications which are further going to increase their weight. If we find that the weight is increasing, ideally this is a better molecule, DPP-4 and SGLT2 combined, to give them a better outcome. So to summarize, what is the benefit of this molecule? Effective glycemic control, of course, is there. The cardiometabolic benefits are there. Targets multiple aspects of the type 2 diabetes pathology. It is cost effective now, because earlier these medications were available, they were very expensive, could not be afforded by most people. Now, because of the reduction in the prices and also with the onset of combination therapy, the price further reduces. It also reduces the pill burden. So instead of taking 2 tablets, they can take 1 tablet. And of course, we have the extra glycemic problems. So with this, I thank you for the patient
Hello. Thank you so much, ma'am. I think everyone who is agree with me. बड़ा ही स्वीट सा लेक्चर था ये, स्वीट सी मैडम का, and it definitely all about the rest. And believe me, Mdmpa is the best. Now I request our chairperson, Dr. Janvi and Dr. Nasim sir
का मैसेज
to please
भेजा हूँ,
felicitate
सारे
Dr. Lotika.
फॉर्मेट से डिलीट हो गया है. मैं डाल देता हूँ. टाइम बताओ.
Now I also request our respected members, Dr. Deepak Jumani and Dr. Shashikant Thora, to come on the stage. Shashikant Kamat, sorry sir, to come on the stage to felicitate our chairpersons.
Madam is definitely very GP oriented lecture. Thank you so much, ma'am. Now I request our smart boy of Mdmpa and our editor, Dr. Kiran Avari, and young, talented and woman of substance, Dr. Poonam Mesri, to come on the dais to chair the next session.
Our next speaker is very young and onco-physician Dr. Jobanputra, and his topic is very interesting one. Can we beat cancer? Sir, kindly come on the dais, please.
Hi, good morning everyone.
पहले से माइक एडजस्ट करना पड़ेगा, अगर नहीं किया तो उनसे
Hello.
जिंदगी कैसी है पहेली कभी तो हंसाए कभी ये रुलाए।
बाबू मोशाय, हर एक आनंद के जीवन में एक नए उम्मीद जगाते हो।
कैंसर का हर दर्द दवा से ही मिटाते हो। कैसे चलाते हो ये जादू और कर देते हो कमाल। नाउ वी हैव इन बिटवीन अस यंग एंड हैंडसम डॉक्टर Kunal. Now I request our chairpersons Dr. Kiran and Dr. Poonam to introduce our respected speaker Dr. Kunal Jobanputra.
And Dr. Kunal Jobanputra. He is a clinically certified gold medalist, highly skilled medical oncologist, trained at Tata Memorial Hospital. He has passed his MBBS from Vijay Medical College, Ahmedabad. His MD Internal Medicine from GS Medical College, Mumbai, and DM in Medical Oncology from Tata Memorial Hospital. He is a European certified medical oncologist. He was assistant professor in medical oncology at Tata Memorial Hospital and as assistant professor in internal medicine at GS Medical College. Sir is presently working at MOC, that is Mumbai Onco Care Center. He is a gold medalist in general medicine also. And above all, he is a smart looking guy with down to earth personality and ever smiling face. Thank you, sir.
Thank you for the kind introduction, and good morning, and thank you association for inviting me for speaking on this topic. So I kept my presentation short if anyone wants to interact, and also very simple. As I can see, this year's the logo below the Mdmpa has death, cardiovascular disease, stroke, heart attack, chest pain. But I think we should also have very soon cancer because it's increasing, unfortunately. So today I will be talking on can we beat cancer and how can we achieve and what can be done and what are the newer advances, what has developed in recent times. So first of all, very basic, what are the red flags of cancer and when do we suspect cancer in any patient? So if we go for solid tumors, we will divide into solid tumors and blood cancer. So here are the key signs that starting from the top to bottom, head, neck to the lips. So any change in the voice, which is new onset and persistent hoarseness or long-standing persistent non-resolving cough, any mouth or tongue ulcer that lasts more than 2 to 3 weeks, coughing up of blood, hemoptysis, unusual change in the size, shape or feel of the breast, including nipple and skin changes, nipple discharge, breathlessness, difficulty swallowing, persistent heartburn or indigestion, loss of weight, loss of appetite, persistent blotting sensation, then coming down to the GI tract, change in the bowel habit or in the bladder habit which has been persistent for quite some time in spite of symptomatic medications, gynecological problems, unexplained vaginal or postmenopausal bleeding, or hematuria, or there are dysuria and problems in the micturition. Other general complaints which can be any type of cancer could be loss of appetite, fatigue, unexplained weight loss, involuntary weight loss, unexplained body ache or unusual body lump anywhere or any swelling in the body, or we should also be careful for the skin cancers like melanoma and squamous cell carcinoma. So why this is so much of importance? Because there is an important aspect to detect and screen cancers early. If we are able to detect cancers early, report cancers early to the report the symptoms early to the physicians and to cancer physicians, then we are at a higher chances that we are able to diagnose the cancer at the early stages. And early stages cancer, as we all know, the survival has improved dramatically. If we see cancers like testicular cancer, earlier in 1990s, 1980s, 1990s, the 5-year probability of a patient surviving with testicular cancer was 60%. Now it has come to 95%. If we see Hodgkin's lymphoma and other types of lymphoma which occur in the young, now the survival has gone beyond 90% in many early stages of Hodgkin's lymphoma. Even in breast cancer, now if we detect breast cancers early, at the earlier stage, at second or third stage or even at first stage, then we have a chance of 80% or 90% chances of long-term survival. So this has increased, not even in early stages, even in metastatic cancers, as I will discuss in the next few slides, because of newer treatments. In 1990s and 2000s, for lung cancer, we had only 1 or 2 types of chemotherapy, and the chances of patient living beyond 3 years was only 10%. Now it has increased to 30 to 40%. So how we have been able to do this, I will just discuss. So now this is again a brief summarization of the different types of symptoms which a patient might have and which needs a referral to a cancer physician or a surgeon or a medical oncologist or a radiation oncologist, be it any oncologist in a community practice, to report these symptoms as early as possible for better and early diagnosis and treatment. So now we look at what are the symptoms of blood cancer. So blood cancer, as we know, there are 3 or 4 main types of blood cancers. We see leukemias. So leukemias will have more of bleeding manifestations, repeated infections, fever because of reduced blood counts, reduced platelets. It can have easy fatigability because of low hemoglobin. So leukemia will kind of a emergency kind of picture. When a patient needs to be admitted as soon as possible for leukemia, because they have very high blood counts to cause hyperleukocytosis and those features, or they have very low blood counts to cause life-threatening infections. They can also have baseline fungal infections because of prolonged neutropenia. They need urgent admission and platelet transfusion if they are having severe thrombocytopenia or bleeding manifestations. They need to be transfused blood, and after doing this basic management, we need to do a bone marrow biopsy or a peripheral blood flow test to detect which type of leukemia is there. So leukemia is kind of an urgent thing. Other type of blood cancer we know is lymphoma. So lymphoma, there are various types of lymphoma. In young patients, there are more chances of Hodgkin's lymphoma and then non-Hodgkin's lymphoma in elder patients. Other type of blood cancer is myeloma, which is very common in older age groups. They typically present with fatigue, bone pains, hypercalcemia, renal injury. So there are cramped features of myeloma. So here we have mentioned cough, unexplained bruising, pain in the bone joints, which could be a feature of myeloma, frequent infections, tiredness, unexplained fever, unexplained rash, weight loss, shortness of breath, pale. For which screening is recommended. There are few cancers for which screening is not recommended. For screening, there are 3-4 basic principles to be kept in mind to decide which cancers should be screened. We can't screen all the types of cancers. So cancers in which early diagnosis and treatment is helpful to the patient and there are lesser false positives, that those cancers should be screened. So breast cancer is a significant problem in our society. So breast self-examination and a clinical self-examination is mandatory and to be practiced by every woman monthly. Apart from this, there are certain recommendations for screening mammogram. So there are screening mammogram and a diagnostic mammogram. So screening mammogram is readily available in the market. Many of the labs now currently do it, and current recommendation, the US Societies has recommended and lowered the recommendation of the onset of doing a mammogram from 50 to 40 years. So from 40 years of age till 75 years of age, they are recommending a mammogram to be done biannually. For cervical cancer, again a very important problem in Indian population and developing world. So cervical cancer now, pap smear, as we all know, has to be done, and it is advised to do from 21 years of age, starting from the reproductive age group to 65 years of age every 3 years, and after 65, when the pap smear are consecutively negative, then you can stop testing. So most of the screenings are between 40 to 30, depending on the type of cancer. Usually they last up to 65, 70, because after 70 the life expectancy, what in general in Indian patients and also in the worldwide population, is around less than 10 years when a patient is at 70. So the benefits of screening won't be that much. If we see prostate cancer, so prostate cancer is there are many societies recommending different things, but if we see a uniform consensus, then it is like starting from the age of 40 to 50 years, depending on the risk status. Some patients have risk of prostate cancer in the past in the family, or they are of some ethnic like African American or patients who are having first degree relatives of prostate cancer. We start screening early. Otherwise, we start from the age of 50 years. and depending on the PSA level which we get, then we advise and decide about the subsequent frequency of doing a PSA testing. So if the PSA is less than 2.5, we can do it every 2 yearly, and if it is more than 2.5, we can again do it yearly. But we should remember that causes of false elevation of PSA, which is very common, urinary tract infections, recent Foley's catheterization, any prosthetic massage in the past, any digital rectal examination in the past can also elevate PSAs, albeit to a lesser extent, not a drastic increase like 20 or 30, but a small elevation in PSA can also be because of these reasons. Colorectal cancer screening. So again, here the age of onset of screening is 45 years of age, going up to 75 years, and there are various methods of screening of colorectal cancer. Basic screening test could be a stool-based occult blood testing, and then colonoscopy can be done every 10 yearly, or a flexible sigmoidoscopy can be done every 5 yearly. Lung cancer. I think this month is, as we know, it's a lung cancer awareness month. So it is practiced all over world. So the recommendation to do a lung cancer screening is to do a low-dose CT scan. So this CT scan is different from the routine HRCT thorax or NCCT thorax which we do commonly. This is a low-dose CT scan, and this is done every 3 to 4 yearly. And patients who are taken in the trial, these were patients of 50 to 80 years of old age, and who are current smokers or who were smoking in the past and had quit smoking in the last 15 years. Now, an important aspect and inclusion criteria of this study was patient must have had a history of 20 pack year smoking. So, as we know the calculation of pack years, if a patient has got, if a patient is smoking 1 pack per day for 20 years or half pack per day for 40 years, then it comes to a 20 pack year. And this patient should be in a 50 to 80 years of age and must be currently smoking or recently quit smoking in last 15 years. So, these are the various screening recommendations. So basically breast, cervical, colorectal, prostate, and we have lung cancer. So these are the 5-6 cancers in which screening is recommended. So now what are the latest advances and what are the types of cancer treatment? So as we know, cancer treatment basically is dealt by 3 type of cancer physicians. These are surgical oncologists, the radiation oncologist, and the medical oncologist. Surgical oncologist will operate, radiation will provide radiation to the tumor to ablate the tissue, and medical oncologist will give systemic treatment. Now, the area of medical oncology has expanded recently in the last 5 to 10 years, I would say. And as you can see, chemotherapy, immunotherapy, hormone therapy, targeted therapy, and stem cell therapy. These are all under the purview of medical oncology because it provides systemic treatment. So what are the differences between the conventional therapy and the recent therapy? So chemotherapy, as we know, chemotherapy are cytotoxic. These are the chemicals. These are the chemicals which used to be, which were used previously in the world wars, in the Nazi era and in the both the world wars. These chemotherapy agents kind of were used for killing people. So this chemotherapy now, the agents which we have been conventionally using from 1970s to even till today, this chemotherapy agents, they target the rapidly dividing cells, and the side effects, as we know, hair loss, nausea, vomiting, fever. Now, because of when we administer chemotherapy, after a few months we see that patient progresses, patient develops resistance to chemotherapy. So, going on this principle, the researchers and the scientists have come up with latest type of therapies. These are targeted therapy and the immunotherapy. So, I will discuss one by one the specific of each therapy. So these 2 people were the game changer of cancer treatment. They received Nobel Prize in 2018. The names of these people were James Allison and Tasuku Honjo. So they received Nobel Prize for discovery of the discovery that cancer therapy can be done by inhibition of negative immune regulation. So I will explain one by one what was this. So these are the game changers. So how does immunotherapy work? So when a person has cancer cells in the body, cancer cells have got this typical mechanism which has been discovered recently in the recent few years, that they try to escape or evade from the immune system. They try to run away from the immune system, or when they interact with the immune system, cancer cells will inhibit the immune system. It won't allow the immune system to work on the cancer cells. So immunity doesn't just work on bacteria, viruses, fungi and parasites. It also works on cancer cells, but normal mechanism of cancer, cells is to inhibit the immune system so that it won't allow the immune cells to act on it. So this is the, as I mentioned in the figure, that tumor cells bind to T cells to deactivate them, and immunotherapy drugs will block these tumor cells from deactivating these tumor cells. So again, schematic representation of the same, that when antigen presenting cells, as we know, carries the tumor antigens to a T cell, there is by default there is a T cell suppression because of the nature of the cancer cells to evade the immunity. So when I give any antibody which acts against these receptors which are in the T cell inhibition, then it can lead to tumor destruction by T cell activation. So immunotherapy is a very broad term. Commonly what we are using immunotherapy in recent times is the checkpoint inhibitors, the first one. In the market and in various consultations and various advice given by oncologists, what we prescribe, these are the checkpoint inhibitors which we are using in lung cancer, melanoma, kidney cancers, colorectal cancers, breast cancers, bladder cancers. So this has changed the whole treatment of cancers. Initially, this immunotherapy or any type of immunotherapy, the trials are done in the 4th stage, that is the metastatic stage. They get proven, they show benefit in the 4th stage, then subsequently the trials are also done in the 1st, 2nd and the 3rd stage. So this is how the clinical trials are done. So initially all these new drugs were studied in the metastatic stage and have been found to be very successful. As I mentioned earlier, the survival rate of lung cancer was less than 10% for 3 to 4 years. Now it has become to 20-30%. Even for breast cancers and all types of cancers. Even in kidney cancers, previously we had only one tablet, that was sorafenib or sunitinib. Now we have got 10 options, and we have a chance of 5-year survival of going up to 20-30% for kidney cancer who are using immunotherapy. So what are the other types of immunotherapy? These are the adaptive cell therapy. They are T cell transfer. So they inject the T cells which are stimulated, and then they lead to cancer tumor cell destruction. Other types of immunotherapy are cancer vaccines. Now we read in the newspaper the vaccine has been developed, but then vaccines are not still very effective. There is only one vaccine which has been approved, that also for prostate cancer, but it is only for patients who are having lesser symptoms, not for advanced disease. So basically immunotherapy deals with checkpoint inhibitors. There are various names of the drugs. I have not got into specifics, but there are pembrolizumab, nivolumab, atezolizumab. These are various MABs which are antibodies against the receptors which can help in T cell activation. Now targeted therapy because cancer cells have got specific receptors on their cells. Only by this help of receptors they proliferate. They need something stimulation to proliferate and to multiply. So this target are there on different targets are there on different cells. Best example is breast cancer. Breast cancer has a target of HER2. So that is kind of a epidermal kind of growth factor, and we have an antibody against it, which is Herceptin. You must have seen patients getting trastuzumab for breast cancer, and now newer types of antibodies are getting developed against HER2. We have trastuzumab, we have pertuzumab, we have trastuzumab emtansine, we have TXT. There are 4 to 5 types of newer antibodies which are developed, and this can effectively help in suppression of tumor cells. So now this you can see so many targeted agents. Then this list is not exhaustive. This list is not complete. This is just a schematic representation. So 2001 we had only the first targeted agent was imatinib. So imatinib you must be knowing in CML, chronic myeloid leukemia, it was the first agent used, and it has dramatically changed the survival of CML. Initially CML was not curable. Patient used to go for bone marrow transplantation. Now CML we have outcomes in good risk, we have outcomes going up to 90% for 10 years. This is dramatic. So after this we have developed, the researchers have developed so many targeted agents used in various types of cancers, and the list is endless. So another thing is CAR T cell therapy. Again, it's a new sensation coming recently. You might be aware of the news that now India has also developed CAR T cell therapy by collaboration of Tata Memorial and IIT Bombay. So what are this CAR T cell therapy? CAR T cell therapy is used currently approved in blood cancers, in leukemias. Patient blood is collected, and this blood we collect the T cells. The T cells are reprogrammed. The T cells which are having receptors, these receptors are reprogrammed to act against the body's own cancer cells, and these cells are cultured in a medium, and they are again infused back in the patient. So we know about bone marrow transplantation. Bone marrow transplantation can be done from another donor or from the same patient. That is allogenic BMT or autologous BMT. So similar kind of concept. The CAR T cell therapy is used. CAR T stands for chimeric antigen receptor. So the antigen, the receptor which is there on the T cell of the patient's body, those are modified and developed into another type of receptor which can act against the tumor. So these are chimeric antigen receptor T cell therapy, and this CAR T cell therapy is the next future of treatment of cancers, and that will come into blood cancers and again into solid tumor cancers, and many trials are going on. So this is another, let's not just discuss about the newer therapies, we should also discuss about newer technologies which can help in reduction of side effects of cancer treatment. So we know that breast cancer patients and many other types of cancer, young patients, female patients, they are very apprehensive about side effects of chemotherapy like hair loss. So now something has come up which is known as scalp cooling. So by scalp cooling, it induces vasoconstriction in the vessel supplying the hair, and this scalp cooling is applied typically during the chemotherapy administration. So before chemotherapy, during chemotherapy, and after chemotherapy, there is scalp cooling done at the low temperature, and this kind of helmets are worn. And this is a specific machine which can be used for 2 patients at a time. So this scalp cooling can help in reduction of significant alopecia by 50% in some patients. And recently we have presented this data at the recently conducted Indian Cancer Congress at Bombay. So all this immunotherapy, targeted therapy, newer types of therapies, the problem with these therapies are apart from the effectiveness of such therapies, they are able to overcome the resistance of chemotherapy, but these are not the total solution of cancer. So there are other drawbacks like that they are having newer side effects. The side effects which we have seen from chemotherapy, the conventional side effects, the side effects of targeted therapy or immunotherapy are completely different. Because of immunotherapy, there is immunity stimulation. So we can have autoimmune side effects also because of immunotherapy. There are other spectrum of side effects of targeted therapy. So it's not like a complete panacea or a solution, but it again has its own benefits, and we should consider on case-to-case basis. Another important aspect of this newer therapies is accessibility and affordability. That has become an issue in India, as we have seen in a study by Tata Memorial that 90% of patients in visiting Tata Memorial don't have access to immunotherapy because they can't afford it. So now newer solutions are getting done. We are using lower dose of immunotherapy, lower dose of targeted therapy. But above all the advancements, all the technologies, one thing which is to be kept in mind in all the branches of medicine, but specifically in oncology, is hope, compassion, support, empathy, and support and full support to the patients. And you can beat cancer by how you live, why you live, and in the manner in which you live. So we can conquer cancer. Thank you.
Hello. Telling you this MOC, that in the treatment of cancer, MOC, that is Medical Oncology Center, is doing great. And believe me,
Mdmpa is the best. Now I request our chairperson, Dr. Kiran and Dr. Poonam ma'am, to felicitate our eminent speaker, Dr. Jobanputra.
Thank you, sir. Thank you for your valuable lecture. And you have introduced us to something new, that is the CAR T cell in scalp cooling. Thank you, sir. Thanks so much.
सेंटर में
now I request our chairperson, Dr. Suman Patil. Now I request our respected and enthusiastic senior member, Dr. Arun Bhore and Dr. Vasant Gadre, to come on the stage and felicitate our esteemed speaker.
गजरे सर का
चेयरपर्सन
गजरे सर आना अरे बोला है तो फिर फोटो निकालने का मैं बोलता हूँ कि पहले से आना एक्चुअली सिंगल ही है ना, इसके लिए वो
Now I request youngest and Dashwood enthusiastic member Dr. Suman Pandya and our calm and quiet boy Dr. Yashas Bhure to chair the next session.
Our next speaker is a well-known hematologist in the town, Dr. Shyam Rathi, with an interesting topic, interesting cases in hematology. Sir, please come on the dais.
मेरे भाई दीवाना नहीं है तो तेरी एचपी हुआ है कम
या है तुझे एनीमिया, थैलेसीमिया या ल्यूकेमिया? कॉन्टैक्ट एमडीएमपी का बेस्ट साथी डॉक्टर श्याम राठी. Now I request our respected chairperson to introduce our respected speaker, Dr. Shyam Rathi.
Good morning, everyone. Dr. Shyam Rathi is a consultant hemato-oncologist and bone marrow transplant physician. He has fellowship in leukemia, bone marrow transplant, Vancouver, Canada. DN clinical hematology, AIMS, New Delhi. Fellowship in hematology at CMV Vellore. MD General Medicine from Mumbai University. He is a consultant at Hinduja Hospital, Mumbai, and Hematology Clinic at Dadar. This topic today is interesting cases in hematology. You are welcome, sir.
Good morning. I am thankful to Andheri IMA for this kind invitation. So what I have done, I have taken the common topics, what you do and what you see in the day-to-day practice. So every patient asks for the routine test, and I will ask you some questions related to this case. This is an interactive session to try to answer as much as possible. We'll start with our first case. Mr. SRK, 50 years old gentleman, and planned for hernia surgery.
Everyone silence, please.
Yeah, you do the blood investigation before surgery, like for all the patients. There was no significant past and family history. Pre-op investigation showed APTT is more than 100. It was almost not recordable, and all other investigations were normal. So this is a common thing when you take any patient for surgery, you ask for the pre-op investigation. This is very simple question, which is not needed out of all this: history, CBC, INR, BTT, BTCT.
Or BTCT?
Yes. So it's almost like outdated. So if you have good history and all these three parameters, there is no need of BTCT. And I think many labs stop doing it nowadays. We'll back to our patient. So our patient is that 50 years gentleman, planned for hernia surgery, presented with deranged PTT, is he fit for the surgery? So you should know the causes of PTT. So this is another question. Which one is not the cause of deranged PTT? Factor 8, factor 9, factor 11, deficiency or liver dysfunction? Very simple question.
Liver dysfunction.
Yeah, absolutely. So liver dysfunction generally affect the PT, prothrombin times, unless it's very advanced liver dysfunction, you don't see derangement in the PTT. So you should have, this is the basic pathway which you must have learned in your MBBS days. There is intrinsic pathway and extrinsic pathway. The intrinsic pathway, factor 12, 11, 9, 8 deals with the PTT, and extrinsic pathway deals with the PT. So when you see any patient with deranged PTT, your first step is to identify whether there is a deficiency or inhibitor. So what you do the mixing study. So like this patient, you do the mixing study, the APTT connected with normal plasma, you suspect that patient has factor deficiency, you do factor 8, 9, 11, all of them were normal, now the patient has factor 12 deficiency, and factor 12 is below 1%. Now you have 50-year gentleman planned for surgery, deranged PTT, and the factor 12 is below 1%. The question is that is he fit for the surgery? Yes or no?
No.
Okay. So this patient evaluated at multiple places. He received plasma infusion before surgery, but PTT still remained deranged, and surgery was cancelled multiple times. So what you are going to do? Challenging situation. You have a patient with deranged PTT due to factor 12 deficiency. I said that history is very important. He never had any bleeding in the past. So factor 12 deficiency, there was no history, past history of bleeding. Factor 12 deficiency doesn't require any support. It's a basically lab effect, but personally patient doesn't have never bleed in the family. So this patient underwent surgery without any problem, and there was no need of any transfusion. We'll move on to our next case. 45 years old female, referred from Tata Memorial Hospital.
How did we diagnose him that it was the lab deficit?
At the end of the discussion. So 45 years old female, referred from TMH, presented with CA breast stage 1. I think she should go for the curative surgery. You do the pre-op investigation, INR is more than 2. All other investigations were normal. See a young patient planned for the surgery, only INR is deranged. Again the question is that is the patient fit for surgery? Yes or no?
Yes.
Oh, deranged INR. Okay. Which of the following is not the cause of deranged INR in your practice? Liver dysfunction, vitamin K deficiency, warfarin toxicity, factor 11 deficiency.
Again, liver deficiency.
Not. Liver deficiency, one of the most common cause for deranged INR. I showed you in the previous slide, the coagulation cascade. You must have learned in your MBBS days that factor 12, 11, 9, 8 deals with the PTT and the factor 7 deals with the PT, along with liver dysfunction, vitamin K deficiency, warfarin toxicity. So the approach is same for any patient with deranged INR or PTT. Your first step is the Nixon study to find out whether there is a deficiency or inhibitor. This patient, the INR corrected with normal plasma, patient suspected of factor deficiency, and there is only one factor you have to check is factor 7. Factor 7 is below 1%. LFT is normal, there was no drug history, and the patient didn't respond to any vitamin correction. So this patient, young lady with curiosity, approached for the surgery, and she has factor 7 deficiency. And the problem with factor 7 deficiency is not like factor 8, like hemophilia must have heard. It has very short, like maybe 5 to 6 hours. The plasma infusion is not possible because you have to give quite good quantity of plasma to get that level of factor during the surgery. And there is always concern of trolley if you transfuse the patient lot of plasma. What else you can do? Like factor 8, you have the factor 7 available. Like you must have heard of hemophilia patient getting factor 8, 9. The same way there is a factor 7 is available. This patient was put on the NOVA 7 factor 7 during the surgery, and she underwent surgery without any problem. We'll move on to our next case. 73-year-old gentleman, case of ISD, planned for CABG, pre-op platelet count is just 26,000. There was no history of bleeding, and the platelet count was variable in the past from 26,000 to 2,54,000. The hemoglobin is 40.6, WBC is normal, platelet count is 24,000. Is he fit for the surgery? Your elderly gentleman planned for CABG, pre-op investigation shows thrombocytopenia, and you have to give the fitness for the surgery. Is he fit for the surgery?
It asks for manual platelet examination.
So always when the 5 common causes of thrombocytopenia, you are right. So whenever you see any patient with thrombocytopenia in your practice, hemoglobin WBC normal, platelet count is only low, then you have to think of this 5 common differential. Remember in your practice, because every patient, alternate patient, you do the CBC, you come across all these problems on the regular basis. The topmost is the liver dysfunction. Second is the infection like viral, parasite like malaria, bacterial like sepsis, HIV, HCV, and malaria. Drugs. Always check the patient's drug history. There are a lot of drugs which can affect the platelet. Autoimmune disorder like SLE. And the last on the list is the hematological disorder. So continuing with our case. So this patient was admitted at some cardiology center, and there was no history of fever, jaundice, organomegaly, no history of any drug, no features of autoimmune disorder, WBC differential was normal. How to manage during surgery? Any guess? So patient since he was admitted under cardiologist, the patient received platelet transfusion multiple times. There was no increment in the platelet count. Now come to you. So any guess?
Sir, it is mega platelet.
Yes. So always check the smear. Any patient with thrombocytopenia, if you remember this patient, the platelet count was variable. There was no history of bleeding even after taking the aspirin also. So there was clumping of the platelet which can be detected only on the smear. So you have to rely on your pathologist, ask him to check the smear carefully. So this is the dictum that any patient with thrombocytopenia, always check the platelet smear. There was no need of platelet transfusion, patient underwent surgery without any problem. We'll move on to our next case. 24-year-old male admitted for severe thrombocytopenia. If you look at the hemoglobin 17.6, WBC is 2.9, and platelet count is just 4,000. History of fever 10 days back. You are afebrile for last 10 days. History of fever 10 days back. Dengue IgM positive that time. LFT RFT normal. INR PTT normal. There is no coagulopathy. Since he admitted with thrombocytopenia and the physician received platelet transfusion multiple times without any increment in the platelet count. And now he referred for the hematologist. What will you do? Will you continue platelet transfusion? No. So what will you do? So it is good. So what happens that any patient in your practice come with the platelet count like 5,000, afebrile, stable, you do the platelet transfusion one time, there is no increment, never transfuse them because it doesn't work. The problem is that the production or destruction. What we are suspecting here is the destruction. And if there is a destruction, body is already producing 8 times platelet. You are transfusing 2 SDP, 8 only, each SDP costs you around $12,000 and it doesn't work actually. So transfusion is not recommended if somebody is not bleeding where the platelet count is low. What else? So you suspect that patient has developed immune thrombocytopenia, so you will start him on the steroid, and you have drugs like romiplastin, Mdmpa. Everybody is aware of erythropoietin. You know the erythropoietin is a drug for the hemoglobin. The same way you have the drug for the platelet called romiplastin, Mdmpa, which just improve the platelet count. Okay, this point the patient got discharged happily. Now he came back again after 2 years. This time he got admitted directly in the ICU. Presented with fever, body ache, jaundice, breathlessness, multiple ecchymotic and petechial rashes. The platelet count is again 4,000, WBC is 900, hemoglobin is 18.6. So what do you suspect? Second dengue infection. So dengue NSL positive second time, and LFT was significantly deranged. The patient presented coagulopathy. So almost like so received platelet transfusion. Since he was presented dengue shock syndrome type of presentation, received platelet transfusion, hydration for coagulopathy, supportive care. So any test which can change the current management. The patient came in very bad shape with second dengue infection with coagulopathy. Do we want to do anything which can change the management here?
The pro platelets are there, so that you will evaluate whether they are there. Pro platelets.
Yeah, but the platelets are anyway, whichever way technically do it, they are on the lower side. The platelet transfusion is not working here. Patients having bad coagulopathy. You want to do one test which can change the management here. So here you do the ferritin. So I hope you heard of ferritin. The ferritin was more than 90,000. You are dengue patient with coagulopathy, hepatitis. The ferritin is coming more than 90,000. So it presents like dengue with HLH. So dengue with HLH, the management is changed to high dose dexamethasone with IVIG and is discharged in a good shape. We'll move on to our next case. Young girl, 17 years old female, presented with weakness. There was no history of bleeding. Appetite was good. Hemoglobin is 4.9. WBC count is normal. Platelet count is normal. Reticulocyte count low. That is production problem. MCV is low. That is microcytic anemia. So when you see any patient with low hemoglobin and low MCV, remember these 5 differential in your data. Very simple hematology. And these top 2 are the 90% of the causes of anemia. Iron deficiency anemia, anemia of chronic infection, then comes the thalassemia, hemoglobinopathy, cerebroplastic anemia, and genetic deficiency. Okay, so back to our case, we do the serum and study the serum iron is low, TIBC low, transferrin saturation is low, HB electrophoresis within normal limit. You always want to differentiate iron deficiency anemia from other conditions like anemia of chronic infection. So here in iron deficiency anemia, serum ferritin is low, that is iron stored, serum iron, transferrin saturation will be on the lower side, iron binding capacity will be increased. What is happening in anemia of chronic inflammation? Because of chronic inflammatory state, hepcidin blocks the iron production, iron from the storage. So because of blockage in the storage, the ferritin is increases, serum iron, TIPC, transferrin saturation will be below normal. And thalassemia, sideroblastic anemia, all of them will be normal or increased. So in our patients, serum iron, TIPC, transferrin saturation, all were below normal, and HB electrophoresis was normal. So this patient was suspected iron deficiency anemia and received multiple iron infusion. Unfortunately, she didn't respond. On the contrary, she started developing iron toxicity. You check the iron level from multiple labs, and all the labs, the iron level is always on the lower side. There is no doubt about the iron study. And you try to give the iron, the patient is, instead of improving, developing the toxicity, iron toxicity. So what do you think? What will be next step? If you have to do one test for iron deficiency, which one will you do?
Ferritin.
Serum iron, TIPC, transferrin saturation, serum ferritin. Ferritin. So in your practice, you strongly suspect iron. You want to do only one test, don't want to waste your resources, just do ferritin.
Yes.
If it's below normal, then no other differential for the low ferritin. That is iron deficiency. In this patient, it was missing part was the serum ferritin. The physician forgot to check the ferritin, and the ferritin was 6,500. Normally just 100, 50 to 100. The patient has developed significant iron overload. What was the problem? The transferrin level. What is transferrin? Transferrin is the transporter. It transports the iron from the storage site to the site of production. So this patient, the serum transferrin level was low. So because of deficiency of transferrin, the iron is getting accumulated in the storage site, but is not getting utilized at the site of production, like the hemoglobin. The treatment. So treatment is this patient has genetic transferrin deficiency. It's a rare cause, and hereditary hypotransferemia. The treatment is the plasma infusion. You have to put the patient on the lifetime plasma infusion. We'll move to the next case. 18-year-old girl presented with weakness and tiredness since childhood. No history of menorrhagia, hemorrhoids. Hemoglobin is 9 gram. Again, the MCU is 66. That means the patient has microcytic anemia. White blood cell count is normal. Platelet count is mildly increased. Reticulocyte count is low. That means problem is in the production. This is a dictum. Always remember this 5 differential in your practice. Very easy hematology. Always remember the iron deficiency anemia, anemia of chronic infection, thalassemia, hemoglobin, sideroblastic anemia, rarely genetic deficiency for the microcytic anemia. Okay, so back to our case. Young girl with anemia, the ferritin is less than 10, serum iron low, transferrin saturation low, iron binding capacity is increased. So what do you think?
IDA.
Iron deficiency anemia, correct. Okay, so as you suspect, you start the patient on oral iron supplement, but there is no improvement in the hemoglobin. You give the iron supplement, you confirm that patient has iron deficiency, but patient doesn't respond to your iron supplement. What is the problem?
Absorption.
So the iron study repeatedly, it shows iron deficiency anemia. Now she started on injectable iron, and the hemoglobin improved to 11 gram within a month. You give the oral iron, it doesn't work. You give the injectable iron, it works. And patient is responding to injectable iron but not oral iron. Any guess? So which hormone regulates the iron metabolism? The insulin, growth hormone, testosterone, or hepcidin? Hepcidin, correct? Everybody is quite updated. So what is the problem here? So hereditary disorder leading to iron deficiency, TMPRAS mutation. What is TMPRAS mutation? Hepcidin, like insulin, is secreted by the liver. It regulates the iron absorption from the gut, intestine. Because of genetic mutation, the hepcidin control is lost, and excess hepcidin blocks the iron absorption from the intestine. So you can get away with this by giving the intravenous iron. So you are not dependent on the oral absorption. So the treatment is the intermittent injectable iron. For this condition, it's a TMPRAS mutation related genetic condition. This is the last case. 60 years old gentleman presented with weakness and breathlessness. He underwent dental treatment with dental cement, started using dental cream regularly for last 6 months. Hemoglobin is 7.6, MC is 105. So macrocytic, we are moving from the micros to macro. Micro, hemoglobin, MC is less than 80, macro MC is more than 100. This patient has macrocytic anemia, WBC is low, platelet count is low, almost pancytopenia, reticulocyte count is low, that means problem in the production. So when you see any patient with low hemoglobin, high MCV, remember this 5 differential in your practice. Very simple hematology. Megaloblastic anemia, anemia of liver disease, alcohol, drugs related. For any patient macrocytic anemia, always check the thyroid, myelodysplastic syndrome, and then autoimmune hemolytic anemia. So back to our case, the TSH, B12, folic acid, everything is normal. So megaloblastic anemia rule out, hypothyroidism rule out, bone marrow is hypocellular, lot of dysplastic cells, karyotyping is normal, and lot of accumulation dysplastic cells on the bone marrow biopsy. He was diagnosed with MDS, elderly person with pancytopenia. We do the evaluation, biopsy, dysplasia. We diagnosed with MDS. And there are different categories in MDS. One of the categories is the RCMD. So there is a biological therapy for this condition called azacitidine decitabine, which works very well in this condition. So this patient was put on the biological therapy, didn't respond to that, and now planned for the allogeneic stem cell transplant. So at this time he was referred to us. So in any case, history is very important still in medicine. So what was the history here? Dental treatment. So what is the problem with dental creams? It contains a lot of zinc. Zinc. If you take a lot of zinc in the body, what will happen? It's an antidote for what? Copper. Yeah, somebody said. What is that? It is the antidote for which another metal? Copper. So, if you review the history, dental implant, lot of zinc supplement, and patient developed copper deficiency. He was put on copper supplement, the counts improved, and it's fine. Thank you.
थैंक यू सो मच सर। हेमेटोलॉजी की फील्ड में डॉक्टर श्याम राठी का नाम है वन ऑफ द बेस्ट, एंड बिलीव मी MDMP is the best. Thank you so much.
Now I request our chairperson, Dr. Sumant Pandya and Dr. Yesus Bure to felicitate our respected speaker, Dr. Shyam Rathi.
Now I request our ever young and backbone of Mdmpa, Dr. Rajesh Kovil and Dr. Shamim Azmi to come on the stage dais to felicitate our chairpersons. Thank you so much everyone. Now I request our next chairpersons, a hard-working guy of Mdmpa, Dr. R.P. Joshi sir and Dr. Suresh Bhatt sir to please come on the dais and chair the next session.
Our next speaker is very well-known young and dynamic cardiologist Dr. Amit Patil, coming up with the interesting topic, updates in interventional cardiology. Sir, kindly come on the stage please.
पहले से ही चला है चालू कर
भाई क्यों चीर के देख रहा है, मत लेना इतना टेंशन।
अब आ गया इंटरवेंशन में है सबसे हिट अवर लवेबल डॉक्टर अमित। नाउ आई रिक्वेस्ट अवर चेयरपर्सन डॉक्टर R.P. जोशी एंड डॉक्टर सुरेश भट्ट सर टू इंट्रोड्यूस अवर स्पीकर डॉक्टर अमित पाटिल।
Friends, Dr. Amit Patil is a renowned interventional cardiologist practicing in South Mumbai, Chembur and Ghatkopar. He completed his medical training from reputed institutes like KM Hospital and DJMC UN Mehta Cardiac Research Institute, Ahmedabad. He has multiple national and international publications with a strong academic inclinations. He is founder of ECG Helpline Program, providing ECG education and emergency cardiac guidance to more than tens of thousands of doctors in Mumbai and across India. He has special interest in structural heart disease intervention like TAVI, TMVR and complex angioplasty procedures like RDTA, ROTA, ablation, bifurcation, trifurcation, stenting and IVL. Please welcome Dr Amit Patil.
Thank you, sir, for a nice introduction. Very good morning to all the delegates, and I'm really thankful to Mdmpa for giving me this opportunity. So today we are going to discuss one topic, that is hypertension and denervation update. So hypertension is a very common topic. You might be seeing couple of patients daily and one patient a week which is resistant to hypertension treatment. So this update is very new. Since you are seeing a lot of patients of hypertension, you guys must be aware of this. So in hypertension, as we know, there is a medical therapy, and you might not be knowing about the intervention. So renal denervation is an evidence-based complementary treatment option for difficult to control hypertension. It fulfills unmet need of hypertension care, and patients want additional option. So you might have seen patients are on single antihypertensive, double antihypertensive, triple antihypertensive. Some of the patients are on 5 antihypertensives, but blood pressure is not under control. And such a patients are likely to complicate with the hypertension complications like stroke, heart attack, renal failure. For such a patient, this is a complementary treatment therapy available. The simplicity blood pressure procedure is safe, effective, providing significant always-on blood pressure reduction in presence or absence of medication. So basically, this renal denervation procedure is very safe, and it is effective with or without medicines. And it has been observed in studies there is a significant fall in blood pressure over the time. So what we are going to see, so hypertension is a global challenge. If we see hypertension data, so almost 1/3 of the patients are untreated, and those are treated, only 1/3 of the patients are with a controlled blood pressure. Even with treatment, 1/3 patient remains uncontrolled. So this is what the data of the hypertension says. So 1/3 of the patients are not treated, they just neglected, and those are treated, only 1/3 are under control, 1/3 are without under control. That's why the hypertension is a largest comorbid disease. If you see Indian data, prevalence of hypertension, almost 25% of the urban population have hypertension and 10% of the rural population have hypertension. And if you see COVID has impacted like anything. We don't have Indian data, but if you see US data, before COVID, blood pressure control was quite good. Around 50% of the patients who are under treatment were under control. But if you see progressive data, post-COVID, the blood pressure control has declined like anything. So that's why almost a 5 times greater rate of annual BP increased during the COVID pandemic. And hence the complication rate are more with the reduced control of the blood pressure. Now, why blood pressure control is important? Why hypertension control is important? If you see, if you just reduce systolic blood pressure by 10 mmHg, some patient is having suppose 170 mmHg systolic blood pressure persistently, and if you reduce his blood pressure by 10 mmHg, it leads to 20% reduction, relative risk reduction in major cardiovascular events like coronary heart disease, heart failure, stroke. Similarly, reduction in relative risk of all-cause mortality. So this is what the impact of reducing the blood pressure. Even simple 10 mmHg fall of blood pressure can reduce this much of the comorbidity. Now, the biggest problem in our patient is more you prescribe, less they will take. So adherence is big problem. In hypertension, you might have been seeing those patients not under control require 2 medicine, 3 medicine, 4 medicine, and there where the non-adherence comes. So if you see data, almost 44% of the patients are non-adherent and 17% of the patients are partially non-adherent. So big problem with the hypertension treatment is non-adherence. And it's a chronic disease. It damages the organs gradually. Patients do not have symptoms initially, and later on they develop the symptoms and complications. So rationale for renal sympathectomy. So contribution of renal sympathetic activity in development of hypertension has been demonstrated in both animals and humans. So as we know, the hypothalamus, which is a sympathetic control center, sends the overactive sympathetic impulses to thoracolumbar sympathetic system that goes to renal artery, where sodium reabsorption, renal artery constriction happens, and that leads to high blood pressure. So this is the role of renal sympathetic innervation in contributing the essential hypertension and all resistant hypertensions. That's why this pathway is targeted in renal innervation system. So as I told you, there will be sodium reabsorption and renal vasoconstriction, which will lead to high blood pressure, sympathetic activation of the system, endothelial dysfunction, inflammation, then cardiomyocyte dysfunction. These are all side effects of angiotensin, which is released in the renin-angiotensin system. So because of elevated blood pressure, there will be remodeling of the heart and vessel, glucose intolerance, atherosclerosis, ultimately leading to MI, stroke and death, all cardiovascular complications. So as I told, the pathophysiology, why renal denervation is important. If you see rationale for renal sympathectomy, the whole pathophysiology I just explained you, same is summarized here. The same thing here. Okay. Now coming to the renal denervation, how we do it. So briefly I will tell you. So renal sympathetic fibers surrounds the adventitial layer of the renal arteries. Main artery is branches. Whatever the adipose tissues around the renal artery, there are the renal sympathetic fibers. And by renal denervation catheter, simplicity catheter, we use the radio frequency energy, which increase the temperature of the adipose tissue, and it denervates the renal sympathetic fibers, and which leads to control in the blood pressure. I will just show you a few slides and how we do it. So basically, it is a minimally invasive interventional approach to achieve a reduction in blood pressure. Precisely control and targeted radio frequency energy is delivered to renal nerves with no permanent implant left behind. And you can see these are the sympathetic fibers which innervates the renal artery. This is the renal artery, these are the branches, and these are the sympathetic fibers. In renal denervation, these fibers got disrupted. So this is the animated video. At the same time, I will give running commentary. It's not playing. Excuse me.
Sunil bhai.
So the system is it's a spiral simplicity spiral catheter which has 4 electrodes, and this is the generator, simplicity G3 generator. So what we do, from the femoral artery we pass a wire through the abdominal aorta, we cross the renal artery, and these are the renal sympathetic fibers innervated to the renal artery and its branches on the both sides. This is what our target. So from the femoral artery we take a puncture, and from the sheath we pass this simplicity catheter over the wire. This is a helical catheter which has 4 electrodes, 1, 2, 3 and 4. This is 4th. So 4 electrodes are there. Once it goes into the renal artery and we retract the wire, it takes the helical shape, so that in all quadrants of the renal artery we can deliver the denervation energy. So this is the catheter we hook to the renal artery through the abdominal aorta. This is the wire, black color is the wire, and this is the catheter. We will retract the wire and it will take a helical shape, so that all 4 quadrants of the artery get a radio frequency energy through this renal simplicity renal denervation catheter. So once we pass this renal denervation energy, adventitial nerve fibers get denervated. This is the old catheter which we used to rotate by hand, but this newer catheter has a 4 electrodes, so that all quadrants get covered at the same time. So once we start from the generator, all these 4 electrodes will emit the radio frequency energy, and we can just analyze the data of each electrode. If suppose temperature go on a higher side, impedance is higher side, we can see in a G3 generator, and we can selectively deactivate a particular electrode. So see, this is the cross section. All 4 electrodes are touching to the vessel wall, and this denervation energy is delivered. So once the right side renal artery and its branches are done, we start with the procedure in left renal artery. And the same thing we do all the accessory branches, and main artery we denervate with the renal denervation catheter. So this is how this spiral helical catheter helps to denervate the all sympathetic fibers. So this is the simplicity spiral catheter. As I told you, so what is the size of artery where we can do denervation? It is 3 to 8 mm. Okay, initial the old catheters were also there, but sizes were very well, 4 to 8 mm, 4 to 12 mm. So this is for 3 to 8 mm. Easy to use, plug and play type design. Easily it can be exchangeable, and it is a non-occlusive catheter. Since it's a helical shape, renal blood flow is not compromised. Now, responsive system, as I told you, if temperatures go on a higher side, we can just selectively deactivate the particular electrode, and it causes effective denervation. Now, so 63% of the kidney has renal nerves that join distal to the main renal artery after the bifurcation. Basically, the more and more sympathetic innervation is in the distal part of the renal arteries and in accessory branches. So special thing is about this is we can just denervate small branches of size 3 mm also. So this procedure is significant and safe. There is a lot of real world data from 2017 to 2022 about effectivity and safety of the renal denervation procedure. Now I will show you the patients who were taken in the studies for renal denervation. So basically office systolic BP more than or equal to 150 and less than 180, and stable on 1, 2 or 3 medication for 6 weeks. So I will tell you which particular patients are candidate for this. Basically resistant hypertension patient. Those patients are on 3 or more than 3 medicines, antihypertensives, including 1 diuretic, and optimal doses are achieved. Such a patient who are not having controlled blood pressure, like if systolic BP is more than 140 or diastolic BP is more than 90, such a patients are candidate for renal denervation. So if you see data, 24-hour BP reduction is around 3 to 4 mmHg. In office BP also almost 9 to 5 mmHg of blood pressure reduction is there. If coming to 3 months data, there is almost 10 mmHg blood pressure reduction. 6 months data showing almost 10 mmHg reduction, and if you see 3-year data, almost 20 mmHg blood pressure reduction. So as you go, duration wise, more and more blood pressure reduction is there, and it is always on effect. Now you might have seen hypertension patient on antihypertensive drugs, but morning uprise in the blood pressure, or non-deepers who have a high blood pressure in the nights are prone for the complications like stroke, IC bleeding, heart attacks. So it has always on effect. It's not that only daytime effect, it's always on effect. So I told you that this is very safe procedure. As such, very rare complication, more or less only puncture site complication has been observed. Otherwise, no as such renal artery stenosis, renal artery thrombosis, any local complication have not been observed. Not only this, but those patients are high risk, like having resistant hypertension, diabetes, atrial fibrillation, CKD, isolated systolic hypertension, old age patient, prior MI, stroke. These high risk categories also has been studied in various registries, and it has been shown effective in those patients also. So durable blood pressure reduction, as I told you, it has always on effect, and like even after 3 years also you see the blood pressure reduction. Reason being, if you see the denervated nerve do not regenerate. Denervated nerve, once denervated, it doesn't regenerate. If it regenerates, again sympathetic activity will go high. But in case of renal denervation, it doesn't happen. This is the long-term RDN data. demonstrate durability of benefit over time. So if you see, it's a 3-year data. Almost 18 to 90 mm of blood pressure has been seen in multiple registries. So it's a shared decision making between patient preference, physician recommendation, and this is the workshop has been taken in Mumbai. Only 18 cardiologists has been invited across the India for the workshop. I was there. So this is how renal denervation is important for the resistant hypertension patient. So it's not that detailed topic, but what I want to give you a message: those patients are 3 or more than 3 antihypertensives, but blood pressure is not under control. In such a patient, renal denervation is the option, which is really effective. You can see always on effect, and over the time blood pressure reduction is good. Advantage is over the time we can reduce the antihypertensive medications and patient may become off medicines as well. And as such procedure is very safe, very less complications during the procedure. So any questions?
No question.
Okay, so I will if you are not asking the question, I will tell about some practical things. Cost. Exactly. So cost is around 7 lakhs. That is one restraining factor. Only 2 cases in the Mumbai has been done till now. One of the cases is done by me in the OCARD, and you can see more details about this. I have my interview on the Z Hidgoods program also, that is available on the YouTube. So you can see more information over there. It is covered in the Mediclaim. So it can be for the particularly Mediclaim patients, we can do these cases. Thank you. Thank you very much.
इंटरवेंशनल कार्डियोलॉजी में डॉक्टर अमित है, a cardiologist full of jest, and believe me, Mdmpa is the best.
Now I request our chairperson, Dr. R.P. Joshi sir and Dr. Suresh Bhatt sir, to felicitate our respected speaker, Dr. Amit Patil.
I also request Dr. Ayazuddin Faruqi and Dr. Doifode to kindly come on the stage and felicitate our respected chairpersons. Dr. Doifode and Dr. Faruqi.
Dr. Ayazuddin Faruqi. I request request Dr. Preeti Patre to come on the stage to felicitate our chairperson.
Friends, now we'll disperse for some time for a cup of tea.
चाय के बाद मत करना टाटा बाय बाय,
क्योंकि कॉन्फ्रेंस अभी भी बाकी है मेरे भाई।
लेक्चर अभी बाकी है मेरे दोस्त, लेक्चर अभी बाकी है।
There will be 15 minutes tea break.
सर गुड शो आप लाइव हो।
चाय मिलेगा
प्रवीण, गुड शो यू आर लाइव ऑन यूट्यूब।
I'm live on YouTube. Mdmpa rocks.
Yes.
तर म्हणाले होते झोपली होती मी म्हटलं त्यानंतर काहीतरी प्रश्न
Madam, you are live on YouTube.
Oh my God.
Congrats, President.
Thank you so much, sir.
Yeah. And past President
Yeah,
also.
thank you, sir.
Yes. अरे secretary तो main है. Yeah. चलो Congress.
सबसे ज्यादा फोन कॉल उनको और विनोद सर पे गया.
Thank you.
एक इनका ये अपनी ब्रांच और भाई हो गया
वो डॉक्टर श्याम राठी का कार्ड चाहिए था यार हेमेटोलॉजी कार्ड
कार्ड चाहिए था होंगे ना है इधर मेरे ख्याल से कहीं तो होंगे देखते हैं मिलेंगे तो ले लेंगे मैं देखता हूँ
तो हमें एनीमिया के पेशेंट बहुत आते हैं उनको रिफर करना अच्छा रहेगा
यस
बैंक वाले आते हैं ना तो उनको मैं बताता हूँ
चलेगा
शिंगन साहब आप YouTube पे लाइव हो
अच्छा
कांग्रेचुलेशन फॉर द कॉन्फ्रेंस
थैंक यू एम खान सर
कांग्रेस
थैंक यू
नहीं आज का कॉन्फ्रेंस बहुत अच्छा चल रहा है
हाँ।
और आज के जो स्पीकर्स वगैरह हैं
हाँ।
उनका जो नॉलेज है बहुत ही अच्छा है
अच्छा
और हमारे जो जनरल प्रैक्टिशनर है
तो
जूनियर सीनियर उनके लिए बहुत ही महत्वपूर्ण है और उनका होम मैसेज लेने की जैसा है और उनका जो नॉलेज आज स्पीच दे रहे हैं वो हमारे प्रैक्टिस में बहुत ही यूजफुल है एंड विल रीच सेंड दिस मैसेज एंड आवर नॉलेज अप टू द पेशेंट्स. थैंक यू वेरी मच फॉर Mdmpa इज द बेस्ट.
थैंक यू आइए यस सर
आपने जो ट्रांसमिशन किया ना
हाँ.
मैं लाइव देख रहा था इसमें.
अच्छा वेरी गुड अच्छा आपका मैसेज मैंने पढ़ा
मैंने मैसेज दिया.
हाँ लाइव चालू है अभी भी चालू है लाइव चालू है अभी अनिल भी बैठ के देख सकते
मैं
हो
भी बैठकर मैं आपका मेरे मोबाइल पे देख रहा हूँ
सेम इमीडिएटली आ रहा है ना कहीं पे भी कट नहीं
कुछ देयर इज नो ट्रांसमिशन लैग. नहीं तो कभी कभी आवाज बाद में आती है
बराबर
पहले आता है.
ओके
एब्सोल्युटली क्लियर. कुडोस टू यू.
थैंक यू सर थैंक यू वेरी मच फॉर अप्रिशिएटिंग. प्लीज वॉच चाय लेते हैं. हाँ कांग्रेस आप लाइव हो यूट्यूब पे. अरे सर आप भी लाइव हो यूट्यूब पे. डॉक्टर अरुण भूरे साहब
थैंक यू.
कंग्रेचुलेशंस फॉर योर इतने साल तक मेहनत करने का ये सिला है.
थैंक यू
हेलो सर कैसे चाय लेते हैं. अरे हाय यू आर लाइव ऑन यूट्यूब. यस अच्छा है इमीडिएटली एवरीबडी इज गेटिंग एवरीथिंग.
ये पाहिजे होते इनिशिएटिव्ह.
चलो कैरी ऑन. चाय ले लेते हैं. गुड वर्क. चलो कैरी ऑन. अच्छा मैडम भी आए हैं ना. नहीं है अच्छा ओके.
बच्ची छोटी जगह.
अरे कांग्रेस
थैंक
यू आर लाइव ऑन यूट्यूब.
हाय
डैडी को हाय बोल देना.
डैडी देख सकते हैं उधर.
हाँ Friends, thank you for watching live conference on YouTube and please continue the show and because we are already 2 hours are remaining. 2 घंटे तक अभी आपको लाइव मिलता रहेगा आपको। थैंक यू वेरी मच, थैंक यू फॉर वॉचिंग। हाँ हाँ
आप जो वीडियो लेते हैं ना उसका साइज बहुत बढ़ जाता है इतना आगे तक देखा
क्या बोल रहे?
मैं रोज टोकता हूँ कि
नदीम बाबा को बोलो।
हाँ हाँ
अभी हम लोग को भी दादा दादी बनना है यार।
हाँ
एक तरीका ऐसा है, 2 टाइम में 2 हो जाते हैं। मैटर क्लोज।
या
फैमिली प्लानिंग सब आएगा।
जरूरी है।
जॉब जिंदगी भर है, बच्चे आज के समय चाहिए। क्या करो, मैं वो उनको बोल रहा हूँ बच्चे को घर से निकाल दो, उसको लड़के को मैं अगर मैंने बोल दो अभी निकल जाओ 2 साल, हमारे पास आना ही नहीं जब तक 2 बच्चे पैदा नहीं कर।
अरे माझा फोटो घेतला
3
साल की हुई है। हाँ हमारी जो छोटी है 3 साल की हुई है, उसके कुछ लोगों का मुंह देखा तो मेरे को बोलती है नाना यू ऑल्सो ग्रो
बिस्कुट रखा है ना उधर।
वही तो मजा है। कल
बातें तो हमारे मैडम बहुत मजा
बहुत मजा
अपने को मुंडी चुप बैठना पड़ता है, सब साइड एक बाजू हो जाता है।
लेता हूँ
कभी उसके साथ चिढ़ाया तो बोलती है 3 साल की बच्ची भाई और शॉपिंग एट में नानी। आजकल के बच्चे के साथ बड़ा मजा आता है। इसे जबरदस्ती हम लोग उसको चिढ़ाने के लिए जो झगड़ा करते हैं तो आएगी मेरे पास, डोंट चिढ़ा में नानी।
बहुत धमाल है घर में आया हमारा तो बड़ा मारा कॉलेज जाए थे ना एक मारो तो
टाइम पास होता है।
वो शोले वाला डालोग है, जल्दी शादी हुई तो जल्दी बच्चे हो गए, जल्दी बच्चे हो गए तो उनके वेट नहीं किया मैंने, टाइम पास नहीं किया। सिगरेट चल
स्पीकर लोग का ले लो ना।
किसका
है? जा रहे भाई लोग।
किसका ले रहे?
ये एडिक्शन के बारे में मेरे से बात कर रहा था।
स्पीकर का
फोटो लेना है?
हमारे वीडियो में
लिया ना क्या?
मेरा इंटरव्यू लिया कि नहीं?
अरे ले बना। हेलो डॉक्टर आरपी जोशी साहब, कैसा है कॉन्फ्रेंस? आपको क्या लग रहा है?
फर्स्ट क्लास है, सब अरेंजमेंट फर्स्ट क्लास है।
अरे वाह, क्या बात है।
You all know MDMP is the
बेस्ट। यस यस
बार-बार MDMP बेस्ट बोलते हैं।
Ansab is the best.
MDMP बेस्ट बोलते हैं बार-बार। बार-बार बोलने की जरूरत नहीं है।
पंच लाइन है, पंच लाइन।
पंच लाइन अच्छा है वो, लेकिन मस्त है। चाय लेता हूँ। किधर गया चाय? बोला सर।
सरांच्या वर फोटो
हाँ हाँ
जरा बोला सर। आम्ही जर बोललेलो आहे
सर, दिस इज यूट्यूब लाइव.
Acha.
So yeah.
So I am very thankful to Mdmpa for this wonderful conference, and especially Kamble sir and all the organizers. Very good organization here. Really thankful.
Yeah, your lecture was very good.
Thank you very much.
Every speaker, today's every speaker
All
is
speakers.
speaking for the GP orientation subject,
Oriented subject.
and their knowledge is reaching to up to us. So we can send this knowledge to our needy patients. Very good, sir. Thank you. Yes.
Thank you, sir. Thank you.
हो इकडे
चाय किधर गया?
लाइट
विकी एना मानस ने लावाना
चाय दे दो, एक चाय।
थैंक यू।
तो ये कोहिनूर होटल का स्विमिंग पूल है, देख लीजिए। सब लोग अभी टी ब्रेक में सब बाहर आए हैं। जैसे टी ब्रेक ख़त्म होएगा वैसे फिर हमारा स्टार्ट हो जाएगा, वापस सेशन कंटिन्यू करेंगे। थोड़ी देर और वेट कीजिए, 10-15 मिनट और। Sir, this is YouTube live. Yes. Just say few words about our conference.
So this is a conference by Mdmpa, Andheri Medical Practitioner Association. It's a good gathering, vast gathering of general practitioners and specialist doctors who are practicing in this area. We have seen, since morning we have seen lectures, good knowledge from cardiologists, diabetologists, oncologists, hematologists, and now another session awaits us. It's going to be exciting and lot of information. Thank you.
Okay sir, thank you very much. Thank you. डॉक्टर कुणाल जैन, आप YouTube लाइव पे लाइव हैं, तो थोड़ा सा आप बताइए हमारे इस कॉन्फ्रेंस के बारे में।
This is my first time in a mini conference.
Okay.
It's very well organized.
Okay.
You can see all the big doctors of our Andheri association. It's very good to meet everybody.
Yeah.
So hoping to see everybody again in the main conference in Andheri.
Okay. Thank you sir. Thank you. Thank you. चाय उधर खत्म हो गई, आ रही है, चाय लेता हूँ अभी।
कॉफी है उधर। क्यों नहीं लिए चाय?
खत्म हो गई थी।
किसका वीडियो लिए?
सभी का पूरा चालू है अभी भी, लाइव है।
मेरा तो नहीं लिए।
ले आओ ना, तुम बोलो तुमको कैसा लग रहा है कॉन्फ्रेंस?
कैसा लग रहा है?
कुछ तो बोलो।
मेरे को ओके लग रहा है, वो खाली वहाँ बोलेंगे। स्टेज पे बोलेंगे। आप खाली स्टेज पे बोलने वाले हो। स्टेज पे बोलेंगे।
We thank Dr. M.A. Khan, the digital man of MDMPA, because he is the one who makes all these electronic things possible for MDMPA. He is the one who introduced this.
And thank you so much, Dr. M.A. Khan, for arranging such a live show. Thank you so much.
And you both are rocking.
Thank you, sir.
बन जाएगा, मास्क बन जाएगा।
बहुत दिन के बाद में लाइव है, अभी भी चालू है। या
चालू है।
हाँ
मेरे मोबाइल में।
हाँ चालू करना चाहिए, अभी भी दिखेगा लाइव, सब लोग देख रहे हैं। चाय एक चाय दे दो ना चाय।
सर आप चुटकी भी कर रहे हो या कुछ खा भी रहे हो?
बहुत ज़्यादा ही खा रहा हूँ।
गरम नहीं है, पिट्टी गरम है खाली।
हाँ चाय गरम, चाय से ज़्यादा पिट्टी गरम। मैनेजिंग कमेटी चलो। पता नहीं कि किसने डबल कॉफी लिया, किसने डबल चाय लिया,
सब मालूम पड़ जाएगा।
हेलो
लाइव चालू है। बोला काहीतरी बोलायचे? हो गया सर, तो बस थोड़ा सा थोड़ा एक
ठीक है उनको नहीं सर स्टार्ट करिए।
चलो
मेरा फोटो
Get inside. All please get inside. All. Hello, madam.
Where is Dr. Panikar?
Hello everyone. Everyone please come inside and have your seats. Now I request our next chairperson, smart and eminent practitioner Dr. Jobanputra and dashing debonair Dr. Shrikant Naik to chair our next session.
Our next speaker is famous personality in the field of diabetes, Dr. Vijay Panikar, a legend no less, and his topic is how to use insulin in practice. Sir, kindly come on the stage, please. मेरे भाई दिल नहीं खोया है सुसु की वजह से, तू रात भर नहीं सोया है।
खाना चाहते हो, अगर तुम इस डायबिटीज पे जाए, यू शुड कंसल्ट डॉक्टर पानिकर विजय। Now I request our chairperson, Dr. Jyoti ma'am and Dr. Shikant sir to introduce our speaker.
आवाज की दुनिया के दोस्तों,
बहुत अच्छा, something new.
Good afternoon. I'm sure everyone has had that 2 cups of tea or coffee.
Yes.
Fair enough. So our speaker is all ready. So let me tell you that he needs no introduction, but I think it is mandatory, sir, for all of us to introduce you because of your great personality. So, Professor Dr. Vijay Panikar for us, an MD, DNB, FCPS. He's been an honorary consultant, Department of Endocrinology, Diabetes and Metabolism, Lilavati Hospital Attachments, Guru Nanak Hospital. He's been a chairman with the Research Society for the Study of Diabetes in India in Maharashtra chapter, past president in the College of Physicians and Surgeons, a secretary associate for diabetes care and prevention, organizing chairman, of course, for RSSBI National Conference in Mumbai since November 2011, an ex-professor of medicine at KG Somaya College, and an editorial board with the RSSBI textbook of diabetes. Publications as an author of the book Healing Way of Living with Diabetes, which has been translated into 4 languages, written chapter in textbook on diabetes, chapter in medicine, which has been updated in 2008-14, and Diabetes Update 2014. Many research publications to his credit, and pioneering work on triple drug therapy for diabetes using sulfonylureas, metmorphin, powering work on the usefulness of low dose of 7.5 mg in clinical practice. Now, what more to say when we all know insulin is a must, but how to use it in practical purpose is all what we want to look after and learn from you. Please.
Thank you, madam, for a very nice introduction. But whoever has given my biodata, वो मेरे बचपन का biodata वो बचपन का है। इसके बाद में बहुत कुछ चीजें हो You know the song नींद न आए or whatever it is. साला जब इंसुलिन चालू करोगे ना, अपनी नींद उड़ जाती है। So that is where you should be able to use your insulin properly, so that your patient does not get hypoglycemia at night and he doesn't have to call you. That is the basic. So that's what came to my mind when I saw Amir Khan singing that song. Today is, it's a wonderful era actually for diabetics and diabetologists, because all the drugs which we currently use are in their generic form. The patents have gone, they are quite reasonably priced. In fact, you will find an SGLT2 and a DPP4 is cheaper than a sulfonylurea. So, we have a free hand to use these drugs in our patient. And when you treat your patient with type 2 diabetes, remember one thing, there are only 2 molecules which will cause hypoglycemia. One is sulfonylurea and the other is insulin. If you minimize the use of these 2, नींद अच्छे से आएगी. That is the most important thing that we have to see. Now, generally, I don't like speaking on insulin, though I am the main author for the National Guidelines for In-Hospital Management of Diabetes. We have authored that. We also got an app for in-hospital IV insulin management. But I generally don't like to talk on insulin because I think that is the last resort that you have to use. If you use your oral hypoglycemics very well, probably you may not need your patient to be on insulin for many, many years to come. But nevertheless, insulin insisted, No, sir, you should speak on insulin. I said, "ठीक है." How to use insulin in practice. Now, insulin is the most powerful agent which can control the glucose. There is no dose limit for insulin. You can give as much as you want till you get your sugars controlled. So it is the most powerful glucose lowering agent that we have. And this is a miracle drug which came in 1922. Look at this child. Generally, before insulin came, children used to die. Type 1 diabetics, within 6 months they would die. Look at this child. This was the child who received the insulin, the first shots of insulin. And 1 year later, this is how he was. February 23, 1923. So type 2 diabetes is a progressive disease. Why is it a progressive disease? Because insulin levels gradually will decline because the beta cells are dying. So as the beta cells die, you have less and less insulin in the body, sugars will go up, number of OHs will go on increasing, and finally a stage will come when there is not enough insulin in your body, and most of the diabetics, say 10, 15, 20 years down the line, depending on how they have been treated, will need insulin eventually. You have insulin delivery methods. The insulin syringe was the conventional method which we always used when I was a student, but today we have insulin pens. Very simple device, very easy to use, very user friendly. So, and I think all of you should get a hang of using the pen. You should keep a sample of that pen in your clinic. If you have to demonstrate it to your patient, that should be there. And I think most of these companies will oblige you with that. There are multiple types of insulin now available. You have a fast acting, that is rapid acting insulin, which is your Aspart, Lispro, Glulicense. You know, these insulins, they start their action within 15 minutes of injection. You have a peak action at 2 to 4 hours, and then by 4 hours, the action is over. There is a fast acting. You have the short acting insulin, which is a human regular insulin, which is the standard. This action starts after half an hour, peak action 2 to 4 hours, and by 6 to 8 hours the action is over. As compared to this human insulin, the rapid acting analogs are much faster in action, and they have their role in certain places. Then you have the intermediate acting insulin, which is the NPH. So this NPH is our standard, which we have been using for years together. And it's a very good insulin. Its action starts after 2 hours, peak action 4 to 6 hours. And then by 8 to 12 hours, the action goes down. That is your NPH. Then you have the long-acting basal insulins. This intermediate-acting insulin will give you a peak at 4 to 6 hours. It rises. So when you give an NPH in the morning, it doesn't act at breakfast. It will act at lunch and bring down your lunch sugar. So that is the advantage. Whereas the long-acting analogs, they are absolutely flat. There is no peak. They only supply basal insulin the way we want it. So that you have the Glargine U100 and you have the Detimel, and then you have the ultra long acting insulin, Degludec. That also, just like Glargine, will give a very flat insulin level which will take care of the basal level, and that works for almost 36 hours. Same way with Glargine U300. Works for more than 24 hours, almost 30 hours. Flat, no peak. Then you have the co-formulation Degludec with Aspart mixed together, and that can be used like a pre-mixed insulin twice. That can be used. Then you have Lispro is a short-acting analog with insulin. Aspart is short-acting analog with insulin, 30-70, 50-50. And you have the regular human insulin with NPH, 30-70. See, the advantage of the human insulin, regular with NPH, is if you give that injection in the morning, you have 30% of that which is a short-acting insulin, 70% is the intermediate acting insulin. So you have a component which will take care of your post-breakfast sugar, and you have NPH which will peak at lunchtime and control your lunch sugar. But if you give a degludec as part, degludec is flat, no peak. Only the breakfast will be controlled, post-lunch will not be controlled, you'll have to give another injection there. So our human insulin is sundar, sasta, majboot, tikau. And yes, practical, very practical. And cost-wise, degludec, it costs a bomb. It costs probably 6 or 8 times the cost of a human insulin. Even last evening I was taking rounds in Lilavati, senior citizen. उसको किसी ने तो भी ये डेग्लोडाइक वगैरह सब दिए, सर ये बहुत महंगा है, कुछ कर सकते हो क्या? We are retired people. It was done. So that is very important there. So if you look at the pharmacokinetics, I have just discussed that with you. All the different types of insulin. Now what is the normal physiology of insulin secretion? See now this is, if you see the straight line, endogenous insulin, that is your basal level. You need insulin continuously even if you are not eating. Suppose you had your dinner, at night insulin is there. That is known as the basal insulin. And what is the action of that basal insulin? It prevents hepatic glucose output. If you don't have insulin, your liver will start producing glucose and increase the blood sugar. So you need a basal insulin throughout. And with each meal, you find an excursion. With breakfast, it has gone up. With lunch, it has gone up. With supper, it has gone up little. And why this difference? See, this is Americans or Europeans have done this. They have normally a heavy breakfast. वो lunch में office में कुछ एक sandwich खाता है, and by 6:37 he comes home and has supper. उसका खेल खत्म. Whereas we Indians are eating all the time. वो breakfast क्या, lunch क्या, उसके बीच में क्या, शाम को पानी पूरी, सेव पूरी, सब फिर throughout. वो डिनर के बाद भी टीवी के सामने टिकू चालू है. So we are constantly eating. So that is why this. But what I want to show you is that with each meal, you need an insulin. So you have two types. One is a basal insulin, and each meal is a bolus insulin. So that is the basal bolus insulin. Now if you look at the time curve, this is the rapid acting insulin. Like it said, it starts immediately and the action is over by about 4 hours. वो जो 4 दिख रहा है ना, उसके level पे comes the basal insulin. This is the short acting regular human insulin. This is the NPH insulin. You know, you have the 30-70 premix, which has a regular insulin and an NPH insulin combined. 30% regular, 70% NPH. This is the glargine, the basal. So basal level is maintained throughout. There is no peak there. Now the question is, when do you want to start insulin for your patient? Obviously, if he comes to you with a very high sugar. And at diagnosis, I have seen, last evening I saw a young boy, just 24. He's come with 580 sugar. But he has got no ketones, he's got nothing. But we have initiated him on a small dose of insulin along with the OH. Because such high hyperglycemia should need an insulin initiation. Hyperglycemia in spite of full doses of oral hypoglycemic. सब देखे हो गया और शुगर ही कंट्रोल नहीं हो रहा है, then you have no option but to start insulin for them. There are certain decompensation situations like acute injury, stress, infection, myocardial infarction, hospitalized patient, ketoacidosis, hyperosmolar states. If there is an uncontrolled weight loss with hyperglycemia, And if there is use of corticosteroids, any steroids is going to increase the blood glucose very rapidly, and it may not be able to be controlled with just OHAs. You will need a temporary use of insulin at that period of time. Then again, patient going for surgery, especially where you has to be kept nil by mouth for some time, those are the patients where again you need to be on insulin. And pregnancy is one indication where insulin is the gold standard. And in that also the gold standard is human insulin. Though now Aspart and Lispro are approved for pregnancy, Glulysin is not approved for pregnancy. Glargine and Degludec till recently were not approved. Degludec is not approved. Glargine has been given a class C approval for pregnancy. So when it comes to pregnancy, we still prefer human insulin conventional. So what should be your glycemic targets? Basically, you are looking at an HbA1c below 7 in most people. If you have a young guy, you might get it down to 6.5. But if the person is elderly, he has got comorbid conditions, so heart ka problem, kidney ka problem, then even 8 is okay, 8.5 is okay. I mean, you have somebody who is 85-year-old, like last evening I saw 85-year-old gentleman. I mean, you should not go for very aggressive control there, because at that age, hypoglycemia would be more dangerous than hyperglycemia. If his sugars remain a little higher, he will get the complications after 5 years. He is 85. Dekha jayega. But if he goes into hypoglycemia, he will get complication immediately at that age. So that is something that you have to be careful. Now when you talk of the fasting blood glucose, ideally it is 80 to 130 is your target. But when you are going to adjust your insulin level, you take the fasting target as 100. I want to achieve a target of 100. And when you talk of 2 hours postprandial, it is again 130 to 180. That is your range in which you are going to play. But when you are adjusting insulin dose, you take it as 150. So 100 in fasting, 150 in 2 hours post-meal. Key clinical consideration, what should be the starting dose? At what time of the day should the insulin be administered? See, obviously insulin, if you are giving just a basal insulin, a long-acting basal, nothing else, you can give it at any time. But keep the time fixed. Because see, the action of these long-acting basal is almost 24 hours. You can give it in the morning, afternoon or evening. But whichever time you give, keep that time fixed. Suppose he is taking it at 10 o'clock at night, every day it should be 10 o'clock at night plus minus 1 hour. But ऐसा नहीं कि आज रात को दिया, कल सुबह दिया, परसों रात को दिया. No. Then the cumulative effect of that insulin will come in. When you talk of pre-mixed insulin, and as far as you are concerned in your practice, I think pre-mixed insulin would be the insulin for you to use. This basal bolus and all these things are fancy. You have to be very simple to understand, simple to teach your patient. So pre-mixed insulin, I will tell you how to do it in due course of time. And this pre-mixed insulin is generally given twice a day, about ideally half an hour before breakfast and half an hour before dinner, ideally. But that becomes difficult. So 15 minutes bhi chalega. But give it before the meal. And which device to use? A pen device is the best, very simple to use. वो syringe डालो, उसमें air डालो, बाटली में निकालो. And nowadays the insulin syringes, these pens are available free of cost from the companies. So whoever representative is coming to you, take his number, he will supply it to the patient free of cost. That's what they do with my patients. So that is not. Otherwise, if they go to buy, it costs anywhere from 800 to 1300 rupees for the pen. So you should keep a sample so that you can teach the patient how to use the pen. Very simple. कुछ उसमें ये नहीं है. How to inject? Basically, the best place to inject is the abdomen. Umbilicus के उधर 1-2 इंच छोड़ दो, and rest of the thing is like a football ground. किधर भी shot मारो. कोई problem नहीं. You just have to pinch like this and lagao. And every time they should do it at a different site. That is what is most important. How to adjust the dose, I will tell you. But whenever you talk of giving insulin to your patient, there are barriers. The moment you tell the patient कि इंसुलिन लेना है, अरे आई नो वन लेडी से मैं मर जाऊंगी पर इंसुलिन नहीं लूंगी. अभी इसको क्या बोलेंगे? मैं बोला बराबर बोली. हाँ, मैं मर जाऊंगी पर इंसुलिन नहीं लूंगी. मैं बोला देख, तुम्हारा और मेरा मरने का डेट है ना ऊपर वाले ने फिक्स किया है. अभी मैं चाहता हूं आप मरने तक जरा जियो. तो क्या फायदा? आग गई, किडनी गई, पैर काटे और इंतजार कर रही है कि कब वो लेके जाएगा मेरे को. वो नहीं होना चाहिए. इसलिए मैं आपको इंसुलिन दे रहा हूँ. मेरे को कोई खुन्नस नहीं है तुम्हारे पास. ये आपके सेहत के लिए अच्छी है. आपके शरीर में इंसुलिन नहीं है और लेना है. दैट इज हाउ यू नेवर बी नेगेटिव कि अरे इंसुलिन नहीं लेगा तो मर जाएगी, ये ले. वैसा दम देके उसको साइक नहीं कर देगा. बी पॉजिटिव कि यार इसका फायदा है. आप है ना मरने तक हंसते खेलते जाएंगे, फिर मरने के बाद क्या फर्क पड़ता है. तो दैट इज व्हाट इज इम्पोर्टेंट.
जिंदा है साले मरे नहीं, जब मर ही गए तो हम ही नहीं.
In the mind of patient and doctor, दोनों. But basic fact remains that what is diabetes is the lack of insulin. So what are the patient barriers? वो patient को लगता है इंसुलिन आ गया है, लास्ट स्टेज आ गया मेरा. Yes. यानी अभी मैं that is what they really think, you know, कि तो you have to explain to them, नहीं रे बाबा ऐसा कुछ नहीं है. आजकल शाने लोग 85-90 के पहले लुढ़कते नहीं हैं. और उनके पास पैसा है तो डॉक्टर लोग उनको लुढ़कने नहीं देते. This is the ground reality. तो लियो hypoglycemia. Hypoglycemia is a real fear. And if your patient has experienced an attack of severe hypoglycemia, then he becomes very defensive. He doesn't want to experience it again. तो वो खुद से डोज कम कर देगा तो शुगर कभी कंट्रोल ही नहीं होगा. या तो he is eating, defensive eating कि hypoglycemia नहीं हो and he puts on weight. So these are the problems which you have. So you have to be very careful how you initiate insulin, how you control without giving him hypoglycemia, but at the same time explaining to him what is hypoglycemia, what are the symptoms of hypoglycemia. कि जब शुगर कम होता है तो तुमको जरा धड़धड़ होएगा, पसीना छूटेगा, शिवरिंग आएगा. ऐसा कुछ हो गया तो समझो कि शुगर कम हो रहा है. अगर मशीन है तो चेक करो, मशीन है तो नहीं, लेके रखो मशीन, चेक करो और कुछ मीठा खा लो और कुछ ऊपर से कार्बोहाइड्रेट दूसरा भी खा लो और मेरे को बोलो, फिर मैं डोज कम करूँगा. सिंपल. सो whenever you are initiating a patient on insulin, you should be contactable. वो है मेरे दोस्त लोग सब साला फोन नंबर ही नहीं देंगे पेशेंट का. हाँ, अगर फोन करेंगे तो उठाएंगे नहीं. अरे मैं जब फोन करता हूँ उनको तो नहीं, उनका सेक्रेटरी उठाता, डॉक्टर बिजी है, पेशेंट देख रहा है, बाद में फोन करो. No means, see, if you are going to take the responsibility of treating your patient, it is your responsibility to see that he is available. Yes. No question. See, we are in a profession where we have to be accessible. And I will tell you one thing about me, you can ask Sonali. I always pick up the phone even at 2 o'clock at night. Because अगर कोई पेशेंट मेरे को रात को 2 बजे फोन कर रहा है, वो मेरे को सताने के लिए नहीं फोन कर रहा है, उसकी फटी पड़ी है इसलिए फोन कर रहा है. और तब अगर मैं उसको हेल्प नहीं करूँ तो क्या फायदा? I mean, this is the ground reality. So explain hypoglycemia and other thing. Weight gain. देखो, anybody whose sugar is not controlled, he is going to lose weight. There is no question about it. Alright? And once his sugar gets controlled, whether it is with insulin or with OHA, he regains that lost weight. And if you over control the sugar, he is getting hypo, so he overeats, he can put on weight. So weight gain is a factor there, but nothing major. Injection will hurt. See, I will tell you, our Indian psych, साला इंजेक्शन से डरते हैं, क्योंकि बचपन से उनको ऐसा करके रखा, तू नहीं सुनता ना, तेरे को इंजेक्शन देगा. This is how we have been brought up. समझे ना, कि थोड़ा बहुत बदना है, इंजेक्शन देगा तेरे को, डॉक्टर के पास ले जाके, तो बच्चा डॉक्टर से भी डरता है. So that is our psyche. The moment you say injection, उसको तो कुछ तो ऐसा फोबिया हो जाता है. That is where you have to show him, अरे यार वो, and he thinks injection है, दे बड़ा सुई घुसा देगा. Show him it's a 31 gauge Teflon coated needle. दिखता भी नहीं. So that is how you have to. The other thing is, पब्लिक में मैं कैसा इंजेक्शन लेगा? मैं बोला पब्लिक में तुमको लेने का क्या कोई है? तुम घर पे रहो. पब्लिक में देना नहीं डॉक्टर साहब, वो क्या है ना, अपन कभी शादी में जाना पड़ता है तो क्या, अरे शादी उधर डिनर 8-9 बजे होता है ना, तुम 7 बजे जा रहे हो ना, घर से लगा के जाओ ना, एक थोड़ा स्नैक ले लो, थोड़ा डिले हो जाएगा, उधर खा लो, कोई प्रॉब्लम नहीं. एंड इसका भी एक एडवांटेज है, मैं एक कॉन्फ्रेंस में था, कहीं तो था, वो खाना ही रेडी नहीं हो रहा था. तो मेरे दोस्त लोग सब थे, एंड वी वर हैविंग अ स्मॉल वन. बोला सारा कुछ स्नैक्स नहीं मिलता. मैं बोला मैं लाता हूँ. मैं अंदर गया, उस शेफ को मिला, मैं बोला बॉस आई एम डायबिटिक, मेरा शुगर लो हो रहा है, कुछ बंदोबस्त करना. उसने मस्त बंदोबस्त करके लाया. तो this is right. You have to. Now at the physicians, starting insulin is too complex. सच्ची बहुत बार मेरे दिल में भी आता है, अरे इसको किधर में भी सिखाते बैठो, 15 मिनट जाएगा उसमें. But fortunately I have got assistants who do the thing. But that is the most important thing. Starting insulin complex, उसको समझाओ कैसा लेने का, कब लेने का, पेन से कैसा लेने का, कार्ट्रिज कैसा चेंज करने का, नीडल कब चेंज करना है, उसमें 15-20 मिनट जाता है. But that is what is required. Again, you have to teach him about hypoglycemia, weight gain, and
Panikar sir,
if you still can't do it, then you have to refer it somewhere. But it is very easy to do it.
मैं तो पहले बोल के आया हूँ इनको.
So basically, you have to educate the patient that injection is not painful, and believe me, it is not painful. कुछ नहीं है. Once the patient takes it ना, मेरे पास एक बच्चा आया था 12 साल का, टाइप 1 डायबिटिक, एंड द मोमेंट आई सेड इंसुलिन एंड ऑल दैट, वो बच्चा तो रोने लगा. एंड ही हैड टू टेक बेसल बोलस 4 times a day, 1 basal and 3 bolus. I said no, मैंने the mother is again very protective. ना मैं दूंगी उसको, वो नहीं लेगा. मतलब कुछ नहीं, आ जा बैठ. बच्चों क्या डरपोक है तू. उसके हाथ में दिया, मैं बोला लगा. वो लगाने के बाद वो स्माइल कर रहा. अंकल मैं करूँगा. Because I tell you, this type 1 kids are very smart. They only need your support. They don't need your sympathy. So it can be done. So give the first injection by.
Sir, time is over.
Time is over.
Yeah.
Thank you.
Sir, you can continue.
You can continue.
Sir, you can continue.
मैं जल्दी कर देता हूँ.
हाँ सर.
नहीं, मैं अभी आपका इसमें डोज कैसे कैलकुलेट करने का ये सब छोड़ो यार, टाइम पास है. देखो, दिस इज वन केस. ही इज ऑन ऑल दी OHs and his fasting sugar is 200, postprandial is 180. So his postprandial is within the range that you want. His fasting is high. He is an ideal patient to give a bolus injection. And so you give bolus, you forget all this formula. You look at, see, 1 unit of insulin will bring down 20 milligrams of glucose. His sugar is कितना था वो पहले?
200.
हाँ, 200. तो you want the fasting 100. 200 minus 100 is 100. Divide by 20 is 5 units. तो उसको 5 यूनिट देना और फिर 2-3 दिन बाद वापस देख के ले और क्या ज़्यादा टेंशन नहीं लेने का जो फॉर्मूला विर्मिला सब रहने दे अपने ओके दिस इज बेसल बोलस आई वोंट वेस्ट योर टाइम ऑन बेसल बोलस प्री मिक्स्ड सेम फॉर्मूला वर्क्स see now this is fasting is 200 postprandial is 270 तो उसको 200 minus 100 तो 5 units you will give before dinner of the 30-70 उसमें brand names are mixtard है Huminsulin है Lupisulin है Exulin है Insugen है so you will give 5 units before dinner his postprandial is 270 your postprandial target is 150 so it is 120 का difference है divide by 26 units so you will start with 6 in the morning and 5 in the evening. After 3-4 days do a fasting and post lunch. उसमें जितना ज़्यादा या कम है वो see if the fasting is less than 80 reduce 2 units. If fasting is 160 you add 3 units to whatever the previous dose night में था. Your post lunch less than 70 reduce 4 units in the morning. If post lunch is 80 to 120 reduce 2 units because your post lunch target is 150. If it is 190 तो वो फॉर्मूला वापरो फिर 150 के ऊपर एंड 2 यूनिट्स लगा दो. These are the insulin devices. ये सब छोड़ो पंप भी है बहुत महंगा है. डायबिटीज अ प्रोग्रेसिव डिजीज एंड इंसुलिन इज रिक्वायर्ड. कुछ इसमें टेंशन नहीं लेने का. But keep a pen device with you, keep a glucometer with you, so that you can teach the patient how to take the insulin, where to take. And इसमें if somebody doesn't know how to use the pen, अरे YouTube में videos 10,000 है, उसमें का अच्छा वाला देखना. Thank you.
Thank you so much. Definitely, I was asking for the standing ovation. तालियों ने इतना बता दिया कि मुझे बोलने की जरूरत ही नहीं रही. But sir, your lecture is not only simple, but it's also smart and entertaining. इससे कहते हैं कि जिंदा रहना जिंदा दिली का नाम है. In the field of diabetes, Dr. Panikar sir is great, and believe me, Mdmpa is the best. Thank you.
Thank you so much, sir. Now we all must know that along with the dosage of insulin, what we must know is creating a rapport with the patient. That is where your humor comes into the picture, sir. And I think that is what we should all learn from him. Books teach us a lot of things, but what he is teaching us is very, very valuable. Thank you very much.
Now I request our chairperson, Dr. Jyoti and Dr. Shrikant, to felicitate our respected speaker, Dr. Vijay Panikar sir.
I also request the gentleman of Mdmpa, Dr. Amit Patil and Dr. Nikhil Gurjar, please come on the stage and felicitate chairpersons.
Thank you very much. Nowadays, I am very scared to come and give lectures anywhere. क्योंकि few months back नासिक गया था, साला गिर गया और टांग टूट गया. I have just recovered from that. So, thank you anyway. It was great.
Thank you, sir.
Dr. Anil Malani, kindly come on the stage, please. Dr. Anil Malani. Dr. M.A. Khan, both of you, please felicitate our chairpersons.
Thank you so much, everyone. Now we request our next chairperson, our past president of Mdmpa and ever energetic Dr. Avni ma'am, and our hardworking member of Mdmpa, Dr. Rajesh Jathar, to come on the stage and chair the session.
Thank you.
Our next speaker is ever talented Dr. Abhijit Kale, whose topic is recent advances in joint replacement and spine surgery. Sir, kindly come on the stage, please. घोड़े जैसी नहीं है चाल, जॉइंट पेन की वजह से हुआ है ये हाल.
होगा ऑस्टियोपोरोसिस, पर करना पड़ेगा तुझे ठीक है यार. You have to consult Dr. Abhijit Kale यार.
Thank you for that lovely introduction.
Thank you, sir. Just. Now I request our chairperson to introduce our respected speaker, Dr. Abhijit Kale, sir.
You must have heard that song, that मुसाफिर हूँ मैं यारो, मुझे चलते जाना है, बस चलते जाना. तो अब ये सर्विस है, चलते चलते हो जाए दर्द में, दर्द हो जाए घुटनों में ऐसे, तो और तो प्लैनेट चले आना. Now next to Avni madam.
Hello. Actually, sir doesn't need any introduction, but still, Dr. Abhijit Kale sir has done his MBBS from St. GS Medical College. He stood first in MS Orthopedics from LTMG Science. He also stood first in FCPS Orthopedics. He was awarded for the video presentation in American Academy of Orthopedic Surgeons in 2009. He is Associate Professor in the Department of Orthopedics in LTMG Hospital and Medical College. He is having his clinic at Kohinoor Square, Dadar, also working with Saifi Hospital and Raheja Hospital. He is Chief of Regional Organ and Tissue Transplant Organization. Also, he is Chief of State Organ and Tissue Transplant Organization. And he is the Vice President of Paraplegia Foundation, Science since 2017. Over to you, sir.
Thank you for that lovely brief introduction. Without much of ado, I will take you through the glimpses of the recent advances in joint replacement and spine surgery. If you look, the most commonly replaced joint in the human body is the knee joint, followed by the hip and finally the elbow. What about the knee replacement? Knee replacement can broadly be divided into primary, complex or a revision surgery. Now, this was a 73-year-old retired government servant. He had a bilateral knee pain, more on the left side. This pain was aggravated on standing. He was unable to sit cross-legged or squat. So when the patient presents to us, the first thing that we do is a single leg stance view. And then once we are sure that it's arthritic, we take him up for this replacement. This surgery is done under spinal anesthesia. If you can compare the cartilage on this and this side, here it's totally worn out. So that brings about the bone and bone arthritis, and that brings in a severe pain. Now this is the jugglery that we have on the table. These are something like the shirts, the ready-made shirts that we have. And just as we check which size suits us the best, 38, 40, 42. In a similar way, we check which of the femoral trials will suit in here the best. So we have the femoral trials, we have the liners, and we also have the tibial tray. So the size which fits the best, we go in with that. And once the final one is put in, this is how the joint looks like. So we have the femoral component, the tibial component, and a polychynin in between. And that's what it looks like. Now you can see a symmetrical gap on both the sides. Now there is no bone on bone touching each other, and this is what relieves pain. And you can see his gait. At the end of 10 months, you can see that the patient is walking comfortably without any support. Usually, after the initial period of 4 to 6 weeks, no support in the form of a walker or a aiding stake is required. Now that's another case. You can see the amount of varus. Classically, osteoarthritis will lead to varus, whereas the rheumatoid arthritis leads to valgus. So genu varum, genu valgus, you can see the degree of varus. All the joint, the cartilage is fired. You can see when it's open up. Can you see the status of the cartilage? No drug in the world can help this. No injection, no physiotherapy, no brace can do any wonders. The only way is to get rid of this cartilage and replace it with the best one available. So this is all the cartilage and the subchondral bone that is removed, and you can see that before the trials are put in, you have to create a shape into which it can be fit in. There are certain geometrical shapes into which we have to put it. If there is a defect, then we have to support it with a stem extender, or else the weight bearing will not be uniform. So that's how again it looks like after it has been cemented. Here you can see that the varus is also corrected, the patient has a good movement and also a stable joint. Now all these systems are done in a operation theatre which has a laminar airflow. All aseptic precautions are taken. Now this was a 74-year-old OT sister in charge who had come down from Nagpur and worked at Nagpur for 3 months before joining residency at Sion Hospital. So she had a bilateral knee pain. You can see the difference here is the lateral joint space is decreased compared to the medial side. So if the lateral is decreased, it's always think of rheumatoid arthritis. Always think about inflammatory arthritis, some form of inflammatory arthritis. Vis-a-vis, if the medial joint space is decreased, it's invariably a degenerative. This applies for 90% of the cases. Now here you can see a classical valgus deformity. But you can see the good part about this deformity is the patient is now under anesthesia. You can see the correction. The ligaments are lapsed. So without doing any soft tissue release also, it's getting corrected. So depending upon whether it's a flexible valgus or a rigid valgus, the cuts are planned accordingly. And this is when we went down, you can see that the lateral is more degenerated. Again, we take the necessary cuts and then the final implant is put in. You can see that on the second day of the surgery, you can see that the drain is still there. Both the knees have been done simultaneously and patient can walk with support. And this is the follow-up at 4 months. You can see now whatever valgus we had presented with, now it has come back to genu rectus. We have collected the mechanical alignment of the knee. You can see a well-balanced knee. So that's roughly the expenses for the knee replacement. Now slightly a complex case. Now patient have a tendency to run away from the surgery, just as Panikar sir was explaining how patient tends to run away from insulin. So this patient had a knee arthritis and hoping against hope they will try to go through all the possible options, medicines, injections, braces, massage. And this patient also tried with a high tibial osteotomy, where you can see that a stapler is put in, but now you can see in the pre-op x-ray, there is a bone-on-bone arthritis, the patellofemoral joint is also worn out. So it's a tri-compartmental osteoarthritis of the knee. Range is restricted. So the first thing that we have to go down is remove this stapler. All this is done in one stage. She underwent a bilateral knee replacement because if you don't remove that stapler, it will come in the way of your implant. So after the stapler is removed, then you take the cuts. And you can see this is something new, the gold knee. It's coated that way. So basically it's an inert material, and it has some patients after surgery complain of घुटना गरम रहता है. So that's because of the temperature difference, a kind of a foreign body reaction. But with this new coating on the implant, the incidence of that घुटना गरम रहता है has gone down. Now this implant is in the market only for last 6 years, so we don't know how long will this last. But the old one, the titanium based one, the survival at 20 years is close to 95%. Knee replacement surgery is often described as the most successful surgery in the human history. And here you can see a good alignment in the post-op X-ray. Patient underwent a bilateral single-stage knee replacement. And you can see her walking at the end of 2 months. She's walking comfortably without any support. Now, after knee replacement, the second most commonly replaced joint in the body is hip replacement. Hip replacement again can be primary, complex, or a revision. Now, this patient was a 42-year-old female. She had a tuberculous hip arthritis. She had taken a EKT, and for 10 years she was walking with a limp. Can you make out? She has a shortened limb and a stiff limb. So for her, doing activities of daily living is very challenging. Here both the femoral head and the acetabulum is fired. You can see this is the acetabulum socket, and this is the newly replaced socket. So this is the titanium socket, and we have put in a ceramic liner inside it. And here you can see that is the thigh bone, the femoral bone. So here the femoral stem is getting in. Now this has been sewed in completely, and once put in, we put this femoral head. Again, this is made up of ceramic, so it's a ceramic on ceramic liner. So post-op, that's the post-op X-ray. We have been able to restore the hip biomechanics and also the length. Now, this was a case of avascular necrosis of the hip. There are many causes for avascular necrosis. The commonest among them being alcohol intake, tobacco intake, or at times overuse of steroid. We have also seen a high incidence of avascular necrosis post-COVID, probably because of the people believe that the COVID virus interferes with the endothelial lining, predisposing to the embolic phenomena. Now here you can see that the avascular head has come out. It's all sclerosed. It's a kind of a cauliflower shape. It has lost its cartilage. And now here what we have used is a dual mobility liner. So this is the acetabulum socket. You can see the screw hole here. Through this hole the screws will go in and fix into the ilium bone. Into this acetabulum socket we will put this liner. Into that will go a second liner, which is a polyethylene liner, and finally the femoral head, the ceramic head. So this is a dual mobility. This is a dual mobility liner. What is the advantage of the dual mobility over the conventional one? Patient can sit cross-legged. Patient can squat. So that's a dual mobility total hip replacement. Now this was a 40 years old female who had undergone a hip replacement surgery elsewhere. And she presented to us 5 months after surgery, and you can see where is the native acetabulum and now where the acetabulum has migrated. This occurs if the patient has an underlying osteomalacia. The bone quality is not good, or probably the medial wall is overrimmed. The support, the quadrilateral plate which gives the support to the acetabulum, if that's broken, the acetabulum will keep migrating in till it hits the sacrum. So the first thing that we do is get a CT scan done, check the femoral vessels in relation to the implant. And here we went down, you can see here the acetabulum cup is lying here. We got that out. Now these are the acetabulum reamers. We have to sequentially increase the size of the reamer. The posterior column was broken. The posterior column of the acetabulum is the weight bearing column. So we have put in a plate here. We have put the trial, and you can see that there is still a big defect. And the difficult part is patient has to weight bear. So if you leave any dead space, any defect, patient will be unable to do that. So that is where these augments come into picture. These are the antennum augments. This augment cost about 1.5 lakh rupee, but they integrate into the bone. So you can see this augment has been put in. You can see the plate on the posterior side, that is the trial liner, and some screws going through the augments. Now some area we have filled in with the bone. That is the bone we get from the bone bank, and then we have put in an acetabulum liner along and cemented it. So this is what the pre-op is, and this is what the post-op looks like. So you can see we have got the acetabulum back to the native level, the plate has been put in, and that's the augment in place. Now we also do sometime replacement in tumor cases. Now this was a patient who presented to us with a fracture shaft femur, and she was advised nailing at one of the places. But when we went through the X-ray, this is not a standard looking X-ray. You can look at the shadows inside it. So the first thing that we did was an MRI followed by a biopsy, and it turned out to be chondrosarcoma. So fixation goes out of question. Age 65. So that's the chondrosarcoma. We have excised along with the femoral head. And now here we get something that are known as the tumor prosthesis. So this part goes into the medullary canal of the femur, and this will now serve as the upper half of the femur. And this is what it looks like once it goes in. That's the acetabulum cavity. So this bipolar head will go inside, and this is the excised part of the tumor which has been replaced with the tumor prosthesis. And this is what it looks on the X-ray. Patient is able to wet beer after this. A word about elbow replacement. This is something rare, but we have been doing elbow replacement. Now this patient had come from Indore. These initial X-rays are of the treatment taken in the central part of India. So in June 12, he had a fracture of the supracondylar humerus for which a plating was done. However, it got infected, and this plate was removed. And then he was back to square one. Then one of the surgeon over there attempted a total elbow replacement, and this was done in March 2014. In March 17, this was the X-ray, and you can see now that the implant is all loose. There is all the lysis around the cement. And he presented to us in April 18 with this X-ray. You can see that the humeral stem has walked out. There is lysis all around, and he has a discharging sinus, which is a definitive sign of infection. So we planned a two-stage. First stage, we go down, we remove this implant, we remove all the debris, the cement, all the infected granulation around. Once it's removed, you can see this is what it looks like. Now we fill the dead space with a spacer. Stage 2, after 3 months, we go down, and now this is the Conrad Moose prosthesis, the revision prosthesis which was put in. Now these are the antibiotic bits that we get. These are calcium phosphate bits into which we can put a heat stable antibiotic which will release the antibiotic over a period of 6 weeks. This is a latest form of antibiotic local delivery system, and you can see a revision replacement, elbow replacement, and he had a good functional range of movement at the end of 1 year. These are the space suits which we use. It believes that they decrease the sepsis rate. We move from the joint replacement to spine surgery. One of the commonest problem in the spine is the disc prolapse. And disc prolapse in the younger age group are common in the lumbar region. You can see here a big disc. This is the disc which has sequestrated. It has come on the right side. You can see this is the spinal cord, the quadrispinal nerve root. This is the traversing nerve root. The traversing nerve root on the right side has been compressed because of this sequestrated fragment of the disc. That's basically the nucleus pulposus along with a part of the annulus fibrosus. And you can see we have been able to remove it through a very small incision. So pre-op, this was the MRI, and you can see post-op a good canal clearance. We have been able to remove the sequestrated disc. So we need not remove the entire disc. The disc which is encroaching into the spinal canal, which is the culprit for the symptoms, only that needs to be removed. Now that was the MIL disc which you see. At times we also do an open disc. Now this patient has, you can see a big disc. Here you can't even make out where the dural sac is. Now this patient presented to us with cauda equina syndrome. He has lost the control over bladder bobble. He has developed impotence. Now here cosmesis will not take a priority. Your function has to take a priority. So we go down, take a big incision, we do a wide laminectomy, remove the part of the facet and remove the entire disc. And it's only over a period of time that they are able to regain the functions. Now this is a case of spondylolisthesis. You can see this is the sacrum and this is L5. Here there is a break in the pars and this has gone forward. So this patient presents with a chronic backache. Chronic backache because of instability. The moment they sit, the pars will toggle, and that's the culprit for the pain. The first thing that is done is MRI. Body has a defensive mechanism and it will try to hit that pars by fibrosis. This fibrosis will eventually engulf the nerve roots and patient will develop a radiating pain. So this patient has a low back pain with a radiating pain. So what we do is we go down and put in 4 screws. You can see that the cord has been decompressed. The disc is removed and this is the artificial disc that we put in. This is a titanium cage and we have filled it with a graft. So this graft will go in, we'll check it under CM. You can see that the screws along with the cage. And this patient post-operatively, this is how it looks like. We have been able to reduce the listhesis, we have been able to recreate the disc space, and you can see a nicely put in screws, and those are the post-op staplers. And eventually this patient, they do well on follow-up. You can see a walking video at the end of 5 months. Sorry. Now, this was a 39 years old male who had presented with tingling and numbness in both the upper limbs. The first thing that is done is a cervical spine X-ray. We also do a bending X-rays to rule out instability. When an MRI was done, you can see that there are big discs. You can see the amount of disc that is pressing upon the cord, that's the brain. So at C4, 5, C5, 6 level, there is a big compression. So this patient presents with upper motor neuron symptoms. They have spasticity, they have hyperreflexia. At times they are unable to do fine motor activities. And so we have gone down, we have removed the disc from the anterior side, and these are the cages that we put in. These are along with the titanium cages. Now instead of taking a bone graft from the rib or from the iliac crest, we use this artificial graft. You can see this is the cage through which these 2 screws will go in, and this is the graft. The artificial bone graft which will eventually osteointegrate. And here you can see we have removed 2 discs and supplemented it with the latest implant. And this patient is now just 8 days post-op. But he is able to do activities of daily living. He is given a cervical collar for up to 6 weeks, and eventually that's taken off. Now this was a patient who had climbed on a mango tree during the season to get the mangoes, but rather than getting the mangoes, he fell down and he landed up with a fracture of the C6 body. He presented with quadriplegia. He has lost now the motor function in both the upper and the lower limbs. So you can see the fracture fragment over here. We have put in these Casco pins. We go down and remove the vertebral body. And this is the artificial disc cage along with a plate through which the screws will go in. So again we have decompressed the spinal cord, and this is how the cage has gone in. We have a Shyam in the OT through which we keep checking whether we are in the right position or not. Now this was a case of tuberculosis of the spine, very rampant in our country, in our community. You can see here it's pressing on the cord and causes a paraparesis, that is the D6, D7 lesion. And when we went down, you can see that the tuberculous pus is coming. We have decompressed the canal. This is the pus which is coming out, which will be sent for histopathology, for drug sensitivity. We do all the 14 drug sensitivity, and depending upon which tubercular drugs are sensitive to it, we'll be giving those drugs. So it's all about evidence-based medicine. Can you see the amount of pus and the granulation tissue, the amount of pus that is flowing out? So this is what it looks like. We have put in the screws, we have put in the rods, the cord is decompressed, and we have put in a cage. Whatever dead space was created anteriorly, we have to supplement it. That's what it looks like at the end of 1 month. Another case, again a case of tuberculosis. Again this was fixed in a similar way. The patient had come down for follow-up study, and you can see how comfortably he is able to walk after completing AKT. Just even try to appreciate his bending movements. Don't think that once the rods are put in, so you develop a stiff spine. No, that's not the case. See, science never fails. It is only the application of science which fails. If you apply it properly, you will be able to give the results. This was another case of tuberculosis of the spine. You can see that the spine is going into kyphosis. Here it's going into scoliosis. So he is developing a kyphoscoliosis deformity, again because of tuberculosis. You can see the lesion over here. All the vertebrae is eaten. Again we go down, we put in these cages, and then they are rewarding. But you have to give them complete 12 months of AKT. Surgery is not a substitute to medical line of treatment in tuberculosis. Surgery is an adjuvant. So surgery plus right chemotherapy will work. So what are the advances which have taken place about joint replacement? The surgeries, they have become less morbid. The joint replacement prostheses are now more long lasting. The hospital stay has gone down to almost 3 or 4 days. And the capping on the implant pricing by the government of India has made this surgery very much affordable. About the spine surgery, now we can even do keyhole surgeries. Patients are able to return back to work at very early age, and we have got good materials which matches the modulus of elasticity of the bone. Now, besides the spine and joint replacement, we also promote bone donation. You all must have heard about blood donation, kidney organ donation. There is something also about the bone donation, and I am heading this Government of India West Zone region. So we do harvest bone, and we have harvested about 12 bones from the cadavers of brain dead patients. Whenever they get a call to harvest the heart, liver, kidney, we take a consent even to harvest the bone. But in the body there are 206 bones, and we can't harvest all 206 bones. The principle is not to deform the body. You have to respect even the dead bodies. And only those bones which will not affect the contour of the body, those are removed and sent to the bone bank. We have a bone bank at Tata Hospital. So that was in short about the joint replacement.
Friends, for the TKR, don't search east or west. Contact Dr. Abhijit, and believe me, Mdmpa is the best.
Now I request our chairperson, Dr. Avni ma'am and Dr. Raja sir, to felicitate our speaker, Dr. Abhijit Kale sir.
Now I also request Dada Muni and Danshur Karan of Mdmpa, Dr. Shingan sir, and Dr. Renu Budhwani to kindly come on the stage and felicitate the chairpersons.
दोनों सही कैंडिडेट बन रहे हैं।
कांग्रेस सर।
Now I request our grassroots worker of Mdmpa, Dr. Satish Parshikar, and chocolate boy Dr. Michael Anthony to chair our next session.
That's the chocolate.
Now I request our next speaker, eminent cardiologist Dr. Rahul Gupta, whose topic is long-term ischemic protection in post-MI patient. Sir, kindly come on the stage, please.
सीने में जलन, आँखों में तूफान सा तू है। सीने में जलन, आँखों में तूफान सा तू है। इसी शहर में हर शख्स परेशान सा तू है।
नहीं है तू परेशान सा, ये है सिम्टम पोस्ट एमआई के कॉम्प्लिकेशंस का।
अगर एमआई के बाद भी कुछ तुम्हारे दिल में हो चुकता, यू हैव टू कंसल्ट डॉक्टर राहुल गुप्ता। Now I request our chairperson to Dr. Satish and Dr. Michael to introduce our respected speaker, Dr. Rahul Gupta sir.
Dr. Rahul Gupta sir is a cardiologist and head of the unit at Apollo Hospital, Navi Mumbai. He is the director of Cardium Advanced Heart Care Center. He has expertise in complex coronary interventions. He has done the highest number of TAVI cases in this area. He is also trained in renal degeneration therapy. He is a gold medalist and was topper in MD and DM exams, and he has bagged many awards. He has been invited as a faculty in national and international conferences. He has presented and published his articles and thoughts in national and international conferences.
He's also demonstrated complex cases as live cases, and he is the DNB cardiology coordinator, teacher, and examiner, and has conducted final cardiology exam for students in all over India. His approach towards any complex cardiac issues is to solve scientifically, evidence-based, ethically, and with a heartening approach. Now I welcome Dr. Rahul Gupta sir and to deliver his valuable lecture.
Thank you very much, and good afternoon, everyone. I like the way the organizers organized, very entertaining way of conducting. So, I think just take a few deep breaths. It's very important because there have been lectures for 1 hour, and you know the focus starts going down. So, take some deep breaths with me. It's very important because you want to refresh your brain, be stress-free. That's very important, and we can manage. We all know that incidence of heart disease has increased in our country. We are seeing young patients, and I think heart disease management, as we were discussing, Dr. Panikar has also discussed about diabetes management. We are world capital. All the risk factors, we are world capital, and therefore the incidence of heart disease has also increased. And therefore it's always an approach which is scheme-based, where we do the intervention, but the patient, when they are following up with you, we should know how do we manage their therapies. So today our focus would be on antiplatelet therapy, which regime is best, and what can reduce the incidence of heart disease in our patient, chances of recurrences. That's what we are going to look at. I will try to finish it faster so that we can interact, because there are a lot of queries and there are a lot of discussions which have happened around antiplatelets. So what is the general thought? What do you think? Antiplatelets, dual antiplatelets should be continued for how long?
1 year.
1 year. 6 months, 1 year.
1 year.
Yes. 1 year.
It also depends on the case.
Yes, that's the right answer. So when we say medical science, when we say medicine, it is, I think, both art and science. So there are a lot of evidences. You hear my lecture, there would be some other lecture which will be discussing about other approach. So we have to pick and choose, and we have to see which patient to apply with. So I will try to be as practical as possible. Let's take this case. 53-year-old male. He has history of hypertension, type 2 diabetic, dyslipidemia, STEMI involving multivessel disease a year back, for which he had undergone a complex PCI. So these days complex PCI has become very common. It's not very easy for a patient to be referred for a bypass surgery because of the technology which is available to treat very complex cases with ease and precision. Now this patient was discharged, medications, and he was been on ticagrelor 90 mg BID, aspirin 75 mg OD, and he was on rosuvastatin 20 mg OD, and then he had other medications for his diabetes and all. So he comes to you, he has been regularly following up with you, and now it's 12 months. And as we had a discussion, somebody said 6 months, somebody said 1 year. What do we do with the antiplatelet regime of this patient? Because you will hear all sorts of evidences and data. Leave it at 6 months, continue for 1 year, continue for 5 years, continue for as long as the patient can tolerate, even lifelong. Switch to this therapy, that therapy, switch to rivaroxaban. So there are various approaches which are there. Now if you analyze this case, he is a complex case. It's not a routine simple angioplasty. So he had an MI. He had a complex PCI because it was multi-vessel disease. Other risk factors like type 2 diabetes is also present, and he has tolerated ticagrelor 90 mg for a year. So this patient, the idea of discussing this thought process after 1 year is the patient remain at high ischemic risk even beyond 1 year mark, especially some selected patients, which we are going to discuss. So who are these patients and what will be the approach in these kind of patients? So if you look at this complex PCI patients, this data, they remain at higher ischemic risk even after years of PCI. So if you look at a simple angioplasty, a simple coronary artery disease patients, these patients, the complex patient, they would have a 72% higher chances of major adverse cardiovascular events, which is MACE, 3 times more chances of high stent thrombosis, and 2 times higher chances of repeat myocardial infarction in these patients. And in India, believe me, we all are seeing these kind of scenarios where patients are actually multivessel, complex, diffuse disease. Diabetes produces a very diffuse kind of nature, and these patients will require a different kind of approach as compared to what the Westerners they face. So in India, we are facing, I think all of us, you must have come across these younger patients with diffuse disease or a diabetic patient with a diffuse disease. Majority of our patients these days are diabetic. At least they have pre-diabetes or some kind of metabolic ailment which are there. And diffuseness is, we rarely see a very simple angioplasty. It is always a complex these days, most of the time. So everything is higher in this substrate. Even if we look at this REACH registry, which discusses that patients with history of ischemic events are twice the risk of MACE for up to 48 months. That means about 4 years. So this is just the description about that how they are at higher incidences of repeat MI. Now we have 3 approaches after 1 year. We can keep them only on aspirin. This is one of the approaches, or we can put them on aspirin and ticagrelor 60 mg BID, which is from the Pegasus trial. There can be another approach where it can be aspirin plus clopidogrel, and third approach which was discussed, the noise level has gone down a little bit, but it was aspirin with rivaroxaban, which is which we say it's a NOAC, in 2.5 mg BID dose, which is a vascular dose. For atrial fibrillation, we use 20 mg. For DVT prophylaxis, we use 10 mg post hip replacement and post TKR and all. The orthopedician friend can tell us, they use it quite commonly. But for a vascular dose, rivaroxaban dose is 2.5 mg BID. So we have 3 approaches which can be continued in a complex patient. In a simple patient, I think some of you answered 1 year is good enough. But for a complex patient, we have to give them more protection to prevent recurrent events in these patients. So we have to think out of the box, we have to think what the science says and then pick up the best. Somebody also discussed about 6 months. So those who are at extremely high bleeding risk, even you can stop dual antiplatelet at 1 month, provided you have used the higher generation of stent. Particular stents have got some approval where you can stop it, and we will discuss it if the time permits. But let's look at this patient, the approach. So let's compare who will win based on the scientific data. In a treatment option post-MI, 1 year MI, he's coming to you and now he says, Doc, what should I do? I've been taking Brilinta for 90 mg BID. Will you stop it completely? Will you reduce the dose, or you are going to change it to something else? So we are now going to compare these 2 options. Now, comparison of P2Y12 inhibitor pharmacology and frequency of CYPC. So clopidogrel, basically this is a busy slide. You don't need to concentrate everything on this. Just understand that clopidogrel is a prodrug. It will need conversion into a active metabolite through a enzyme which is CYP dependent oxidation. And this CYP dependent oxidation will vary. There is genetic variation. So there can be it is a C2PY gene is highly polymorphic, leading to gene variation that can cause either loss of function or gain of function. So there is a huge variability which exists, and therefore previously when the patients were there only on the clopidogrel, we saw higher chances of stent thrombosis and all. And when these higher powerful medications came, prasugrel and the ticagrelor, the chances of stent thrombosis have reduced to a great extent, because if we compare with ticagrelor, it does not require any metabolic activation and it can become an active drug immediately. The chances of any kind of variation is very minimal. So we know that the platelet inhibition will be appropriate in all the patients who are given on ticagrelor. While in clopidogrel, there can be this much variation. So if you look at the worldwide data between the poor and non-responder, there are patients, significantly high number of patients in the Indian population which will be having either a poor response to clopidogrel or a non-responder. So sometimes these patients, basically if they are non-responder, and if you have not checked that they are non-responder or poor responder, they are basically protected only by the aspirin molecule which is being given. So this is the data which is available. Now, how do we, initially when we were doing complex angioplasties and when the Brilinta or ticagrelor was not available, we used to do gene testing to find out whether they have some loss of function and gain of function, so that we can appropriately switch over to another strategy in these patients. But then it is not easily available test that we can do it very often in all these patients, and therefore we were always on a lookout for a molecule which is much better, and then here it was. So even the US FDA, if you look at the clopidogrel molecule, they have discussed that effectiveness of clopidogrel depends on conversion to an active metabolite by cytochrome P450. Tests are available to identify patients who are poor responders and consider use of another platelet P2Y12 inhibitor, patients identified as poor metabolizer of CYP gene. But this is not very commonly available test that we do a test and then we will be able to get it. Not every lab will have it, not every locality it's easily available. So we were basically depending on the nature and we did not know. Now there are various trials which have shown, we always look at mortality benefit. We want to prevent recurrent MI, we also want to have mortality benefit. So there were various trials with clopidogrel which actually did not show a significant reduction in the CV mortality. And there are various trials, CAPRI, Charisma and PCI Clarity. Although this is of not practical importance, I'm just putting up the science that which one would be a winner if we have to choose a combination. Even if you look at what was as a prescription information in 2010, the US FDA has removed the mortality benefit of clopidogrel to only saying that for patients with ST elevation has shown to reduce the rate of MI and stroke. They have gone down from reducing the rate of death because it was found that it doesn't reduce the mortality. On the other hand, if you look at the ticagrelor, there is the patient might drive a significant mortality benefit with Brilinta 60 milligram. So there would be patients whose CV death reduction will be 32% in patients who are less than 2 years from MI, more than 2 risk factors, 34% relative risk reductions. And in our patients, in our clinical scenario, you see diabetes, hypertension, dyslipidemia very commonly in our clinical patients. So already they have multiple risk factors and they may be addicted like smoking or tobacco chewing. So they add on to the multiple risk factors. Then there are multivessel disease which we commonly find. Here also in this group you will find 36% relative risk reduction and diabetes per se if their patient is having. And if you choose based on the Pegasus trial you choose ticagrelor, then they would have 26% relative risk reduction in these patients. So the Brilinta has demonstrated significant mortality benefits in all these various trials, Plateau, Twilight, Eco and Sweetheart trial. So I think the clear winner is aspirin combined with, so when they come with 90 milligram BID in a complex scenario, had STEMI, has diabetes, I think we should not stop the antiplatelet if they don't have a bleeding risk. I will go into that algorithm where you can decide. So aspirin 75 plus ticagrelor 60 milligram BID would be a winner in this scenario so that we can give the different benefits which we discussed in our patients. Now let's compare with the COMPASS trial data. Post-MI, whether we should continue with the Pegasus which says aspirin plus Brilinta 60 milligram BID versus COMPASS trial which says aspirin plus rivaroxaban 2.5 milligram BID. So these are the two doses. You must have heard about the COMPASS trial. It came in and there would be a different subset of patients which will benefit. So now let us look at this patient again, revisit. So he's on all these medication. It's a complex PCI, STEMI, just 1 year is over, type 2 diabetic and dyslipidemic. And he has tolerated Brilinta very well. So should we continue with Brilinta 60 milligram BID or switch to rivaroxaban 2.5 milligram BID? Now this is a trial with in the COMPASS trial. What they did is those patients who were on dual antiplatelets were excluded, or if they were included, they had to go on a area where there was a 30-gap discontinuation of P2Y12 inhibitor. So clopidogrel was stopped or the molecule, any P2Y12 inhibitor was stopped before putting the on rivaroxaban. And the issue was with this thought process, with this change, that switching to a newer molecule, which is again an antithrombotic, may create a new bleeding risk in patients who already have tolerated very well the P2Y12 inhibitor. And the highest bleeding risk associated with rivaroxaban has been shown to be in the first year after initiating treatment, as demonstrated in landmark analysis of patients with CAD. So there is also no data available on switching from rivaroxaban back to P2Y12 inhibitor should the patient have an indication for DAPT like an acute MI or a PCI. So now we are discussing the second approach, whether we should continue with Brilinta 60 milligram BID with ecosprin in a complex scenario versus we switch them to rivaroxaban based on the COMPASS trial. But based on this data, this is a different group of patients. Probably this doesn't fit our patients. And the greatest benefit with ticagrelor 60 milligram BID is seen following minimal or no interruption of the ticagrelor molecule inhibitor treatment. So if we can switch over and we can decrease the dose without keeping a gap, they get the maximum benefit. So if you keep the gap less than 30 days, maximum benefit 30 days to 1 year, lesser benefit but still benefit more than 1 year, then it doesn't. So we should not create any kind of discontinuation and continue to give 60 milligram BID for another 3 years based on this Pegasus trial to give the maximum benefit to our patients, because they have higher incidence for up to 48 months after an event. So this is all the science, and in the Pegasus trial, which is on the Brilinta, median time from MI was 1.7 years, while the COMPASS trial, which contained group of mixed PAD-CAD population, only 62%, less than 2/3 of patients had prior MI. So they were not the kind of population which we are discussing right now, kind of patient which we are seeing right now that were included in the COMPASS trial, and mean time from MI was 7.1 years. So the concerned patient is only 12 months from MI and hence more closely resembles the Pegasus population. So I think the answer again would be, winner would be a combination of aspirin with ticagrelor 60 milligram BID for our patients in this particular scenario. So we will discuss which are the patients which will also benefit from COMPASS trial. So we will also discuss a little bit about it. The Pegasus trial enrolled patient within 1 to 3 years of prior MI, where the COMPASS trial did not specifically enroll patient with a recent or prior MI. It was anybody less than 20 years of MI. They included in that. And therefore, if you look at the COMPASS trial, the mean years were 7.1 years where they included, while in Pegasus within 2 years, and Plateau was the ACS population, so it was actually at the index event. Now Pegasus and COMPASS both demonstrate ischemic benefit. So both these, if you look the lecture from the COMPASS trial, if we are giving, it will also show the benefit, ischemic benefit. But does it suit our patient? This is today's topic of discussion, whether this patient will fit into a COMPASS trial or whether it will fit into a Pegasus trial. So the result of these studies, all these have shown, this is the data of reducing the ischemic event. The results of these studies should not be directly compared because of the different risk profiles of population enrolled. Instead, the right patient profile must be understood. So we will look into the right patient profile because that is the most important thing. Now, patient closest to their MI may derive greater benefit. We all saw that if you begin as early as possible, reduce the dose after 1 year, they are the one which will have 32% relative risk reduction in CV death. And but they have helped in all the groups, whether less than 2 years, more than 2 years, CV death, TIMI major bleeding, and switching from ticagrelor 90 to ticagrelor 60 at 1 year juncture can be the most beneficial, is what we can infer. Now we had this discussion. This is the most important step, that how do we select which patient will be suited for this kind of approach, and using an algorithm to select patient with low bleeding risk and more than 2 ischemic risk factors. Belinda 60 mg BID showed a 20% relative risk reduction and 34% relative risk reduction in CV death versus placebo over 3 years. So anybody who is having anemia or prior hospitalization or bleeding, anemia for this bleeding, then we should exclude them for continuing, because we have to always weigh between the bleeding risk and the ischemic risk. There can be an instance where the patient is having complex PCI but he is also at high risk of bleeding. Then probably we will exclude these patients. But if the patient has got low risk of bleeding, is a young patient relatively, and this patient has got, if you look at the data also, most of the 19% are high bleeding risk, while majority of the patient are low bleeding risk. And then you assess the number of ischemic risk factor, whether this patient was on recent MI, whether there was multi-vessel blockages, whether there was diabetes, peripheral arterial disease, CKD, multiple prior MI. These are the patients who would qualify for this thing. And if we look among this population, 81% population also, more than 2 risk factors are approximately in 60% of the patients. So majority of the patient are low bleeding risk. Out of these low bleeding risk, majority are at high risk. So again, majority of the patient, if you apply this rule, it's not very difficult. Patient diabetic, multi-vessel disease, CKD, multiple risk factors, and low bleeding risk, you can directly go for ticagrelor 60 mg BID 3 years post MI, and this will help in reducing the mortality as well as the risk of all-cause death, MI, and stroke significantly. So these are all the data. I think I have just put my point that how it is helpful even in peripheral arterial disease patients, in coronary heart disease death also there is a significant reduction, and 26 it showed with prior MI ticagrelor 60 mg BID. So coronary heart disease death, CV death, CVD, MI, stroke, myocardial infarction, and stroke is all better. So considering all the evidences, I think the right choice for the patient is I think Belinda 60 mg BID with ecosprin 75 for next 3 years. It is essential to fully understand the patient population enrolled and consider the different ischemic risk of these individuals. Having tolerated Belinda 90 mg for the first 12 months, treatment following an MI, he's 53, so not very high bleeding risk, not very elderly, where you can cut down on the dual antiplatelets. I think continuing for 3 years is an appropriate treatment option for long-term management of high thrombotic risk. So I think this will win for sure. The Pegasus will win in this scenario. But there is a role of COMPASS. If somebody is having a polyvascular disease, chronic coronary syndrome, multi beds which are involved, there you can consider rivaroxaban 2.5 mg BID for sure. But in this patient population, post 1 year, if they have come for follow-up, I think without any doubt, the science is to continue with the ticagrelor in our lower dose 60 mg BID for the next 3 years. And this is just to understand the enrolled population and choose as per the population. The Pegasus and Compass trial both demonstrate the potential benefit of antithrombotic therapy for prevention of ischemic events. However, the results of these studies should not be compared directly, and the study enrolled patients with different ischemic and bleeding risk factors. And I would say Pegasus enrolled recent MI patients, whereas Compass enrolled a mix of peripheral artery disease plus CAD patients with relatively chronic nature. And the greatest benefit of Brilinta 60 mg has been seen in patients continuing or having minimal interruption of DAPT less than 30 days from previous P2Y12 inhibitor use. So I think I've been just putting these points that maybe this patient will benefit the best by continuing of the dual antiplatelet therapy for another 3 years. Thank you very much.
Thank you so much, sir. Everyone will be agree with me that your lecture was as smart as you. सर ये सुपर से भी ऊपर था, सर ये सुपर से भी ऊपर था, इसीलिए कहूँगा forget the rest and believe me, Mdmpa is the best. Now I request our chairpersons to felicitate our respected speaker, Dr Rahul Gupta, sir. Now I request Rajesh Khanna of Mdmpa, Dr Ramesh Jain sir and Dr Kunal Jain sir to felicitate our chairpersons.
Very good. Thank you. We enjoyed it. Good one.
Now I request Senior and Past President of Mdmpa, Dr Ramesh Jain, and our charming helping hand, Dr Deepak to chair the session.
Now I request an authority in the field of diabetes, Dr Rajiv Kovil sir, whose subject is NAFLD and MAFLD, the harbinger of diabetes. Sir, please come on the dais.
क्या हुआ कैसे हुआ कब हुआ सब क्या सुनाए क्या हुआ कैसे हुआ कब हुआ क्यों हुआ जब हुआ तब हुआ वो छोड़ो ये न सोचो
ना सोच तो इतना नॉन अल्कोहलिक हो या हो मेटाबॉलिक लिवर डिसीज
बन जाए ना तेरे लिए हरबिंजर और लिखनी पड़े तुझे लास्ट विल. बिफोर दैट यू शुड कंसल्ट डॉक्टर राजीव कोविल. नाउ आई रिक्वेस्ट अवर रिस्पेक्टेड चेयरपर्सन डॉक्टर रमेश सर एंड डॉक्टर दीपा टू इंट्रोड्यूस अवर स्पीकर डॉक्टर राजीव कोविल सर.
Namaste everyone. Dr Rajiv Kovil is a gold medalist from Mumbai University in diabetology, medical director and consultant diabetologist at Kovil's Diabetes Care Center, consultant diabetologist at Nanavati Super Speciality Hospital, SN Raheja Hospital, KLS Hospital, Arogya Nidhi, BSCS Hospital. Speaker for many international and national forum. Founder member and secretary United Diabetes Forum. Vice President of Indian Podiatric Association, Secretary of RSSDI Maharashtra. Thank you.
Thank you so much, Chairperson. Thank you, Mahim Dharavi Association.
Welcome.
And my friend Sunil Kamble for bringing me here. So you had two cowboys, Abhijit and Rahul, speak about, and I'm going to talk to you about a love story. I'm going to make you all think a little bit. And then Deepak is going to make your climax at the end. So today I'm going to put some thoughts into you. It's not somewhere I'm going to teach you or something. We've been talking about diabetes, obesity. Sir is our mentor, guru. He must have told you about how diabetes is increasing. We have almost 101 million diabetics, 136 million pre-diabetics, 22 to 23% of our population has diabetes, 38 to 40% of our population has obesity. We have 355 million people with obesity. We have 40% with hypertension. So where do we have the healthy people? We don't have the healthy people. So our population of obesity is higher than the overall population of US. So we have a huge risk, or probably we have a population where there are a lot of loading of risk factors, and you need only somebody to pull the trigger and the bomb phat jata hai. So I'm going to talk to you about NAFLD. We can call it various other names, but it's important to realize that what are we treating here. So 2 years back there was an article called as the caramel disease. So what was caramel disease is today we are talking about hyperglycemia causing kidney disease, or hyperglycemia driving heart disease. So caramel disease gave a different perspective. Caramel disease is nothing. Caramel disease is cardiovascular, renal, metabolic and liver dysfunction. But what it said is that the cause and effect that we are looking at, that high blood pressure causes heart disease, hyperglycemia causes kidney disease, probably these things that we see, that the lab factor, the blood pressure we see, are probably the effects of an underlying problem. So the high sugar is not the cause, is an effect of an underlying, probably a liver problem. So it made me think that, like how we have reverse causation, people crossing the street will have a motor accident with either a Maruti or another car. So this is reverse causation. So that's what makes us think that what is NAFLD? NAFLD is a part of a multi-systemic disorder, and my topic is it a harbinger? Is it something which comes earlier? Because all of you all will have reports which suggest sonography suggesting of fatty liver, and you say कि थोड़ा खाना कम करो, थोड़ा तेल कम करो, थोड़ा मोटापा कम करो, walk करो, liver ठीक हो जाएगा. This is usual that we talk in our clinic. But are we looking at whether the liver is actually a victim, or actually it is the effect, or it is the cause which is making other organs dysfunction? So it's a part of a bigger sinister plan. How we have sleeper cells in terrorist organization, one is in Bombay, one is in Hyderabad, one is in Jobanputra, and sometimes they all ignite together and you have things happening. Like, today's 26/11, 15 years later, we are looking at 26/11, and 15 years back we were trading. So what is now, the nomenclature has changed. NAFLD is now called as MASLD. And it's a lot of panelists from a lot of countries actually sat down. And if you have a gastroenterologist in the population, the Indian Gastroenterology Association has still not accepted that MASLD. They are still debating whether it is to be called. But majority of the world, NAFLD has converted into MASLD. And what is MASLD is metabolic dysfunction associated steatotic liver disease. But because when we were talking about NAFLD, we were trying to talk about any person who doesn't have alcohol and has a fatty liver has got NAFLD. That is not so. And so steatotic liver disease, where you have accumulation of more than 5% fat in the liver, is steatotic liver disease. And it can be classified like this, where you can have cryptogenic, you could have a specific cause, you could have pure alcohol, you could have a mixture, and you could have metabolic dysfunction also. Now how would you classify MASLD? You have steatotic liver disease, which is either by imaging or LFT, and then you see that whether the patient has any cardiometabolic risk factors. Now the patient has cardiometabolic risk factors, which I'll come to the next slide, then you probably consider that all that he has in the liver is related to other problems in his body, and all these will together form a time bomb in future. So how do we define MASLD? That you have on any kind of imaging or histology, we hardly do. You have fatty liver, and you have any presence of one of the 5 cardiovascular or metabolic risk factors. And these are the risk factors which actually drive kidney disease, heart disease, amputation, everything across the globe, even cancer across the globe. That is why it's called as metabolic dysfunction associated steatotic liver disease. So if you have one of these 5 cardiovascular risk factor and a liver imaging more than 5%, then you can say that the patient is having MASLD. Now, why do we have to treat MASLD? MASLD can go from a benign condition where there are a lot of subphenotypes of MASLD also. You can have a benign condition and it can go on for the rest of your life. But it can become a malign condition and you can have steatosis going into steatohepatitis, which is called MASH, and progressing into NASH cirrhosis, and the chances of hepatocellular carcinoma goes very high when you get into NASH cirrhosis. So again, Panikar sir will say, always say insulin resistance comes first, NAFLD comes first, but we still don't know. You know, the jury is never out which is where the chicken or the egg. You know, the story is that we all have insulin resistance. All of us today have insulin resistance. All of us will have a high carb diet. Where does it get deposited is the problem. The deposition is decided by multiple factors. The way you exercise and also hereditary. So there are some people who have deposition in ectopic organs. One of the ectopic organ is the liver. The most common place where fat needs to be deposited is the subacute tissue. But unfortunately, all of us, as sir keeps saying, that he has to do many things to keep his tummy there. So similarly, it is not, you may have a lean person, but he will be a fat person because his abdominal circumference will be high. So high adipose tissue in ectopic regions undergoes lipolysis. These fatty acids come into the liver. They again form fat and come out. That is called as the Randall cycle in diabetes. So this will progress, and this cycle will keep on going, and you will see fatty liver. Now, and again, we don't know whether insulin resistance came first or fatty liver came first, we don't know. But it's important to consider in the last few years, there have been a lot of research done in that why does a person from normal glucose tolerance go into pre-diabetes, and why does that person from pre-diabetes go on to diabetes? And this is a prospective study done for more than 30-40 years. And one of the schools of thought is that liver is the kingpin in this metabolic blunder. It's not about the pancreas. Everybody says that pancreas is the problem, but the liver is the one of the hypotheses in school is that liver produces a lot of hepatokines, and one of these hepatokines is called fettuin A. If you all have heard of fettuin A, and fettuin A is, I can say, is like an agent. You know, it's like a bad agent. You know, like an ISI agent. So that agent goes and threatens other organs of our body. So fettuin A, what it actually does is that it causes a low-grade inflammation in the body. So the body doesn't recognize the adipocytes, sorry, the fatty acid sequencing in our hepatocytes. That is why there's a chronic amount of inflammation which occurs. That is why you have sometimes a pure NAFLD, which is steatosis, and some which progresses to steatohepatitis. And that fettuin A goes on and causes also the pancreatic hypersecretion of the insulin which occurs. It goes down. So there have been studies to suggest that just 7 grams of fat in our pancreas is enough for our pancreas to stop functioning. So basically it is the deposition of fat. When there is deposition of fat in the liver, it causes an inflammation. The agent is fettuin A. Fettuin A also causes deposition fat in the liver and in the pancreas. The pancreatic fat also is very close to the perivascular fat, and that causes an inflammation in the pancreas, and the excess compensatory hypersecretion of insulin, which actually compensates for the insulin resistance, goes down, and slowly over a period of time you develop diabetes. So probably hyperglycemia we see today is actually an effect of poor liver, and this probably in my lifetime we will not call it type 2 diabetes, we may call it as a different word altogether. So triglycerides, as we know that these fatty acids, Mdmpa comes into the liver, Randall cycles, makes triglycerides and it comes out. And triglyceride and HDL is a huge surrogate marker for NAFLD as such. And NAFLD, why do we have to treat? Globally 25%, in India 40%, and if you have a metabolic condition 58%, in people with diabetes is anywhere between 55 to 80%. Across, I don't know why East India is lesser, but South India has the maximum NAFLD. And if you look at it, obesity is the main, where almost 90% of obesity people would have fatty liver. That means this is a bigger epidemic than diabetes. Today, if you put together diabetes and pre-diabetes, you have around 230 to 240 million people. Diabetes and pre-diabetes. But if you put together diabetes and obesity, it is almost close to 800 million. So you are looking at a huge population of people with NAFLD, and that needs to be treated because all these people will either progress towards diabetes or chronic kidney disease or heart disease or other complications of metabolic disorders as such. And what we see is that the fibrosis rate is much higher in people with diabetes as compared to with people without diabetes. If you look at the progression in the US, NAFLD without diabetes to NASH is around 10 to 20%, out of which 10 to 15% progresses to cirrhosis, 3% progresses to a carcinoma, 13% have mortality, and very few go on to a liver transplant. But in the lower part, if you see, if you have diabetes, the progression is very, very fast. So you have 40% progressing to NASH, and you have almost 25% progression to cirrhosis and 5% progressing to hepatocellular carcinoma. So if you have diabetes, it becomes a driver of NAFLD and worse prognosis as such, and is always associated with other major adverse cardiovascular events. Again, challenge is how do we diagnose patients? Screening is most important. So whether you are a diabetic, whether you are obese, whether you have cardiovascular disease, I think asymptomatic, most of our patients, you need, and the European Congress or the American Association for Study of Liver Disease suggests that if you have diabetes or pre-diabetes with elevated liver enzymes, suspect NAFLD and NASH and determine patient's risk of advanced fibrosis. Again, you can just diagnose by just an ultrasound, liver enzymes, FIB4, and I'll come to the transient elastography as well. So again, just having normal enzymes does not exclude NASH or NAFLD. That's extremely important. That you may, and you know that when patient progress towards cirrhosis, his enzyme levels are very, very low. So liver enzyme may be normal in 80% of a patient with MASLD or NAFLD, and it's not very sensitive. Poor correlation between ALT, that's SGPT, and histology. And again, histology severity similar in NAFLD with normal versus abnormal liver enzyme. So don't just look at liver enzyme. What you can do is very simple, do a FIB4 scoring. And FIB4 scoring, you have apps on you, and it's very, very easy. SGOT, SGPT, age and platelet count is all that you require. And you get a score and you have to match this score. If it is less than 1.3, then there is absence of advanced fibrosis, very, very sensitive. FIB4 is very similar to the FRAX score in osteoporosis, very sensitive. So if you have less than 1.3, just forget about it. If you are indeterminate, you may have to go in and do a fibroscan or a transient elastography. If you are advanced, then the chances of you having an advanced fibrosis to cirrhosis of liver is very, very high. So what do? We do something called as transient elastography, which is available, which is expensive, but with that you can actually stage. With transient elastography, it measures the liver stiffness over an estimated area, and it's as good as a liver biopsy. Failure to obtain readings is more likely in patients with a very high BMI. What you get is a scoring which is from F0 to F4. If you want to diagnose what is called steatohepatitis, you need something in the fibroscan elastography which is called CAP, which controlled attenuated parameter, and CAP score more than 250 suggests steatohepatitis. So if you get fibrosis score and if you are into F3, F4, then the hepatologist comes in. So this is an algorithm for diagnosis of NAFLD. that if your most simplest thing that you need to do is do the fifth score. So if you see, fifth score is you get an app. So if you have sonography, which most people with diabetes will have, to a fifth score, less than 1.3, let them have fun. Between more than 1.3, put them in this is the group. Then you repeat a transient elastography. If they are in higher amount of fibrosis, they will have to do many things to get them back. Otherwise, they will all progress into liver cirrhosis. So this is in simple. And what you need is weight loss. I'm not getting into treatment because that is a huge emerging segment. And a few drugs which are of very good significance here is obviously the TZDs, which is pioglitazone. You have SGLT2s, you have GLP-1. The triple GLP-1s has shown almost a 95% resolution of NAFLD in latest findings. But anything which makes you lose weight is going to make you lose weight from your liver as well. So in short, if you have a fatty liver, do a fifth score. If you have a higher fifth score, put them through an elastography, and then you can go ahead and refer to a hepatologist. So that's in short that I wanted to say, that do not leave NAFLD around, because NAFLD is a huge pandemic, and what you will see in the next few years, multiple drugs will come for NAFLD, and we may have to treat NAFLD much before diabetes. Thank you all for appreciating.
Thank you, sir. Very extensively you have taken up this subject, and this is a very new subject actually, sir. But thank you for the information. Thank you, sir.
Thank you, Dr. Kovil, sir. Your lecture was superb and very innovative. And I know everyone wants to hear you more, but there is another lecture next. And believe me, Mdmpa is the best.
Now I request the silent worker of Mdmpa, Dr Khimji Gohil and Dr Rahul Parik to come on the stage to felicitate our chairpersons.
Thank you so much.
Now friends, I know you are waiting for the next lecture, and that will be the last lecture, and you just have to wait for 5 minutes more. Because now friends, there is a small appreciation program of the man behind the show, who really work hard for the minicon 2023. जिनसे हमने सिर्फ इतना ही सीखा है इस लास्ट 1 मंथ में, कि कौन कहता है कि आसमान में छेद नहीं होता, कौन कहता है कि आसमान में छेद नहीं होता, एक पत्थर तो तमन्ना से उछाल हो जाए. Now I welcome on the stage Dr. Sunil Kamble sir. Dr. Sunil Kamble needs no introduction, because as they say, thank you so much everyone, as they say, action speaks louder than the words. And sir, with his experience in clinical skills and sheer emotional attachment to Mdmpa, has time and again brought Mdmpa to long way with his pursuit of scientific and general medicine excellence.
I also now welcome on the stage the eminent diabetologist Dr. Vijay Panikar sir, who is also guru of Dr. Sunil Kamble, and also request Dr. Rajiv Kovil to come on the stage and felicitate Dr. Sunil Kamble. I also request our president, beloved president Dr. Sandeep Singh, and secretary man Dr. Janvi Khavle to come on the stage. And our handsome hunk as ever, Dr. Vinod Jain.
Yes.
Hello. Hello. It is indeed an honor to receive the trophy. Sunil मेरा ही बच्चा है.
Yes, sir.
He has worked with me and all my students are good. They are really good. In fact, we just finished the RSSDA National Conference, which I was chairing. They लोग ने सब, all my students from all over India managed all the halls perfectly, including Sunil. And when they get an award like this, चला मेरा छाती है ना 56 इंच का. वो एक्चुअली 58 इंच का है, but yeah. I would request Rajiv. Rajiv has been the organizing secretary for this conference which we just did, where we had over 5,000 attendees, and it was in fact the best RSSDA conference, and Sunil was also part of it.
I think when you have somebody like a father figure like Dr. Panikar and me, Sunil and everyone, we didn't work for RSSDA, we worked for him. You know? Our dedication is to him, and all the students, everyone from across India came together, and we put up a good show, and we had at least more than 5,000 delegates from, not only from India, from other parts of the world also. And it is one of the most memorable events, and all thanks to sir, we had celebrities and big performances and everything, and science was at the peak, and we all had a best camaraderie and one of the most memorable events which we are going to celebrate tonight. Thank you sir,
Thank you so much everyone.
Thank you.
Now I request our next chairperson, our beloved president, sorry sir, Dr. Sunil Kamble, he is having a surprise today. He just want to say 2 words.
I'm speechless. I'm not prepared any speech. It's a privilege to have a felicitation like this when your guru and guide and Dr. Panikar sir and my idol. Dr. Kovil sir and sorry, I can't control. But it's wonderful. On my single call, they accept my invitation, come and deliver the session. And its entire Mdmpa family as a team working sincerely for last 1.5 months. They may talk me as a Mr. Perfectionist, but other side they say Mr. Khadus also. Because I torture them a lot to make this event possible. I say, love you all, love Mdmpa, and thank you once again. Thank you.
We all love you too.
Thank you so much. Love you, sir.
We love you 2, 3, 4, 5, 6.
Yeah. We love you too, bhai.
Now I request our next chairperson, our beloved president, Dr. Sandeep Singh sir, and our new generation, young and dynamic Dr. Push Pashnekar to come on the stage to chair the next session.
Now I request our next speaker, Dr. Deepak Jumani sir, an expert in the field of sexology. Sir, kindly come on the stage, please.
Yes, if you want to be Sikandar, आपकी जवानी की कहानी को रोमानी करने के लिए आ रहे हैं डॉक्टर जुमानी एंड इट्स रिटन बाय डॉक्टर गोकाली। आपको आज थोड़ा 1 मिनट लेता हूँ सर के पहले कि मेरे एक पेशेंट से इंस्पायर होकर मैंने एक पोएम लिखी थी, पूरी पोएम बाद में कभी सुनाऊंगा, जस्ट फ्यू वर्ड्स ऑफ दैट एंड सेइंग सॉरी टू एवरी गुप्ता जी। एक दिन गुप्ता जी मेरे क्लिनिक में आए, देखकर मुझे से थोड़ा सा शर्माए, बोले डॉक्टर साहब एक बात पूछूं, बुरा तो नहीं मानोगे? मैंने कहा गुप्ता जी यहाँ सुनने के लिए बैठे हैं, सिर्फ जो भी सुनाएंगे वो सुनने के पैसे लगेंगे। गुप्ता जी बोले डॉक्टर साहब मेरी शर्म वाली जगह है नरम और जोरों की नरम वाली जगह है गरम।
मैंने कहा क्यों सोचते हो तुम इतना जानी, तुम्हारे लिए एक ही ऑप्शन है और वो है डॉक्टर दीपक जुमानी।
Good afternoon, everybody.
Now I request our chairpersons to introduce our respected speaker, Dr. Jumani.
Good afternoon, everybody. Minicon started with the heart. We covered slowly each and every part of the body. And if we don't have a lecture on one of the most important organ of our body, then the session is not, conference not successful. If there is no reaction and action after watching a sunny CD, then definitely you are suffering from ED. Depends कौन से सनी की सीडी देख के आपको गदर मचानी है. Obviously, I will watch Leonis CD, not Sunny Paji CD. Professor Dr Deepak Jumani sir is a senior sexual health physician and counselor, assistant professor of Sir J.J. Group of Hospital, fellow of American College of Sexology, fellow of Regenerative Clinical Medicine, certified clinical sexology at American Board, co-chairman IMS Initiative for Sexual Health, cybercrime intervention officer, and author of the bestseller Sex Has No Expiry Date. So please join our hands and welcome Professor Deepak Jumani sir.
Thank you very much for that sexy introduction.
Sir, I like your attire also. It's very sexy.
वक्त अच्छा जरूर आता है, men do get erections, पर कम वक्त पे नहीं आता. पल पल तरसते थे वो पल के लिए, वो पल भी आया तो कुछ पल के लिए. सोचा उस पल को रोक लूं और पल के लिए, पर वो पल न रुका एक और पल के लिए.
क्या बात है, क्या बात है.
Around the world, people love. They sing for love. They dance for love. They write poems. There are legions. There are monuments built. They kill for love. They die for love. In fact, we all sitting here are all victims of love. We are all born out of love and sex. The sad part is we don't talk about it. How long do we continue this taboo? We talk freely about piles, fissure, cancer, heart disease, etc. But when it comes to this, we tight-lipped. We don't talk about it. Oh, क्या सोचेगा मेरे बारे में, this, that. Anyway, in this next 30 minutes, I'm going to give you some nuggets of wisdom to enrich your understanding about the most common sexual problems in males, the erectile dysfunction. With pranams to God and thanks to my teacher, Dr. Lotika Purohit, Dr. Prakash Kothari and Sashrang Joshi, I beseech them to bless me always. I have no conflict of interest. Mitro, look at our Prime Minister, his hands are down. He was helpless. He offered us GST and lockdown. And that was good for us. Then he said, Deepak, look, my hands are up. I said, I shall also offer, I will offer unlockdown and my GST to all of you is great sex therapy. This talk is about erectile dysfunction, so may contain some naughty images. Please bear with me. At the beginning of marriage, every wife treats her husband as God, Pati Parmeshwar. Later on in marriage, I don't know, somehow the words change. Every wife is a mistress for her husband. Miss Pavanar and the stress for the rest 23. Is sex a secret? Who doesn't know what is sex? Even school children knows about it. We must understand it's not just secret, it is sacred. It has to be, it is an act of worship. We need to do it without fear, guilt and shame. Rishi Vatsayana and Kama Sutra clearly mentioned that sex is to be used, not abused. Sex wasn't God's mistake. Judging against it is humanity's biggest mistake. And pleasure is as divine as any cathedral, temple, mosque, church or a pilgrim. It's all about pleasure. It's the greatest passion and you're right. Of all the human urges, the urge to have sex is the strongest in every human being. And its sexuality is the right, it could be exercised at any age. Many do not discuss their needs due to the bias of judgment, but we need to express our sexuality and experience sexuality, and that's the natural part of aging and well-being. Aging, we all age. But does it mean that it is a metaphor of asexuality? No. American Heart Association and American Urologists Association clearly say that sex is the best prescription for good health and longevity as it improves every system of our body. And it is said, use it or lose it. Let me talk about erectile dysfunction. It is not new. It was known way back by Hippocrates in 460, 370 BC. He reported many cases of impotence. He presumed it to be because of excessive horse riding. Aristotle then later, he said there are 3 branches of nerves which carry spirit and energy in the penis, and it was something like a pump, it was influx of air. But it was Leonardo da Vinci, he noted large amounts of blood in the erect penis of hanged men. And he debunked Aristotle's history theory which was there for a long time. And it was Pear who discovered that there is definitely a blood supply. And what he writes, when the man becomes inflamed, he wasn't comfortable writing that he gets an erection. He said when a man becomes inflamed with lust and desire, blood rushes into the male member. It was you are not willing to write penis and causes it to become erect. Even Sushruta mentions about it. But what happens to us today as we age at 30 to 40, after 30, 40, we are, up till that time we are busy in the errands of life, making careers, making money and all that. So these are throbbing times, sometimes you are happy, sometimes you are sad, kabhi khushi, kabhi gum. And at the age of 40, you're scared, salah, kal ho na ho, I might get ill, I've got diabetes already. And he becomes naughty. So at the age of 50, Papu can't dance, salah, he's got diabetes, hypertension, obesity, and he's got erectile dysfunction. Then he comes to Dr. Jumani, and he treats, and then at the age of 60, he says, Buddha hoga tera baap. Friends, there is a sexual health tsunami across the globe. Every male and female today have some or the other bedroom woes. 40% of men have issues in the bedroom. 62% women have admitted that they are not happy with their sexual lives. In the high courts of Mumbai, we found 12,000 cases of divorces due to impotence. And it's a rising trend in India. Men with erectile dysfunction face higher risks. In fact, European male aging study also mentioned that. And 80% of men with erectile dysfunction are staying in silence. They don't talk about it. They have issues, their partners don't have issues. They're depriving their partners of the pleasures which she deserves. When I googled, I found Viagra had 196 million web pages and aspirin had only 53 million. So it's a huge problem to the individual and to the partner, and there is definitely a dent in the relationships. Let me give you a newer perspective. According to Masters and Johnson, the male sexual response begins with the desire, leads to arousal, erection, orgasm, ejaculation, and then there's a resolution. So there are 4 cardinal events which occur in a male during a sex act. It is the desire which comes first, leads to erection, penetration, and orgasms. Our first KEM data with Dr. Prakash Kothari and myself for last 10 years, 56,000 diabetic patients, all males had erectile dysfunction, early ejaculation, low desire, and females had low desire, and depression was the most common symptom we saw in all females. It's highly prevalent in India and China. We are losing to China almost equal. So I call it Chindia are the diabetes capital of the world. And the commonest complication of diabetes is erectile dysfunction. So Chindia are the erectile dysfunction capital of the world. How do you label one person as having erectile dysfunction? The symptom of not attaining and sustaining erection for a complete sexual act should be there for at least 6 months. And there has to be a clinically significant interpersonal distress amongst them. And he should not be on having any mental disorder or any drug or any other stressor or substance of abuse. The causes are psychogenic, vasculogenic, neurogenic, hormonogenic, drug-induced, and to add salt to our wounds, they have also discovered that it is even genetic now. They found a transcription TER1 SIM1 gene that is significantly associated with erectile dysfunction. So what actually happens when a man loses his erection, or what is normal physiology? What is normal erection physiology we all need to know? There is neurologically mediated increase in the penile arterial inflow. So it's neurologically initiated. Then there is relaxation of the corpora cavernosa smooth muscles, so the blood remains inside it. And there is restriction of the venous outflow, which leaves the penis in a rigid state. This is what. And anything going wrong into these 3 things due to any reason, man can get. So ultimately it is reduction in the blood flow. So I call it erectile dysfunction as penile attack or penile angina. And we see penile attack or angina in 4 types of patients. We see in diabetics, obese, hypertensive, and dyslipidemia. But at the age of 50, 60, why we should be worried about this erectile dysfunction? No, we must worried about it, because when we looked at patients having erectile dysfunction, having cardiovascular risk factors, or having clinically, they all had erectile dysfunction. So ED is the earliest marker of myocardial ischemia. Montessori beautifully explained this. The size of the penile artery is the smallest, 1 to 2 millimeter. Coronary arteries are little larger, 3 to 4 millimeters. Internal carotid still larger, 5 to 7. Femoral artery, 6 to 8. When atherosclerosis sets in, and if 50% of the artery which gets blocked will produce symptom of those arteries. If 50% of the penile artery gets blocked, these patients get erectile dysfunction. But this atherosclerosis is generalized. The same amount of atherosclerosis do not occlude 50% of the coronary artery or internal carotid artery or femoral artery, because they are larger in diameters. But sooner or later, we know atherosclerosis is progressive. This can even lead to 50% of blockages of coronary artery, and these patients can get stable, unstable angina or angina. So in fact, erectile dysfunction is the earliest marker of myocardial ischemia. So what do we learn from this? At the age of 30 in your patients, if you have patients who have a family history of diabetes, hypertension, obese or dyslipidemia, you need to ask him a history. In whatever your history you take, ask him one simple question, that do you have problems in making love? It's not vulgar. You will be surprised that he was waiting for you to initiate a dialogue on this aspect. And if you diagnose erectile dysfunction just by this question and work on it, you will retard the onset of critical events like myocardial infarction or stroke in his life. And that's what you should do. So in fact, it is erectile dysfunction is the silent subclinical cardiovascular disease. And the duration of precipitating coronary artery disease is around 3 to 5 years in most of these patients. So you have 3 to 5 years window period of curability where you can counsel him on lifestyle and reduce his sugars, cholesterol, everything, and retard the onset of most of the critical events in his life. So I call penile attack almost equates heart attack. Let me give you a deeper perspective of this. Friends, this is a schematic diagram of endothelium and the corpora cavernosa smooth muscle. A normal endothelium, which is the innermost lining of the blood vessels, the brain of the vascular system, produces endothelial nitric oxide synthetase and enzyme, which potentiates the nitric oxide, which is the chemical signaling molecule or the miracle molecule or the currency of our cell, which enters into the corpora cavernosa smooth muscle cell, converts guanosine triphosphate into cyclic GMP with the help of an enzyme called guanylyl cyclase. This cyclic GMP relaxes the smooth muscles of the corpora cavernosa and allows the blood to swing. But sadly, this cyclic GMP hydrolyzes into 5-GMP with the help of an enzyme phosphodiesterase 5 or PD5. So, what do we have today in our armamentarium? We have PDE5 blockers, inhibitors in the form of sildenafil, tadalafil, vardenafil, sildenafil, and now new kid in the block, avanafil. But what basically is the root cause is the endothelium. We are not curing the restoring the endothelium, we are just trying to give him PDE5 inhibitors, that's it. And when we look at diabetes, advanced glycated end products and oxidative stress ultimately lead to cavernosal endotheliitis or cavernosal endothelial dysfunction leading to erectile dysfunction. So every diabetic has erectile and endothelial dysfunction linked. You are as old as your endothelium. How do we manage? Whether the problem is in the male or the female, you need to see the couple together. Cannot be just by he coming and telling you, "Mujhe ED hai, ye hai." So no, he should call his partner and be together. We have two beautiful questionnaires, IIEF and SHIM, which are validated, which can give you the diagnosis of severity of the issue. Rule out the psychogenic part first, then the organic part. By asking him one simple question, in last 15 days or 1 month, did you have erections when you got up from sleep? If he says, yes, doctor, 3 days back I had, then this patient is normal. He does not have organic erectile dysfunction. He doesn't need PD5 inhibitors. All he needs is counseling and assurances. It can be situational or psychogenic. We investigate, like we check his blood pressure, advise him on smoking, diet, exercise, lipids to be controlled, HbA1c to be less than 7, eyes, feet and oral hygiene. Don't go by the recommendations. Americans, our recommendations are useless. Every time when your patient comes to you, look at his feet, look at his retina and look at his oral hygiene. That is a must. Put them on guardian drugs like aspirin, ACE inhibitors and statins, work them up for heart. We also give in our office 50 mg of sildenafil tablet to him and ask him to think erotic another half an hour or 1 hour. If he gets erection, he's got psychogenic or situational erection. We also give intracavernous papaverine in our clinics and make them lie down for 10-15 minutes. And if he gets erection, he does not have an organic ED. We do additional tests like testosterone-free total sex hormone binding globulin, thyroid, FSH, prolactin, sonography of the scrotum and Doppler studies, digital rectal examination and VG scan. How do we treat erectile dysfunction? We have 3 modalities of treatment. First is the oral drugs. We have pharmacotherapy. We have beautiful PD5 inhibitors. If they don't work, we give injections of papaverine and largectil in the intracavernous tissues. If that doesn't work, we give them vacuum therapy. We also give intraurethral prostaglandins. If all these fail, we send our patients to andrologists or urologists who put implants or anastomotic surgery. But the backbone treatment, the backbone of every patient having erectile dysfunction is counseling and lifestyle measures. If you don't do this, nothing works. So many patients take PD5 inhibitors from the chemist or even from diabetologists. They say, sir, kuch hua hi nahi. You need to understand, you need to counsel them on how to take the medicines, when to take the medicines, what is the dose to be taken. We have 4 PD5 inhibitors. They have various onset of action, duration of actions, and they all have side effects of headache, nasal congestion, visual disturbances, and the contraindications which all you want you to remember is nitrates. If they are on nitrates, please do not give them because it can be a fatal hypotension. It could be very bad. For diabetologists, one important thing is whatever may be the HbA1c, prostatic, hypertension, etc. Put them on low. If he is not taking nitrates, give them low dose PD5 inhibitors for 12 weeks. They will improve in their sexual functions. my friend Dr. Paresh Dandona. These diabetics not only have erectile dysfunction, also have hypogonadism. So if you just give PD5 inhibitor, it doesn't work. You need to check their testosterone free and total, get their PSA level. Then the PSA is normal, put them on testosterone low dose for at least 3 to 6 months. You will find fantastic results. My friend Dr. Jyoti Dev gave his patient, put his diabetic patients on insulin pump and found 83% improvement in their sexual functions. For diabetes, we know metformin is now improving the endothelial functions. SGLT2 also improves erectile dysfunction by its class properties itself. You lose weight, you control hyperglycemia, even dyslipidemia is controlled. So all the causes of vasculogenic causes of erectile dysfunctions are taken care by SGLT2 inhibitors and metformin. So you don't need to give them an additional PD5 inhibitor as a drug. Buried penicillin. Very common problem. You give them L-arginine gel, sesame seed oil, which has got a lot of beautiful androgenic properties, and 1 gram of metformin. In 6 weeks, our patients improve. Then give them PD5 inhibitor, they will be able to have sex. Friends, we've been treating erectile dysfunction for donkey's years, but none of these therapies reverse the pathophysiology of erections. So we need to think a little more. What do we have something better to give to our patients? Yes, now the new thing is stem cells. 15,000 umbilical cord stem cells were injected in 7 diabetic men who failed ED medical therapy and did not want to go for surgery. 6 out of 7 regained morning erections. We have tried platelet-rich plasmas in these patients and we found improvement in their erectile dysfunctions. Intracavernosus injections is now considered to be a promising therapy in the armamentarium of urologists. You're taking his own blood and giving it to him. You're not giving him any drug or any gadget to use or anything, he improves. But besides all these things, we have found erectile dysfunction is very friendly to diet and herbs. So we have a lot of beautiful herbs. We have ginseng, shilajit, ashwagandha, L-arginine, fenugreek, all modulate glucose and lipid metabolism in obesity and diabetes and produce very good. Fenugreek in a saponized form has got a chemical formula exactly like testosterone. What fenugreek does is it displaces the globulin bound testosterone and makes the free testosterone which is required for your desire available. You don't have to give him synthetic testosterone because of the fear of whatever, you may think he may get cancer or prostate or etc. So you can easily give them L-arginine in a sachet form and fenugreek in a saponine. So what's new today? We have got a beautiful drug now available to us in the form of Avanafil, 100 mg, 200 mg. The beauty of this drug is that the onset of action is 15 to 20 minutes. Have the least side effects from all the PD5 inhibitors. And the best part is its half-life is only 5 hours. So this is the only PD5 inhibitor which you can give it to your patients who are also on nitrates. All you got to do is skip the nitrates on the day when he wants to have sex and take PD5 inhibitor in the form of Avanafil. Have sex, take Avanafil, have sex, and next day again start your nitrates. So this is the only PD5 inhibitor which can be taken in patients who are on nitrates. We have sildenafil films and tadalafil films which you can put it on your tongue and the action begins so fast. In 10 minutes, we have sprays available. Eroxon, a new stim gel, 15 to 20 minutes, it just warms up your penis and there is dilatation. All erectile dysfunction patients have loss of melatonin. So you give 3 milligrams of melatonin or even melatonin sprays available. We have so many newer targets today. Amongst them, the extracorporeal low intensity shockwave therapy, PRP, gene therapy, nanotechnology, all have been tried. But we Indians lack robust evidence, so we cannot form clinical guidelines for the same. All have got very, very low evidences. My last part of my talk is, let's think far wide in this. Risk factor of every risk factor is endothelial. So we need to restore the endothelium. Do we have some pharmacological remedies for this? Yes, we have. ACE inhibitors, statins, insulins, L-arginine, etc. They all restore endothelial function and protect you from various diseases. My teacher, late Dr. R.D. Lele, published successful strategy for reversal of endothelial dysfunction. PPAR, alpha, gamma, agonist, which increase nitric oxide. So many things, it's all there. Last thing, let me give you a panoramic perspective. Dean Ornish, must have heard his name. He, with intensive lifestyle, reversed the coronary artery disease of more than 300 patients. It's published. Intensive lifestyle which include vegetarian diet, aerobic exercise, stress management, smoking cessation, and psychological support. This is studied for 5 years. We are fearing that something can be genetic. No, friends, please understand. 20% of what happens to you is because of genes, and 80% is dictated by your lifestyle. And most of the risk factors are all modifiable risk factors. You know, smoking, cigarette does not go on its own, alcohol doesn't go on its own. It's all voluntary. It's not involuntary what happens. Amongst all the things, we all lack in a healthy diet. That is bad. That is why there is increased risk of cardiovascular disease across the globe. It is the not having a healthy diet. So what is the diet which you would give to your patients who come to you for erectile dysfunctions? All red colored fruits, vegetables, all greens, beans, berries, avocados, flax seeds, chia seeds, pumpkin seeds, saffron, garlic, onion, ginger, 8 almonds, 2 walnuts, honey, dark chocolates, cow's ghee, cow's milk, vanilla, white of the boiled egg and fish. Don't send them to a dietitian. Oh, 8 baje ye lo, 9 baje wo lo, 10 baje. No one can adhere to any of the diets. Sarita Dowris, 20 of my patients went to it. None of them are happy. They say, oh, aisa likhe the hum 2 din bhi nahi kar sakte. So, give them a blanket thing that avoid salt, oil and sugar, SOS. Tell them, if you eat more salt, you'll get hypertension, sexual dysfunctions, medicines for lifetime, and it's a killer. O is oil. If you take more oil, you get dyslipidemia, sexual dysfunctions, medicines for lifetime, and it's a killer. Last S is sugar, diabetes, sexual dysfunctions, medicines for lifetime, and it's a killer. Just tell them to cut down on salt, oil, and sugar. That's it. And ask them to fast for 12 to 16 hours a day. I will explain to you why. Ask them to walk for 30 minutes a day. This should be counseled to every patient having metabolic syndrome. Why? Because Cleveland Clinic in their original research proved that nutritional intervention in their study not only halted but even reversed the coronary. Such a huge plaque completely opened up just with nutrition, no drugs. No drugs at all. So the doctor of the future will no longer treat human frame with drugs, but rather cure and prevent disease with nutrition. We are all going to live long. How do we want to spend our long life? Depressed, dependent, unhappy, starved. And there are 5 cities across the globe which are called blue zones where people are living more than 130 years. And they are active, physically active. All live above 100. Do you want India to become? Yes, we can. 3 concepts in my next 3 slides will definitely help you in living longer and being active. The first is, there are aging and cardiovascular, and there is expression of sirtuins. If you restrict calories, it will reduce your glucose and free fatty acids. It will also improve the mitochondrial function by reducing the ROS and TCA cycle. And there is expression of sirtuins. Sirtuins are genes, anti-aging genes which are very important. And that will give you live longer lifespan. The second concept is autophagy, means cleaning of your cells. Every cell has got a cleaning mechanism. All the garbage which is formed by the metabolism, etc., cell functions can be removed, and that can be initiated with fasting. So autophagy is initiated by 12 to 16 hours of fasting. And hormesis, you stress your body a little bit more. So you're taking a hot water bath, take a little more hot water until you bear it. And then after taking that hot water bath, after some time, take a chilled water bath. Do this practice. If you're doing an exercise, walk a little more brisker for 5 minutes and then walk. This is called hormesis. And this is a real indicator that you would definitely live long. Friends, intimacy is ageless. To ignite intimacy, you need to have strategies for mind and body for optimum sexual pleasures. We know couples hardly touch each other. Touch is so. My teacher once told me, "Doctor, tu kya bolta hai? How can I hug my wife in front of my children who are 20, 25? What will they think about me?" I said, "What will they think about you, sir? They will only think that you still love each other and don't you want the signal to go to them." He changed. He said, "You said something wise. Yes, we will do it." You see, children follow you, so you do that. Hugging. I find couples hardly hugging each other. What's wrong? After play, man ejaculates, turns himself on the other side and sleeps. Ho gaya, mera kaam ho gaya. Bullshit. Your foreplay was boreplay. Your erection was aisa taisa. You ejaculated early, and what you did? Nothing. What is after play? The concept is not known only. After try and make your husband jealous also. Nothing wrong. Do it. When will you do it? When? If you don't do it now, when? Please try and look as beautiful as possible. Nothing wrong in that. Keep sex sexy. That's important. And men, we are exposed to so much of erotic, but get charged. Nothing wrong. Bring in laughter. Bring in humor. It's a. We are all born out of a woman. She's the best. Feminism needs to be adored, admired, trusted, and respected. Respect feminism. I pray to God that he should get permanent, incurable erectile dysfunction. Be romantic, even should be. Additionally, wrinkles don't hurt. My last take-home messages are: sexual dysfunctions are not an option for anyone. It's how gracefully we handle the process and how lucky we are as the process handles us. We have 4 PD5 inhibitors. They do not increase the desire. And 40% of our patients are not responding to it. So we give testosterone, the Basha. But we can't give it to younger patients because of the fear of azoospermia. We can't give it to older patients because of the fear of heart failure and prostate issues. So who's the Raja of all? L-arginine, fenugreek, regenerative medicine and lifestyle modification. Bindas de do. They will bless you forever. And also activate serotonin autophagy hormesis by fasting for 16 to 18 hours a day. As Dr Panikar said, हम दिन में भी खाते हैं, lunch के पहले भी खाते हैं, dinner के पहले भी खाने को छोड़ो. Just leave your body, each cell to clean off on its own. There is a mechanism in place. So friends, we have so many things for our patients with erectile dysfunction to give in our armamentarium that this is a symptom which can be easily managed. Dr. Linus Pauling, when he received the second Nobel, now who gets 2 Nobel Prize? Such a brilliant man. When he received his second Nobel Prize, he announced that nearly all diseases can be traced to a nutritional deficiency. Take this home. Take this message home. It is the nutrition what is important. You will fall sick for 2 reasons. One, what you put in your body. Second, what you do with your body. That's it. And it's a shame for a man to grow old without seeing the beauty and strength of which body is made up of. Friends, today, it's really nice to know that erectile dysfunction, if you diagnose early, is a blessing in disguise. Reversal of metabolic syndrome, all of you can manage hypertension, also diabetes. Remission of diabetes is not a myth, it's a reality today. Okay. Activating serotonin's autophagy, hormesis, L-arginine, lifestyle modifications are all there. So if you do all these things, friends, erectile dysfunction is a correctile dysfunction. Your tragedy in the bedroom can turn into bliss.
Love. Golden, do you love me?
Do I what?
Do you love me?
Do I love you?
Well?
With our daughters getting married and there's trouble in the town, you're upset, you're worn out, go inside, go lie down. Maybe it's indigestion.
No, Golden, I'm asking you a question. Do you love me?
You're a fool.
I know. But do you love me?
Do I love you?
Well,
For 25 years I've washed your clothes, cooked your meals, cleaned your house, given you children, milked your cow. After 25 years, why talk about love right now?
Golden, the first time I met you was on our wedding day. I was scared.
I was shy.
I was nervous.
So was I.
But my father and my mother said we'd learn to love each other. And now I'm asking, Golden, do you love me?
I'm your wife.
I know. But do you love me?
Do I love him?
Well,
For 25 years I've lived with him, fought with him, starved with him. 25 years my bed is his. If that's not love, what is?
that you love me.
I suppose I do.
And I suppose I love you too. It doesn't change a thing, but even so, after 25 years, it's nice to love.
Friends, love has no expiry date, so sex also has no expiry date. My honest plea to all men here, try to be monogamous rather than being polygamous. Being monogamous is like a garden and being polygamous is like a jungle. If you want to make your garden beautiful, you need to devote time. In monogamous relationship, you need to devote time. Like in garden, you got to cut the grass, put water, fertilizers, etc. And it's a choice you have whether you want to be a gardener or a jungler. So Voltaire beautifully said, try and cultivate your own garden. Friends, if you have patients of erectile dysfunction, treat them, not difficult at all. Take a detailed history, work them out. If you can't treat, send them to a good sexologist, he will see that he gets a good help. So my last 4 pearls of wisdom. There is no law which says that you must age. Chronologically, yes, but biologically, no. Not at all. You should not biologically age more. Normal age is abnormal aging. Our body has a capacity to stop senescence. And a man can have sex from 9 years to 90 years. So sada sexy raho. At Bareilly, when we showed this talk to Adi ji, he said, Dil khush kar diya. This is my book, Sex Has No Expiry Date. My last slide, friends. Erectile dysfunction is a bigger pandemic than COVID. It's an endothelial dysfunction, earliest marker of coronary artery disease. These 4 PDE5 inhibitors are effective. Low-dose PDE5 inhibitors and statins are good for diabetics. If you envisage beyond PDE5 inhibitors, testosterone can be given with caution. L-arginine supplement and fenugreek is a boon. Activates serotonin autophagy in hormesis. Diabetes remission is a fact and not a myth. If you do so, friends, erectile dysfunction is a correctile dysfunction. So don't let your diabetics die in victim. If you do this, sex really has no expiry date. Thank you all for your love. I'll be happy to answer any questions you have.
Sir, thank you for your wonderful lecture. And I believe, sir, everyone who is in the auditorium.
Just wait for 2 minutes. Just wait for a minute.
Will be feeling young and energetic after hearing sir's expert views. Now I request chairpersons to felicitate our speaker, Dr. Deepak Jumani.
Just wait for a minute, friends. Just wait for a minute. I know everyone is hungry. Please wait for a minute. The last 2 lines only. Now I request our hardworking past president and always helping hand for us, Dr. C.A. Tavre sir and Dr. Bharti Desai, to come on the stage to felicitate our chairperson. Now I hand over the mic. Please, everyone, please just wait for a minute. I hand over the mic to Dr. Vinod Jain.
Lunch will be now served till the felicitation of the MOC. Please be waited for 2 minutes. Now it's time to say tons and tons of thanks to our full-on entertainment, my friends, dynamic, handsome Dr. MOC for today, Dr. Mdmpa sir and Dr. Vijay Panikar. To felicitate them, I would like to request our President Dr. Sandeep Singh, Secretary Dr. Janvi Khavle ma'am, Dr. Rajiv Kovil sir, and Dr. Nikesh Jain, please come on the dais and felicitate
आप
all
और मैं दोनों मिलके थैंक्स बोल देते हैं.
Bye and thanks.
नहीं अभी बोलिए.
Bye and thanks everybody for viewing our conference.
Subscribe to the channel and like to the video. Thank you. Bye bye. गोकरी सर चाहिए.
हो गया?
हाँ. Yes. Bye bye बोल दो.
And Thanksgiving by Dr. Jobanputra ma'am. Thank you Mdmpa.
जाना ज्योति इधर जाना
Dr. Jyoti, please come on the dais.
अनाउंस करता था ना
अभी कर रहे वो करेंगे ना.
Thank you each and everyone, every delegate out here. Without you all, this wouldn't have been possible, is what I would say. The whole strong team of Mdmpa who has tried and worked very hard to put this together. So thank you to each and every member as well, the organizing committee. Everyone out here, I'm really thankful. I would also thank, the console committee, the arrangements done out here, the pharmacy which has helped supported here, and of course the speakers, each and everyone, very much thank you. I think next time we should.
थोड़ा फोटो सेशन होने के बाद चलते हैं. अभी चूँकि लाइन तो लग गई, अभी आराम से चलते हैं. आप भी लोगों को बाय बाय बोल दीजिए. YouTube में सबको बाय बाय बोल दो. हाँ मैडम बोला ना, आपका जरूरी है. चलो.